AIS. So if you go through these pictures, to begin with, one bone rotates, then three other bones rotate with it, and then slowly a spike starts to form, as you can see there, and the head starts to go off. And to compensate for the balance, another part of the spine corrects. Because remember, spine is mobile, and hence from a single curve or from a single bone, you get a single curve to a double curve, and that's how the genesis happens. And hence, the whole idea in 2026 is to understand which part of this curve or this scoliosis is actually structural in inverted commas. Does anyone understand what structural? Can you tell me, brown shirt? Sorry, I don't know your name. What is a structural curve? Perfect, perfect, superb. So it's the part of the curve that originated this scoliosis. Okay, it's the part of the curve that is fixed. It's not going to relent, and you're going to have to work on it. Which also means that non-structural is something that will relent if you treat the structural. And then if you go back to your fundamentals, that you want to fix less amount of spine to get a balance. Why less amount of spine? To keep a functionally mobile spine. If you can identify which part is structural, correct and fix that, and leave the non-structural to correct itself, you've got your goal right. And hence, watering this down, life is now about identifying structural from non-structural when you start planning scoliosis. And that's where the whole, your whole thought process should spin. And you should not take into consideration or not take into your fusion parts of the curve. As you can see, the part that's within the red lines here is non-structural. And if you just fuse this child from C1 to S1, you'd get a ramrod straight spine, but you'd be a shit surgeon. While if you fix only the part that's above the red line, the remaining would correct itself, would remain mobile, would remain functional, the spine would get a balance, the child would be happy, you would be a good surgeon. Okay, I hope I'm making that point clear. So there are a number of definitions, and these get confusing. Major and minor curve is just an English language definition, which means the bigger curve is major, minor curve is smaller. Try not to use these definitions because this is not really a definition. It's just like saying, I think you're tall. Someone else says, no, I think you're short. It's a relative definition. But these are more colloquial terms used rather than definitions. A double major curve is when both curves or all three curves, triple major, look equally, equally big. So the bigger curve is major. But compensatory versus non-compensatory, you should understand. And what do you think would be non-compensatory? Or what do you think would be compensatory? What's a compensatory curve? Any of you? Yeah, correct. But like your definition is correct, that side bending curve straightens up. But in reality, is a non-structural curve. The non-structural curve is a compensatory curve, which means that that curve has been dragged into the deformity because a structural curve is trying to push the spine out of line. Got it? Which also, like you rightly said, means that on correction X-rays, it tends to straighten up. That's a compensatory curve. Again, it's an English language definition. What about the next definition? Okay, let's see what we have here. What's a fractional curve? These are again colloquial definitions used. The answer is right there. That if you see the image on the right, you see the lower curve, or what we call the thoracolumbar curve, makes a full C, which means it's at least a 180 degree of a circle, while the one on your left makes a 90 degree of a circle. So a curve that looks like it's only one part of a half circle becomes a fractional curve. And this becomes important because the fractional curve doesn't really have a lower end vertebra. Okay? Don't get too confused. These are all colloquial terms, and if you don't know the definition, it's okay. But this you need to know. What is a decompensated spine? What do you think is a decompensated spine? Red shirt with the specs.
And coronally not balance
Perfect. I'm liking the way you guys are answering because you know everything. All your answers are spot on. No one's getting it wrong. So a curve where the primary curve has not been compensated well by the secondary curve. Okay, means the compensatory curve is not able to do its job. So that's an uncompensated curve. And the specialty of an uncompensated curve, number one, it could be uncompensated in the coronal plane. It could be, like you said, uncompensated in the sagittal plane. And a compensated curve, uncompensated curve will have gravity pulling it away and making it worse. So it's like if I stood with my foot crooked, the more I walk, the more crooked my foot is going to get because gravity is pulling it away. So biology gets superseded by gravity in a uncompensated curve. Okay, I hope that's fine. Now, quickly, these definitions. Does someone want to tell me what's an end vertebra? The lady, end vertebra. Easy. Vertebra at the end of the scoliosis. But how can you know which is the end? Yeah.
Sorry. Vertebra at the end of the curve, which are the
Yeah.
most
So the vertebra, you're right. The vertebra on either end of the curve. So mark every word, either end, because there's an upper and a lower end. You can't say end. It has either end of the curve, which is maximally tilted and closest to the apex. All words are important. Maximally tilted is a simple way to understand because end defines tilt. But closest to the apex is important because there could be two vertebrae that are equally tilted. So the one that's closer to the apex. So if it's lower, if it's a lower two, the upper of the two will become the lower end vertebra. If the upper two, the lower of the two will become the end vertebra. Is that clear? So which means how many end vertebra can the spine have? Minimum and maximum.
Sir, minimum it can be 2 and maximum if there are 3 curves, if we define that, then it can have a 6.
गलत जवाब. आपको friend को consult करना है. Phone a friend. 2 is not right. Minimum can't be 2. So each spine has 3 curves, remember. So whenever you see a curve, remember now in 2026, it's never a single curve. There's 1, 2, and 3, which means you can, I've given you a hint.
End vertebra.
Yeah, so maximum would be 6. 2 for this, 2 for this, and 2 for this. And minimum could be 4. Why 4? Because the lower of the upper could be the upper of the lower. Okay, so it could be 1, 2, 3, 4. Or it could be 1, 2, 3, 4, 5, 6. Is that clear? And you must know this, then you'll start looking at it like that. So strategic vertebrae are the vertebrae that make the deformity, and it's like having a cricket team where you'll only look for the performers. And if these guys perform, you're going to be able to win the game. The others are fillers. Okay. Similarly, in a spinal column, the strategic vertebrae define the deformity. If you're able to get them out, you'll be able to win the game. Okay. So those are the strategic vertebrae. End vertebra is the most tilted on either end of the curve, closest to the apex of the curve. All right. Anyone can identify? Who wants to take a shot? Yes. Which are the end vertebrae here? Come. You'll come again. It's okay. Wrong is always good. Come. You want to see and point out, you can take a laser pointer. Or it's marked also. You can go there and point out. Anyone else wants to volunteer? You're welcome. This is a safe place to make mistakes. L1 is the lower end vertebra. Great. Why do you think L1 is the lower end vertebra? Yeah. Yeah. So I'm going to correct you there. Never involve a CSVL in determination of an end vertebra. End vertebra only alludes to the tilt. So your answer should be no. I think it's the most tilted vertebra at the lower end of the. You can't even say primary because definition-wise, primary means the one that was first developed, and you don't know which. So by convention, proximal thoracic, main thoracic, thoracolumbar. It's a good convention to follow. Okay, every spine. So this overtly to you looks like a single major curve. So you'll say this is a right-sided thoracolumbar curve. But in your head, as a scoliosis surgeon, you say there are 3 parts to this curve. The proximal curve looks convex on the left. The middle curve or the main thoracic looks convex on the right. So then you will start identifying all the 3 elements. So the correct answer would be the lower end vertebra of the main thoracic seems like L1 because it's the most tilted vertebra closest to the apex because these two could be equally tilted. So this would become the lower. Which do you think is the upper end vertebra? Like this one. Okay. Does anyone disagree? You think it's T8? If there's an argument, how do you solve it? Thank you. The perfect answers. If there's an argument, how do you solve this argument? Come. So first of all, if there's a discrepancy of 1, which means you say T7, you say T8, it's okay. Especially in the upper end vertebra. It's not a big sin. And you're the surgeon, you decide. If you're operating, you will call it T7, you're operating, call it T8. But if there's an argument that has to be made, then how would you normally decide? If I can't see what he's wearing, like what's that brand? I can't see the brand on your t-shirt. What will I do? I'll zoom in, right? zoom in to see which is more tilted. So zooming in is drawing lines. When you draw lines parallel to or along the end plates, you're actually zooming in that angle, because the longer you make those lines, the angle starts to subtend more better. Like a 1 degree won't be noticed when the line is only so much, but when the line gets drawn, the 1 degree starts getting expanded. So when you draw lines, you'll really know which one is most tilted. And this is, I think, self-explanatory. If the lines are parallel, it means both the vertebrae are equally tilted. So the upper of the lower becomes the lower end vertebra of the upper. Okay. Right? Is there any confusion there? Because you all will be made to do this exercise. So here the surgeon has drawn a line on the upper end vertebra or upper end plate of the upper end vertebra. And I think he's convincing himself that T8 is the upper end vertebra. If there's any argument, draw a line at the lower end plate of the see if these lines are parallel. If they are parallel, T8 is the upper end vertebra of the medial tricep. Clear? Any questions? Because you'll be asked this, you'll have to come here and then do this by yourself. The next thing you need to know is that end vertebra are like a name, which means that once you're born, you're given a name, and that name remains with you whether you're in Malaysia, whether you're in Japan, or whether you're dead. Similarly, end vertebra of a curve are determined on a standing empty X-ray, and they remain the end vertebra of the curve. They don't change on bending. So when you do a bending film, you'll find that different vertebrae tilt maximally because you're trying to correct. And those are called intermediate vertebrae. Is that clear? So get that very clear. The idea of telling you what's an intermediate vertebra is to make you understand that end vertebrae don't change on bending film. The most tilted vertebra could change on the bending film, would change. That doesn't make the end vertebra different. Is that okay? Right. What about apical vertebra? So apical vertebra alludes only to the twist. End vertebra alludes only to the tilt. Apical alludes to the twist. So the most twisted vertebra in that curve becomes the apical vertebra. Invariably, it's going to be at the apex of the curve because that's where the business started. The carom point started rotating. Invariably, it's going to have maximum structural changes. The spinous process will be vakra, pedal will be thin, rib will be out. So a vertebra with the maximal location at the center of the curve with the maximal bony changes and hence farthest away from the CSVL. So the CSVL comes into play when you're talking of the apical vertebra, not when you talk of the end vertebra. Keep this crystal clear in your head so you don't make any mistakes. All right. So this is the apical vertebra in this particular case. Now, if there's an argument, here you may argue that I think you may say this is the apical vertebra, and someone else may say no, I think it is this one. How do you then solve that argument? So you draw a CSVL. You draw a CSVL, draw a line that's parallel to the CSVL, tangential to the curve. And where that line cuts the curve becomes the apex. Now here you will see that it's cutting the curve at the disc. Actually. It's not touching the curve at this bone or that bone. So in this particular curve, the apex is a disc and it has two apical vertebrae. By definition, this curve has a disc which is the apex, not an apical vertebra. And these two are the apical vertebrae of this. Okay, it's important because you want to get a screw in each of the apical vertebrae. So when you're operating, you want one screw at least in every strategic vertebra. The end vertebra, the neutral vertebra, the apical vertebra. So you need to know this. Neutrality alludes to rotation. Okay, apical is the apex, neutrality is rotation. So the least rotated vertebra, the lower and the upper end of the curve closest to the apex is the neutral vertebra. Okay, there's a problem here that neutral vertebra is defined by eyeballing. There are no measurements. There's no CSVL. It's eyeballing, which means you look at this and you say, oh, this pedicle looks central. The spinous process looks central to the pedicle. So when I look at a bone, or when you look at a bone in a scoliosis, you look at the pedicle as the eyes, as you see my face. The nose is the spinous process, and the ears are the transverse processes. Okay, so if I'm looking at you absolutely straight, everything will look symmetrical. The minute I start looking at you like this eye will look bigger, this eye will look smaller, deviated. That's exactly what you will see. So the bigger the pedicle, that is the sign of the convexity. And that is an eyeballing, which means that you may think I'm straight. This guy may think I'm slightly crooked this side. And if I do this, he may think I'm straight, but you may think I'm totally vakra. Understood? So that becomes a bit subjective, and hence neutral vertebra, though there is a definition involved, it becomes a slightly gray area. The stable zone is the zone that
That's it.
lies in
Good
the
morning.
stable
What
zone
is
of gravity.
the medical
If
oncologist,
you draw two
sir?
perpendiculars from the SI, I mean, from the L5 S1 junction, if you start and
Tomorrow.
end your fusion in
Tomorrow
this
you told
zone,
he will
you're
take
going to get it right.
live.
If your fusion ends outside this zone, the spine is going to fall off. That's again common sense. All right. And then the stable vertebra. So the stable vertebra is the vertebra that is best bisected. Bisected means cut into two halves by the CSVL. Which one here would be the stable vertebra? Assuming this is 5, 4, 3, 2, 1, 12. Which one is a stable vertebra? Correct? This is better bisected than this. Remember, bisected means cut into two equal halves. This is cutting it, but not into two equal halves. If you keep your LIV as your stable vertebra, you're going to nail the problem. So if there's any confusion, keep your LIV as a stable vertebra, you're sorted. That's why knowing the stable vertebra is critically important. If you stop your fusion level above the stable vertebra, there's a potential problem that can happen, as you can see here. All right, so those are the strategic vertebrae. And then quickly, I'm going to rush through because we're clearly ahead of time, way behind time. When you look at the history taking of AIS after the basics, you want to make sure that you want to ask all the right questions because AIS is not a pathology. You don't have to say contact hai kya, sardi hua tha kya, pain ho raha hai kya. None of that happens. You have to ask them besides a growth history and birth history to rule out non-AIS causes because AIS is no other specific history. What you want to ask them is the lack of complaints. If they have any of these complaints, they are probably not AIS. So that's the first takeaway. And the second is that when you ask for deformity, so you say in your exam that this child has come with the chief complaint of a cosmetic deformity, that's not good enough. What specific deformity bothers the child and the parent is what you need to take away before you can offer a solution, which is what I said right in the beginning. Someone may say, this shoulder is high. That's what bothers me. Well, I have the capacity of correcting it during surgery. But someone says, my breast is unequal. At the age of 15, I'm not able to correct that breast size by doing a scoliosis surgery. So both the parties should be aware of what is on the anvil. All right. And then, this slide you should take a picture of because this slide will cover the whole examination. If you follow from top to the bottom, and you will probably get it right, you probably won't miss the cosmetic problem, and you'll ask the right questions. Because sometimes the children also don't know that they're more worried that this arm looks out. You have to ask all these questions. Do you feel this is okay? Do you feel this is okay? And then they will rib hump at the back, rib hump at the front, joint crease. Sometimes ask all these questions and make the right decision. So I think I'll stop here. There's too much more to be done, and we'll hand over to Shiv to carry forward.
I think this one talk sets the ground absolutely blaze. If you do not know the exact way to find out the end vertebrae, the neutral vertebrae and stable vertebrae, this is like the name, like he mentioned, it has to be crisp. If Vishal is Vishal, he is Vishal, whoever calls it. That's why end vertebrae cannot have a inter-observer variation. It cannot have it. Because all the strategic planning about levels, where to fuse, where to stop, upper vertebrae, lower instrumented vertebrae, it all depends on whether you have got your end vertebrae, neutral vertebrae, stable zone correct or not. And like the last slide that Dr. Abhay mentioned, all the principles that we are going to be discussing today apply to only one problem: adolescent idiopathic scoliosis. But every scoliosis is not a idiopathic scoliosis. There are varied causes to it. And like Dr. Abhay mentioned, if there are symptoms like back pain, dysfunction, neurology, breathlessness, which is our duty to put leading questions and examination, even if patient doesn't complain, it is our duty and responsibility to find out the first thing. Idiopathic scoliosis is like a diagnosis of exclusion. That means you have to rule out, find the secondary cause of scoliosis. And once you have found out that there is nothing abnormal, neurology is normal, skin patches are normal, and the most important thing, it's a female child. If there is a male child, or a curve is on the left side, or if there is a neurology or skin patches, all this in your clinical examination, you can say that I'm not
Find the secondary cause of scoliosis,
and once you have found out that there is nothing abnormal,
So,
neurology is normal, examination
skin patches are normal.
and what is it that comes to your mind when you see a patient of scoliosis to
it's a
say
female
whether this is
child.
the
If there is a
atypical or
male
non-idiopathic
child,
one? or a curve is on the left side, or if there's a
non-AIS would be a
neurology
boy.
or skin
Think of
patches,
if it's a boy,
all
it's
this in
very
your
rare
clinical
that it's
examination, you can say
likely to be
that I'm
AIS.
not
Find
dealing
A
with
the
curve that's
secondary cause of
left-sided convex
scoliosis,
compared to
and
right
once
side
we
is
have found
non-AIS.
out that there is
Anyone
nothing
who
abnormal,
presents with
neurology
minimal
is
is
normal.
quick. If someone
examination
presents
very
any
normal.
simple
And what is it
patches,
that comes to your
and
mind when you
most
see a patient of
important,
scoliosis?
on examination, you
Whether
will
this
find
is age
thinning of
or
one of your limbs.
or a curve is
You
on the
find
left
neurological
side,
signs,
or if there's a
SLRs.
neurology.
If SLR is positive and a child comes with a scoliosis, what do you think is the diagnosis? Scoliosis. The chief complaint of the child is scoliosis, but on examination, SLR on one side is positive. So two potential diagnoses. One is a list because of a PID, prolapse intervertebral disc, and the other is a high-grade spondy. In a high-grade spondy, it gets missed because they are more worried that they've got the secondary deformity, but in reality, it is a. And then, of course, skin markers, skin patches. If there's a child whose brother or sister also has a scoliosis, if there's a syndromic facial features, which means the eyes are low set, hairline is low set, if there's a child, there's a history of a bad birth history, all these then would start making you think of non-AIS. Okay, and if it's non-AIS, put it in another basket. It is all this goes away. You have to think completely differently. It's a different disease, different problem. It is called scoliosis. Don't apply these Lenki criteria, bending X-rays, etc., to the non-AIS. I think that's the take home.
So all these small clinical history, even before X-ray comes, even before you start looking into X-ray and start planning your strategic vertebrae, end vertebrae, LIV, UIV, look further whether you are really dealing with AIS or you are not dealing with AIS. You are dealing with a congenital, syndromic, neuromuscular, or pathological scoliosis, because that requires a completely different mind game. Having said that, the commonest type of scoliosis is idiopathic scoliosis. And after you're done this clinical examination, you know about the definitions of these vertebrae. Where do we apply them? How are they really helpful? What is the next step? Step number 2 is radiological evaluation by none other than Dr. Kshitij Chaudhary. All done? So any questions so far? Any questions? Yes, please.
The margin is not clear for when you are trying to measure the COBs. The margin is not very clear. Is it okay to draw a line in the superior part of the pedicles?
Easy. Because of the kyphosis or the lordosis, the end vertebra doesn't look like this. It looks fuzzy, like this, because it's tilted. So it's a good question. So then how do you know whether this is your line or if this is your line? And you get it wrong. So here and where the pedicles come in, the pedicles are normally very clear. You draw a line on the superior tangent of the pedicles, and that becomes your end plate line. So it's a great question, and that's the answer.
How to measure the COBS angle and why is it important? While Kshitij is going to be mentioning about it, Dr. Neeraj is going to drop something on the delegates group, about different digital apps which can be used to measure the COBS angle. Neeraj, would you do the pleasure for us, please? The op easy thing, and we will play it at the end of it.
So one of our colleague, he has actually designed this Opties app. At present, it is free to all, registration possible, and you can measure everything. Not only measure everything, you can keep it as a data also. Dr. Sharvin Sheth, who is from Ahmedabad, is Amit Jala's colleague surgeon, and he has designed this beautiful app. Not only for pediatric but also for adult spine deformity, where PI, LL, everything is you can very easily measure it, and you can store the data, you can share it for your academic purpose also. He has sent us a small video of it, and we will be sharing in the delegate group, and whenever we have a time in between, we'll play that 3 minutes clip so that you all know, because there were some questions how to measure what are the apps available. So this is one of the beautiful app this that he has designed, and it is as per our Indian requirement. So it's really a good app. Just go through that.
All right. Okay. So you can take a photograph of this slide. I don't know how many of you know the radiographic manual that is available. It is by Medtronic, collaborated with Medtronic, but it is by the harms study group, and it standardizes the way we do measurements. So I think it's a good resource to have. It's freely available on the SRS website. You can download it. So what I'm going to talk about is not really the, all the steps in radiological evaluation, but the errors that we make when we look at X-rays of AIS. So the first error that you make is to do planning on an inadequate film. And the posture is really important and how you make the patient stand when you are getting X-rays done. The AP, but the lateral is with the patient's fist up on the collarbone and their arms going forward. So this is the position for lateral. That's the position for the AP. But when you get X-rays, it has to show the C7 to the femoral heads. Benders, they are supine benders, not standing benders. Supine benders should have curves in all the three curves covered. The knees should be locked, shoulder width apart, knuckles in the supraclavicular fossa, and the X-rays should show the entire rib cage. You don't crop out the rib cage, because if you crop out the rib cage, you won't be able to see the shoulders, right? So here you can see the X-ray where you can't see the S1. In the other X-ray you can't see the C7. So these are inadequate films. Sometimes you have stitching errors like these, so you have to discard these films. Another common problem is your benders don't have proximal thoracic. That's the very common mistake that is made. Your benders don't show the proximal thoracic because your cassette is not that long, and then you do the entire planning without the proximal thoracic flexibility assessment, which is a major concern because your shoulders will go off, right? If you don't have the idea about proximal thoracic. So if you have a short cassette, get another X-ray which shows the proximal thoracic curve. So you'll have two X-rays, one for the lumbar spine and one for the proximal thoracic, right? Another common problem is getting lateral X-rays which are not exposed properly. If they are not exposed properly, you're going to see the proximal thoracic white out like that, right? And you won't be able to see anything there. You won't be able to draw any angles. And as we will see that later, the proximal thoracic sagittal profile is very important to understand the structurality of that curve, right? The second error, you didn't count the levels. Like you get an X-ray like this and you say, okay, I'm going to take the lower instrumented vertebra or instrumented vertebra as L2. That's your initial assessment, that the LIV is L2 because you think that the last rib is T12 and you are going to go to L2 for your LIV. And then intra-op, when you position the patient and try to find the L2, you're counting from the sacrum, and then your L2 is actually the L3 because this patient has only 11 ribs, right? So make sure that you're counting the vertebra properly because you're going to make an error in level selection during the surgery. So whenever possible, you are trying to maintain this 12 plus 5 symmetry when you are counting. So sometimes you have 11 thoracic vertebra, 6 lumbar vertebra, sometimes you have 13 rib bearing vertebra and 4 lumbar vertebra. So keep these numbering same, because if you're counting errors, then intra-op you will choose the wrong fusion levels. Third error, you forgot to test the minor curve in the lateral view. This is very common error. Everybody thinks of the minor curve structurality in AP view, right? They are looking at 25 degree, whether it bends to less than 25 degree or not, and then forget the lateral X-ray. The important thing to remember is that the lateral X-ray overrides anything that you see on the coronal film. So if your lateral X-ray shows a kyphosis in the proximal thoracic of more than 20 degrees or thoracolumbar kyphosis of more than 20 degrees, then it doesn't matter what your AP flexibility of the minor curve is. It is completely overridden. So make sure that when you are assessing the structurality of the minor curve, see the lateral X-ray and don't take a knee-jerk reaction on the basis of the AP film that, array, this minor curve bends to less than 25 degree, it is a non-structural curve. So don't do that. Fourth error, you re-chose the end vertebra on the right. This is another common error that is happening. What is happening is that you are choosing your end vertebra on the AP X-ray, and then when you are taking the benders, you are changing the end vertebra. You are changing the end vertebra because the tilt is reducing. So if you are choosing T4 and T12 as your end vertebra on the standing film, and when you bend, the end vertebra actually comes closer to the apex because the curve is now flexible. If you do that, then your number changes, right? So never ever change your end vertebra. Your end vertebra, what you decide on the AP X-ray are the ones that you are doing on the benders to assess the flexibility of that curve. Common error. Fifth error, you just chose one shoulder level assessment, right? You forgot that there are two kinds of shoulder imbalances, medial imbalance and lateral imbalance. Medial imbalance is what appears as trapezial prominence, and it is measured by the T1 tilt or the level of the first ribs. This kind of a medial imbalance is a little bit in the surgeon's control, what can be corrected. And Dr. Kwan and Chan, they have a maximum literature on shoulder balance, and I think those talks will come later. Lateral imbalance is assessed by the clavicle or the height, radiographic shoulder height. The important thing to remember here is that there is a fair amount of discordance between the medial shoulder balance and lateral. So almost 50% of Lenki 1 or Lenki 2, you may have a T1 tilt that does not match with the radiographic shoulder balance. Means the T1 is tilted left side up, but the radiograph shows right side up. Actual radiographic shoulder balance. So that discordance is not uncommon. Sixth error, you dropped every line from the central sacral vertical line. The only line you draw is the central sacral vertical line. So that's not correct. When you are assessing the apical translation of proximal curve or the main thoracic curve, how far is the apex of the main thoracic curve from the center? You cannot use the central sacral vertical line. The central sacral vertical line is meant for the thoracolumbar lumbar curve, and the C7 plumb line is meant for the thoracic curve. So when you have a spine that is balanced like this, both of them will match with each other. Then your error hides in that situation. But when you have a curve like this, when you try to measure the apex translated from the central sacral vertical line, you are going to make an error because your apical translation is going to come this much. Actually, it is this much, right? So whenever you are judging how much the apex of the thoracic curve is away from the midline, use the C7 plumb line and check this. And for lumbar, check this. So that's the difference between the apical translation between the two curves. Now, seventh error. You drew the central sacral vertical line perpendicular to the sacrum of the pelvis. That's again an error, right? So you don't want to take, draw a 90-degree angle. Or you drew a level here and then took a 90-degree angle. That's not the way to judge the central sacral vertical line. The central sacral vertical line is drawn parallel to the edge of the X-ray. All right. So never to the base of the sacrum, because the sacrums can sometimes be like dysmorphic, a little tilted. Some pelvic obliquity up to 2 centimeters is very, very common. So only if pelvic obliquities is more than 2 centimeters would you put a heel raise and then take an X-ray. But within 2 centimeters, it is considered fine, and just you have to take X-rays with a central sacral vertical line drawn perpendicular to the edge of the X-ray. And if you don't do that, your stable vertebra changes, right? Because your line goes off. So again, remember that. Eighth error. You discounted the measurement error. Now, measurement error means if you take a cob angle measurement every time you're going to measure it differently because there's some degree of measurement error. In AIS, intra-observer variability is somewhere 3 to 5 degrees. Inter-observer is a little bit higher. So you would consider about 5 degrees as kind of a measurement error for you to judge whether the curve has progressed or not. So between two X-rays, let's say 1 year apart, if you are choosing the same end vertebra levels and the curve shows a progression beyond 5 degrees, you would call it a change, a significant change. But if it is within 5 degrees, it's not a significant change because it is within measurement error. If it is a congenital curve or a neuromuscular curve, obviously the measurement error is going to change because it's much more harder to kind of do measurements with deformed vertebrae, right? So measurement error, remember that. And the actual error comes not from measuring the cob angle, it comes from selecting the end vertebra. People choose end vertebra differently, and that's why pre-selecting an end vertebra and keeping that fixed over serial x-rays would reduce this kind of an error. Error number 9, you quantified the rotation and used it like a measurement, right? So x-rays are notoriously unreliable to assess rotation, and that's why the EOS imaging and the Da Vinci view and the 3D classification looks at rotations in a much different way. But just 2D x-rays for you to assess rotation in a quantified manner is extremely difficult and extremely unreliable, and that's why the Lenki classification does not use rotation as a modifier. They tried to use it but discarded it, and that's why it remains a 2D classification. So if you try to quantify how much lumbar spine is rotated with respect to thoracic spine on 2D x-rays, it's very, very difficult to judge accurately. Actually, a better measurement is a scoliometer reading in a forward flexion. So when you put scoliometer on the back of the thoracic area or lumbar area, you would get a fair assessment of the degree to which rotations are. And obviously, you have now the more advanced 3D imaging that can show that. Okay. You used a bending film for a large curve, or you used a traction film for a small curve. And this has been known from White and Punjabi's time, right? What happens is that for a small curve, a traction X-ray is not very efficient in showing the amount of correct flexibility of that curve. Whereas for a very large curve, like 70-degree plus curve, a bending X-ray is not very effective to show how much flexible the curve is. So what you do is, for a curve that is less than 50-degree, bending will be more efficient way of checking flexibility. And for a 60, 70-degree plus curve, a traction X-ray would be more efficient in checking flexibility. Like for example, this one, 53-degree curve, traction X-ray, it corrects to 30 degrees. But on bending, it corrects to 10 degrees. You would think that traction X-ray will show better correction, but actually the bending shows better correction. For smaller curves, choose bending. For larger curves, it is traction. Now, the error number 11, you trusted Lenki classification like it is gospel. It is not like a rigid classification, right? So the recommendations of Lenki are recommendations and guidelines. They are not rules to follow. And there are 3 areas that are extremely weak in the Lenki classification. The first is the proximal thoracic curve. Now, deciding structurality of the proximal thoracic curve using Lenki criteria is very problematic. And many times you make errors, and many times you would choose differently than what the Lenki classification recommends. Again, lot of literature is from the Malaysian group, so we will see that later in the day. Second problem is the CSVL. Because the CSVL doesn't have a central landmark that is very fixed. That's why identifying, what is B versus C versus, where there are like those in between curves becomes problematic. So the Lenki classification says that if you are confused, put it as B. All right. And the third one, that is the weakest component of the whole system, is the sagittal modifier. Getting X-rays T5 to T12, whether it is minus, neutral, or plus. That's again unreliable measurements. So in conclusion, these are the errors where the reading breaks. You can take a photograph of this, and I'll end my talk. Thank you very much. Fulcrum bending. Fulcrum bending. Where do you do fulcrum bending, and what is the method of doing it? So fulcrum bending X-ray has been shown to closely match what the post-operative corrections will be, right? So if you want to estimate what your post-operative corrections are going to be, fulcrum X-ray kind of more closely matches the supine side bends, but actually it doesn't make that much of a difference in choosing your, how you would do the surgery, or, because in AIS, most of the time what we are trying to do is achieve as best correction as possible. So that's the typical AIS, but fulcrum bending is useful for some of these borderline, the little bit higher curves, rigid curves, there you may use it, but I don't use it routinely. No, not regularly. So it depends. The frequency of X-rays depends on where the patient is in their growth spurt or in the growth time. So usually these are adolescent idiopathic. If they are like tweeners, you are doing it more frequently, 4 to 6 months. If they are menarche, post-menarche, you might do it a little bit more, less frequently. And bending X-rays are just deciding the surgical treatment and not for your routine progression assessment. You'll have to supervise it, but you can do it. The Lengi classification recommends supine side benders with maximum effort of the patient. You can do push prone, you can do supine traction also. But these are all accessory. So for you to classify supine side benders, many people make an error of doing standing side benders. So it's not standing side benders, they're supine side benders.
Any questions? So now you know the differentiation between a typical and atypical curve, idiopathic versus a non-idiopathic curve. You know exactly the strategic vertebrae, which ones to label as end, neutral, stable, how to measure, and what are the type of X-rays that you must do as the observation phase, and what are the X-rays you must do in a particular manner, and how to draw lines when you are actually planning a surgery, and how to use these measurements to classify a X-ray. How do we make our understanding uniform? That's where the classification comes in, and Neeraj will speak to us about different classifications and why are they important for us to plan, to talk, to communicate, and also to document for all longitudinal follow-up per patient. Dr. Neeraj.
So, good morning, all. Thank you, Vishal. I'm not going to include so. I'm just going to focus on one Lenki classification, how it has evolved, and how to step by step you classify uh, a curve. So this is basically an approach. How do we tend to classify this entire saga of deformity? Kshitij has wonderfully actually demonstrated how to measure all those things. So why first of all we need a unified classification system? So without a common language, it is very difficult to communicate what we are treating, and classification should give us some guidelines on how should we treat a particular patient. So if classification is not giving this to broad perspective research, communication between peers, classification is of no use. So Lenke is probably one of the most commonly used classification in spine surgery. So it started from Kings and Mo classification. I think when we were studying, this was probably one of the most commonest classification we used to classify our scoliosis. It mainly focused around thoracic uh, deformity in a spine. The lumbar curve was not so much focused because in those time the Harringtons, all those things they were using more. So I think the Mo started with focusing on thoracic curves, and then Lenke came and added these modifiers which focuses on lumbar spine and sagittal profile of a patient. So this was the main change which happened eventually. The whole classification system, basically focuses on three decision making. One, first, which regional curves are structural. So that defines your Plenky type 1, type 2, type 3, type 4, type 5, and type 6. It's purely based on which curves are structural. Then it adds what is the condition of lumbar curve, how far it is from the central CSVL line, and where is the curve residing in lumbar spine. That adds the modifier A, B, and C as number. And finally, the sagittal modifier, that what is the sagittal profile of the patient? Because more or less all curves are hypokypotic curves. In some of the group, they say these two would believe that the first deformity to occur is the hypokyphosis of thoracic spine over which the entire spine rotates. So what is this hypokyphosis? That is what is determining the surgical profile of the patient. So you have to start with identifying what is a structural curve, what are structural curve, then what is the lumbar curve by any modifier, and finally you come up with a sagittal modifier. So it becomes type 1 to 6 added with EDC, added with minus neutral or plus. Minus is hypo, neutral is plus hypokyphosis. So this is how the length classification more or less decides. What X-rays are needed? Standard standing PA, and standing lateral decides your kyphosis, and bending films to decide which curve is structural. So these three X-rays would decide your Lenki classification. Now, before we classify, we need to understand the region. How do we classify this region? So proximal thoracic ranges from T3 to T5. T1 to T12 is generally, this is how you measure it from T1, T2 to T5. Main thoracic starts from T6 to T11, 12 disc. Remember, it is T11, 12 disc, not T11 or T12. It is T11, 12 disc. And thoracolumbar lumbar curve is T12 vertebra or L1 to L12 disc to L4. It goes up starts from T12 and goes up to L4. That is thoracolumbar lumbar curve. So measure the PT, MT, and TLL cob angle on a standing PA. The largest cob angle is the major curve. Regardless of whether on a bending film it goes above or below 25 degree. Some of the delegates had asked in the group that what if both the curves are flexible. So you have to consider that a major largest cob angle is, with definition, it's a structural curve in your scoliosis, even if it is significantly flexible. So once you have decided that what is this curve region, then you go to step B, whether your curve is a structural curve or it is a non-structural curve. So we know the definition. A minor curve is a structural if residual cob angle is more than 25 degree on a supine bending film, or a regional kyphosis which is more than 20 degree on a lateral film. So if your minor curve follows either of these two definitions, that is considered a structural curve and would be included to classify your Lenke curve. Do not judge structurality from the standing cob angle alone. You need a bending film for that. So structural curves always, why it is important? Because every structural curve you will have to include into your fusion mass. If you leave behind your structural curve, your patient will have an imbalanced spine. So this is broadly the Lenke's classification. You start with first what is major curve. So if it is so Lenke classification mainly focuses on two major curves. One, which is a thoracic major curve, main thoracic major curve, and second major curve is thoracolumbar lumbar curve. Entire classification roams around these two major curves. So now first you decide whether your patient is having a thoracic major curve or a thoracolumbar lumbar major curve. So if it is thoracic major curve and no other structural minor curves, then it is type 1. Okay, clear? If only thoracic is major and no other structural curve, proximal or thoracolumbar lumbar curve is non-structural curve, then it is Lenke type 1. Type 2 will include proximal thoracic as a structural minor curve. Okay, so major remains thoracic and added to it, which will be a minor but structural proximal thoracic curve, and that becomes a type 2. So it is in Kings and Moore, it is a double major curve. So it's a proximal thoracic structural and main thoracic major. So it is PTMT, which is Lenke type 2. Now, the Lenke type 3 goes down. So your proximal thoracic becomes flexible, non-structural, and the thoracolumbar lumbar curve becomes structural. Thoracic still remains the major curve, and added to add is thoracolumbar lumbar structural curve, and that becomes Lenke type 3. So type 1 is only thoracic major, type 2 proximal thoracic is structural, type 3 is thoracolumbar lumbar is structural. So there are two double major, which is 2 and 3. Now the Lenke type 4 is triple major, where
proximal thoracic and thoracolumbar lumbar, both minor curves are structural curves, right? So main thoracic, type 1, proximal thoracic, structural, type 2, thoracolumbar lumbar, type 3, and all three curves which are structural, that is type 4. So triple major is type 4, Kings and Mo. So 1, 2, 3, 4 mainly focuses when your major curve is main thoracic. Understood? Okay. Now 5 and 6, where the major curve is thoracolumbar lumbar curve, meaning the apex goes down from T12 to L4 is your apex. So, and that is where your type 4 and type 5 comes. Now, in type 4 comes the thoracolumbar lumbar curve. Only thoracolumbar lumbar curve is a major curve. Rest of all curves are structural, and that is type 4, just like type 1. So, type 1 is thoracic isolated thoracic main thoracic curve, which is major, and type 5 is only thoracolumbar lumbar curve, which is major. So it is just like type 1 is type 4 for lumbar. Okay. And then type 6, where the main thoracic becomes structural along with major thoracolumbar lumbar curve, and that is a type 6. So if you see, how do you decide that, sometimes, there will be a confusion. The measurement errors which Kshitij was mentioning, type 3 and type 6, many a times it will look similar. So that's where, I'll take it in the subsequent slides how to differentiate that, but they more or less look same. In type 3, main thoracic is major. In type 6, thoracolumbar lumbar is major. Okay, so type 3 and type 6 on X-ray, sometimes it looks very similar. So how do you decide which is the main main curve? Main thoracolumbar lumbar is type 6 and main thoracic major is type 3. Sorry. So this is what, entire crux of the you have to divide your classification into two. Your major curve, main thoracic, this is what we have discussed so far. If there is no other structural curve, it is type 1. If proximal thoracic is structural, then it is type 2. If your thoracolumbar lumbar is structural, type 3. All three curves structural, then it is type 4. And when it goes to say major curve, which is thoracolumbar lumbar curve, if no other curves are structural, then it is type 5. And if main thoracic is structural, it becomes type 6. Okay, and you have to remember this 5-degree rule, which I was saying that, there has to be a minimum difference of 5 degrees between main thoracic and thoracolumbar lumbar curve to classify any of the curve as a major. So when you have type 3 or type 6 and you want to classify it as type 6 curve, your thoracolumbar lumbar curve should be at least 5 degree more than your main thoracic curve. Why? As Kshitij mentioned, 5 degree can be an inter-observer error. So you want more than 5 degree to classify them as type 6 or type 3. Now, why this is very important to classify properly is because your fusion levels would be decided based on this Lenki classification. So you don't want to err on your classifying this Lenki curves. Step 2. So then assign the lumbar modifier, A, B, and C. So what is lumbar modifier? Lumbar modifier is how bad your lumbar curve is, how far your lumbar spine is curved because of either proximal thoracic or a middle thoracic curve or by itself. So it decides how distal you want to go. So the more your lumbar spine is away from CSVL, you will have to go down and down to balance your spine. Now, this is very interesting that, if you see type 5 and 6, by definition, will have only C modifier. Because if it is modifier A or B in 5 and 6, thoracolumbar lumbar curve will never be a major curve. Easy to understand. So whenever you are talking about type 5 and type 6 curve, it has to be a C variable. Otherwise, you cannot term them at 5 or 6. So always you see, whenever there is classification, Lenki type 5C, Lenki type 6C, Lenki type 5A will not be there. If you classify Lenki type 5A, your classification is wrong. Okay, so by definition, 5 and 6 has to have a C modifier. So it decides how much lumbar curve is being left behind if you are planning a selective thoracic fusion. And then comes the kyphosis measurement. So hypokyphotic less than 10 degree is minus, normal is 10 to 40 degree, and hyperkyphotic, which is a positive thing. So thoracic hypokyphosis is rule in AIS, as I just said. So that is to obtain your sagittal profile in your patient. Now, why this type C modifier matters? If it is A, generally your lumbar spine is very well balanced on your pelvis. If it is B, it is a slightly overweight. So it's very easy to understand that if you want to do a selective thoracic fusion, it is very easy to do in modifier A. It is online to do in modifier B. Very rarely you can do in C. C is again not a contraindication for selective thoracic fusion. Okay, your spine can be completely flexible, and it also depends on your L4 vertebral.
So Nagarjuna is referring to
Okay,
KVVN
so
Raju.
that is how we decide that. So C is never contraindication, but relatively an uncommon variety for having a selective thoracic fusion. So T1 tilt, Abhay has already mentioned that it decides your shoulder and your fusion level. So it is positive when T1 is tilted left side, the upper end plate is tilted into left side. It is left shoulder up, and your fusion level has to go up to T2. Okay, if it is level, your shoulders are level, your upper end vertebra would be T3. Upper instrumented vertebra would be T3. And if it is negative, that means tilted into right, your right shoulder will be up, and you will have your upper instrumented vertebra will be T4. So this is the T1 tilt, which is not again included into Lenki classification, but you must know about this. So this is one X-ray. I think the measurements are not coming. So how do you classify this? Anybody? I think we'll have to eyeball. I'm not getting the measurements. Anybody? Vishal, you can pick somebody to just classify this curve eyeballing.
Probably a Lenki type 1.
Why?
Major thoracic curve.
Okay.
And lumbar seems to be pretty, in bending x-rays, it is getting corrected.
Modifiers?
Modifiers type A, sir.
Type A.
A.
And?
Kyphosis, hypokyphosis.
So how do you mention it? It's Lenki 1
A minus.
A minus. Okay, that is how you go step by step. Anybody would agree to that? Okay, so one more. Vishal again. So I'm sorry, I'm not getting those measurements here. So you'll have to eyeball, pardon me for that.
So the major curve is thoracolumbar. Sorry, major thoracic. And on bending films, the lumbar curve is getting corrected. So it would be Lenki type 1 B, because it is touching the apex and not going from between. Yes, sir. So type 1B plus.
Okay, plus this was neutral actually, but that's okay. We don't have a measurement. So why I put this X-ray? On this film, it looks like double major, right? It looks like double major Lenki type 3. Okay, how do you decide what it is? Based on this lumbar spine.
Bending.
You see, lumbar spine is becoming completely straight. So definitely, even if you eyeball, this is going below 25 degree, right? So this again becomes Lenki type 1. So there are two Lenki type 1. You see, this is Lenki type 1. And this is also a Lenki type 1 curve. Okay, this is last X-ray. How do you classify this? Anyone? A tip, remember the errors what Kshitij mentioned. You may try. Anybody else want to try?
So the lower levels are not clearly visible. So.
Anybody notice this is a left thoracic curve?
Sir, but for CSVL line, we need the edge and the center of the...
This is not AIS.
Acha, sorry.
This is not AIS. This patient has a spinal dysraphism. So this is what, this is why I have included this part. AP. Yeah, this was a spinal dysraphism. Patient has a spina bifida with a split cord. So this is a different. This doesn't fall in any of no Lenke classification, right? So this was a female child in a left thoracic curve. So right thoracic is more common. Left is also rare, but if you see a left thoracic in a female, you have to try to find other reasons for the curve because they will not fall into classical Lenke classification. So what classification actually changes? Why this classification is very important? So it says fuse the structural curve, okay? Type 1A, 1B, always, or try to go for a selective thoracic fusion. Now, if you have a C variable, I'll not go much into detail because we have a fusion level talk, but just remember that in a 1C, when you have a C modifier, you have to look at the major thoracic thoracolumbar curve Cobb's angle ratio. It should prove that your thoracic curve is larger than your lumbar curve. So ratio roughly is 1.2. So it should go positive. Your ratio should go positive. Then you can probably plan a selective thoracic fusion with clear understanding. So I'll not go much into detail because we have an entire talk on selecting fusion levels. Type 2 is again a proximal curve is always you have to instrument because otherwise your shoulder will be very imbalanced. Type 5 is mainly for selective thoracolumbar lumbar fusion. You can probably go anterior very easily. And modifier refines the end of the construct. Now, there are Lenke outliers, Okay, there is. So I'll just go. I'll not go much into this. If there is a talk, I'll not go again into this because this will also be included into your fusion level talk where how to decide based on your tilt of L4. So we call it 1AL, 1AR. Based on how your L4 is tilted into the curve. So this is what it is. So finally, this is the slide. Now this classification is undergoing a validation, and as Kshitij just said that Lenke classification is mainly a 2D classification and no mention of rotation. So this classification, the Lenke Obin 3D classification, that with EOS system and AI generated axial planes now can measure the rotation of lumbar spine relative to thoracic spine, and they have come up with a 3D classification. This is still in a validation phase, so we'll again not go into detail because today this is not used clinically for decision making in our patient. So this is how it looks like. It measures this rotations, the orientation of regional pain deformity. So this is how one region is rotated against the another region. So to take home message, measure the 3 regional curves first, and then you type 1 to 6. Then add first lumbar modifier, how your lumbar spine is behaving as compared to your curve, and finally do the sagittal profiling on patient, and then you type your curve. So structure, type, UCSVL, finally the sagittal plane parameter to decide your classification. Thank you so much.
Confusing, but broadly there are type of classifications, kings and Lenke of today, validated, time tested, proven that they help not only in documentation, communication. When I call Neeraj and say that I operated type 1AN, he knows what precisely I am talking about. So communication, documentation, that I operated type 1B curve N and corrected it to this. That means there is a documentation and this was the amount of correction. And then the levels, because particularly Lenke has given us the concept of structurality, whether this is structural or non-structural. And the broad idea is all structural curves must be fused. Non-structural curves may or may not be fused based on the modifiers. Single liner. All structural curves should be fused. Non-structural curves may or may not be fused based on the modifiers. If A and B are there, they can be left alone. That's where the selective fusion comes. If type C is there, should be very particular about leaving it into selective fusion. Now, the biggest mistake that we all do, even me today do, is we eyeball measurements. सिर्फ Cobb's measure किया और Lenke बोल दिया. No, that's not the way. Take a plain sheet of paper. Every time a X-ray of scoliosis comes to you, take a sheet of paper, sit down for 10 minutes, draw lines on the X-ray, and keep measuring every single detail. CSVL, C7 plumb line, COBS, and stable, neutral. This exercise we did in the group also, multiple times. Every time, measure end vertebrae, neutral vertebrae, stable vertebrae, bending, whether it is structural, non-structural. Decisions can come later. Whether I have to do selective or non-selective can come later. What type of curve is this can come later. And it will automatically fall in place if you have all the data points. AI becomes accurate when it has multiple data points. Similarly, natural intelligence becomes absolutely accurate if you give multiple data points. And these data points we have to measure. COBS angle, end vertebrae, neutral vertebrae, stable vertebrae, CSVL line, modifier, bending films, magnitude during bending. Only this. You don't think about whether it is structural, non-structural, or what type of curve it is. Like in the last slide Neeraj highlighted. Please make all possible measurements first. Apical vertebral translation, neutral, stable for the upper, neutral, stable for the lower, end vertebra, the upper end of the lower, COBS here, COBS there, COBS in bending of the upper one, COBS in bending of the lower one. Just write down on a piece of paper. The moment you write it down, the eyeballing thing goes away and your natural intelligence becomes absolutely accurate because of multiple data points that you have fed there. And then automatically it will come there. Automatically you'll know what type of curve it is, whether it is a structural or a non-structural, what kind of modifier it is, whether I have to fuse the upper one or leave the lower one. And once you start thinking that I have to fuse both, that's when the actual concept of how short to stop and how long to continue. How much stability I have to give, how will I get maximum balance, and how can I leave the motion segments free. Ultimately, scoliosis boils down to only this. To give a stable, balanced spine, leaving behind segments mobile. If this three have to be given an answer, I think the answers will come when you have multiple data points to use. Now, all this is about surgery. We had a very interesting question on the group also. Where is the role of bracing? If a patient comes at 25 degrees at age of 13, is bracing useful or not? If a child is of 25 degrees scoliosis at the age of 8 years, where does it fall in place? And a child of 5 years with 20-degree curve, does bracing helps? If a child who already passed the pinarchal age and is 35-degree curve, non-surgical, but will bracing help or not? For all these questions, what kind of brace, how long do we want, when to use, and when please strictly say that bracing is not for you. All these questions by Dr. Arjun Davle.
I'd like to thank Vishal and I'd like to thank Vishal and Shraddha and the spine team at Lilavati Hospital and also Medtronic. So I'm going to sort of ask you. One is, we had the first talk by Dr. Nene about what is the most effective treatment. When we talked about the most effective surgical treatment, I'm going to reframe the question and say, what is the most effective treatment for scoliosis? Okay, and I'm going to ask you to answer this at the end of the talk, and you can sort of maybe raise your hands right now also. And the other is, who is the most influential author in scoliosis treatment or overall treatment? And I'd like you to sort of just give me a show of hands. And the option number one for the first question is bracing, and the other is the VBT, and the third is fusion. So how many people are in favor of bracing as the most effective treatment? Nobody. Okay. And how many people are in favor of fusion? Okay. And how many people are in favor of VBT? And for the second question, suppose I ask you, most influential author, Lenke. Everybody? We just had a talk on Lenke classification. And the other is Weinstein. So how many people would say Lenke and how many people will say Weinstein? Most people Lenke, I think. Surgery with whatever it is fraught with its own problems. Okay. On this Friday, we had a revision scoliosis surgery at Vadia. Dr. Nene and I had to do revise a patient who previously was operated at Lilavati. And, we lost signals intraoperatively. There was a breach and a CSF leak. And fortunately, without a deficit, but eventful surgery. All right. And I think we got a correction, but not as great as we would have liked. So surgery, with all its, however we sort of look at it, there are complications which are associated. We have to be aware of it and definitely try to avoid it when we can. And that's where bracing comes. How does this move, sir? Okay, so basically we've talked about, how do you sort of understand? So it's not only the X-rays, you have to get a good history when you see the patient. So you start with a good history and you always ask the parents when they noted the deformity first, whether they've noted a progression, whether there are other complaints, like was alluded to earlier, and is there any back pain? You have to look, feel, move, and measure. Don't just concentrate on the curve. Look at the skin. Look at, the shoulders. Be sure about, any other deformities, lower limbs, etc. Don't sort of try to focus only on the spine. Many times these patients will have other associated findings. And always look at the patient undressed. So you always have to see that there is privacy and the patient is looked at, without, wearing all the garments. And here, this is a patient who looks absolutely normal, looks totally normal. But when you see on the forward bending test, you can pick up that there is a scoliosis, all right? And actually, this was a curve. Always do a good neurological examination. Check for any, asymmetric abdominal reflexes, because that may be a sign of a cord. And do the SLR. Now, the evaluation has been very, very well discussed by Dr. Nene and Dr. Chaudhary. And, understanding the cob angle, progression, maintenance. So why? Because you have to check serially what's happening. Looking at the CSVL, okay. So kind of, this has been well spoken about, but I'm just kind of reiterating it. Now, the resor. The resor is actually the key. So there is the resors and the Sanders. So why is this important? Because this determines if the patient is skeletally mature or immature. Okay, so you always have to get a history of menarche. So you ask about the periods in girls, because why? Because that's when they have completed their peak height. Okay, so you always want to know if the patient is premenarchal or not.
Have an orthopedic question?
Sexual characteristics.
A complex fracture? A difficult TKA? A challenging spinal deformity? The answers may already be on OrthoTV.
So that you're not having
From trauma and knee to hip, spine, and arthroplasty. Explore thousands of videos covering the entire spectrum.
Scale. Of course, it's obviously preferable to look at the Sanders also. Looking at the end vertebra, seeing that you see the same levels. Looking at the sagittal balance. Now, how does bracing work? So basically, bracing works, if you've heard about the Utah-Volkmann principle, okay? And in the normal spine, there is basically a symmetrical loading on both the sides. And that results in a balanced fascial growth, okay? Because of the uniform compressive force. And this leads to an equal vertebral development. While in a scoliotic spine, what's happening is that there is asymmetric mechanical loading, which leads to growth inhibition on the concave side. And this leads to basically asymmetry in the fascial growth. Now, with this, there is also a muscle imbalance. Now, there is a cause effect here. We don't know for sure, whether there is the muscle imbalance which is causing this, or it's a result of. But usually, I think it's a combination, and it's idiopathic because we really don't know the cause. Okay, but there is a asymmetric growth which is happening, and how you get around that is really the key. It's not actually on that coronal X-ray what we are perceiving, because that's just what we are perceiving in a two-dimensional way. And maybe the 3D classification will throw more light on it, but we don't have EOS in most places here. So now this is a child, who I had treated maybe around almost 10 years back. So you can see here that, the curve basically with time, it doesn't look like it's really progressing, but you can see that the patient is kind of going off. Right? So like a little decompensation. And this is what happened over, 18 months. And you can see that here. So you can see I've drawn the CSVL and you can see what's happening. The patient is just kind of going off, okay? But the cob angle is not actually changing that much. You see the cob angle is kind of not greatly changed. So the cob angle itself is not the only marker of progression. Okay, you have to see the balance of the patient and what's going on. And this child was treated with a brace. Now the SRS guidelines for treatment are very clear. Below 20 degrees, you monitor. 20 to 40 degrees is, where you consider orthotic treatment. And it has to be a skeletally immature patient. And if it's more than 45 or 50 degrees, you will, offer surgery. So this is a patient who, came to me at the age of 13, and she was skeletally immature. You can see that riser was less than 2, and she had a double curve. Okay, so a lumbar curve and a thoracic curve. Anybody would like to classify this Lenke classification? So here you see the lumbar curve is more than the thoracic curve. So basically, then what type of what would you call it? So remember that the 1, 2, 3 are primarily thoracic and 4, 5, 6 are lumbar. So you just have to kind of keep that in mind, okay? And so 6 is correct. And you can see there are 2 balance curves, okay? It's there on the. See that that's what I'm saying. So you see that your radiograph includes is wide. So you're not doing another area. You see to tell the X that you please include the pelvis on the same X-ray. So you're not doing extra radiographs unnecessarily. How would you like to treat this patient? Anybody? Anyone else? Yeah, that's correct. She is premenarchal. Premenarchal. Premenarchal less than RISA 2. So what would you like to do? Okay. So she was braced, okay, and you can see the curve has reduced. The thoracic curve is down to 20, and the lumbar curve is sort of not changing that much, but that's basically out of the brace. That X-ray is taken out of the brace, and you can see that's holding. This is when she was 15, and this is when she finished her growth. She finished her growth, and this was when she was around 16 years old, and you can see that the thoracic curve has actually now gone to 42, and the lumbar curve is 38. So this is how she looks. What would you like to do here? So this is a success of bracing treatment, okay? Because she has 2 curves. There's a primary thoracic curve, and that lumbar curve has kind of stayed static, and she's actually very well balanced. Okay, and how do you assess the effectiveness of the brace? So suppose you have a patient who's had a brace made. How do you know that the brace is effective? So you have to get a radiograph in the brace, and you have to see that the cob angle is reducing by more than 50%. Okay, because otherwise, so after you get the brace made, you actually send the patient for a radiograph and then call them back. Now, this is just to show you how the EOS, software is, and there is something called CAD/CAM. So, computer assisted design, and that's how usually the bracing is made. This is another patient, 11-year-old premenarchal, You can see that the curve from 46, so this is a 46-degree curve, okay? But she's been treated with a brace and the curve is down to 33. And she has managed in a brace. She's not needed surgery. Similar, another, 13-year-old. And you can see that that curve is flexible. And here you can see that curve has decreased, from 35 to 22. Okay, so always have so we have a in-house orthotic factory at Vadia, so we can get it done. Our patients go, they get it done, and they come back to us. One of the limitations is getting a good brace, but you can get around that. There are different types of braces. So this is a conventional way of making the brace, where with the plaster you take a negative and then you get it done. Okay. There are various types of braces. So, there's a Wilmington brace, which was in DuPont, the Boston brace from Boston Children's Hospital. There's a Charleston brace, which is like a nighttime brace, which is basically bent. It's like a bent brace. You only wear it at night. So if somebody's not ready to comply with the brace all the time, they wear it only at night for like 8 to 12 hours. Okay. Then there are new braces like the spine cord brace, which is a flexible brace. So bracing has a role. And, one should sort of consider it in those patients who will be benefited. And actually, that's where the school screening program, all that comes in. It's not to actually identify surgical patients. The surgical patients will identify and come to you at some point whenever it is to identify that window of opportunity wherein you can manage the patients without surgery. This is just to show you the CAD cam. Now, who should be braced? So all adolescent idiopathic scoliosis patients between 25 to 40, early onset scoliosis, idiopathic curves which are flexible. And scoliosis, I do use it sometimes to control the secondary curve. Okay, I do use it in smaller children. The brace compliance is a key, so they have to wear it for 20 hours. They can remove it when they go to school, but then they can wear it after that. So if they're conscious, the psychological effects are sort of emphasized, but I think it should not be overemphasized. I think it's about how we counsel. Self-image is one of the concerns. Okay, dermatitis, and then just restriction in some sports activity, but you can wear the brace. Actually, sports is recommended. It's good to have good truncal strength, etc. So this is Alf Nachimson, okay, the Swedish surgeon, and actually he came up with this randomized trial way back in 1995. Okay, and he basically compared 3 treatments. One was bracing, one was electrical stimulation, and one was observation. And they found in their subset in Karolinska that the bracing had a success rate of 74% versus 33% with the other 2 treatments. Okay. So landmark study this was, okay. And then you come to this, randomized trial. Now, over the years, still bracing has had its, proponents and people who differ. Okay, and some patients agree and some don't, and some surgeons believe in it and some don't, just like in this room right now. But this study by Weinstein, and which was published in the New England Journal of Medicine, actually kind of set everything straight. Okay, and this was a multi-center North American study. Okay, with all the big centers where scoliosis treatment was being done, patients were included. Very, very strict criteria for inclusion. And what is clinical equipoise? So basically, when there is genuine uncertainty about which treatment option is superior in the professional community. So in this case, it was whether observation is going to help or only bracing, or bracing going to help. Okay. And these were the 2 arms. Now, this is actually the top of the sort of, if you look at the evidence pathway, RCT. Not very easy to do RCT because you're basically telling the patient and the family that I'm not going to decide what I think is right for you, but you're going to be put in a study and your future is going to be determined by whatever happens. So not very easy. If any of us have to go into it, not many people will agree to it. And the goal of the study was, because of the improved research design to randomize to eliminate any bias, and the outcome was determined independently. So it was not at the center; it was sent blinded, and then it was checked there. and it was multi-center, and they did a effect size, so very strong statistical a priori analysis. Okay, and they looked at the quality of life measures, etc. also. So what is PICO? So this was a patient population who were AIS patients 10 to 15 years, reserved to COP 20 to 40, strict inclusion criteria. What is the intervention? TLSO brace. So either Boston, Wilmington, a proper TLSO brace. What is the control? Observation. So the control arm was observation. And what is the outcome? Outcome progression to a surgical threshold. So if the curve went to about 45 degrees, it was surgery, and then that was failure of treatment. And this is just to show you the entire chart of how it was done. And who basically agreed to randomize, not randomize. Okay. And there were 242 patients who were included. Okay. Out of this, 116 underwent randomization and 126 chose the treatment. And in the primary analysis, basically they found that the bracing was far more effective, 72%, okay, compared to observation, with the odds ratio of 1.93. And in the intention to treat analysis, again, it was 75%, okay, with the odds ratio of 4%. So the bracing was almost twice as likely to succeed than observation. And this was the brace dose response relationship. So based on the number of hours, so why do we say that you wear the brace for at least 16 hours? Because of this graph. This graph actually tells you that if the brace is worn for 16 hours, then it's going to be a 90% success rate. If you wear it for 6 hours, it's a 40% success rate. If you wear it for 12 hours, it's around a 70% success rate. This is why we say what we say about number of hours you want to wear the brace. Okay. So the strength of this study was it was a RCT, it was a multi-center trial, it was independently funded. It was not funded by any company. Okay, it was funded by the NIH, and it was adequately powered. And this is the take-home message. So bracing works if there are proper indications, if there is correct counseling of patients, if the bracing technique is right, if you do a check X-ray, and if you comply with the brace wear for 16 to 20 hours, and you continue till skeletal maturity or reserve 4, and then you wean the brace. And if we go back to who was the most influential author of this 20th century, it is Weinstein. For this century and also for the last, because probably the best natural history study on scoliosis is also done by him in Iowa. Okay, thank you.
You make a conscious effort to learn how to talk to her. See, this.
Himself said that there is some big program that a occupational therapist has to undergo to make a brace adequate. So then in that case, how have you been able to overcome that, number one? And secondly, the Western literature also criticizes bracing for the simple reason, as you said, 16 to 20 hours of bracing which is required. So in a tropical country like India, how does that hold true?
And it's how invested the patient is. It's how you counsel. Now, if you counsel the patient is going to work, they will believe you. If you tell them, no, I don't think it works, they're not going to it's how you are invested in it and how the patient is invested in it and how the orthotist is. It's a combination and it needs the support of a system. I do agree that, everybody doesn't make a good brace, but there are people available who locally are able to make good braces and who will sort of see that things are sorted out and minor adjustments, etc., can be made. But if you have a patient and that patient can get through their skeletal maturity without any scar or without any fusion or without any VPT or any procedure, and they are balanced and flexible at maturity, then obviously there cannot be a better treatment.
No, I agree that.
But it is but also I will tell you, it is how we are predisposed in our minds. Are we predisposed to giving conservative treatment a chance, or are we, as surgeons, it's also where we fit in the. See, all surgeons are not the same. There are some surgeons who will find a reason to operate, and there are some surgeons who will find a reason to conserve. Now, where you fit in that is how you will counsel your patients. But there is always a way to find a way which is effective if you are believing in it.
No, I agree completely that a surgery is always fraught with its own risks. But the fact is that the accessibility, according like we are seeing one center of Vadia, probably, but then if bracing as per the studies was so you know can be a game changer for scoliosis early if applied early and correctly. We've not been able to apply it on a mass scale. I think the reason is lack of unavailability of having good.
So basically, I think
there's a screening problem.
The biggest problem in our country is that by the time patients come to the doctor, they are already beyond the scope of bracing. And this is because of absence of scoliosis screening programs in our schools. That is one. And of course, the second point that you genuinely mentioned is the proper type of brace per child. It has to be tailor-made. It is not that one size fits all. It is not that one ready-made brace will work for every kid, because there are certain pressure points that have to be worked upon and they have to change as the child grows. The brace may become tight or the curve may become supple, and that's why it will need little more pressure. So yes, a right type of brace to be made, applied at the right time, worn for the right number of hours till the skeletal maturity is achieved is the success of bracing. And that is why, despite being an effective method, because of so many ifs attached to it, it has not become widespread. But the whole idea of this talk is to bring forward to you that now going forward, with more and more parents being aware, spine picking up its pace, you are going to be seeing more kids with scoliosis at an early stage. There are many schools where their physical examination and PE has become a very important subject and topic of thing. So you are going to be seeing in your own districts, hometowns, more kids with non-surgery magnitude of the scoliosis at an early age. And if you know what tricks work, bracing will really prove efficacious. So I'm sure this is the message that is going to percolate out. While the next talk comes up.
Yeah, till what time the bracing should be continued? Like what's that what's that skeletal maturity?
Skeletal
Like
maturity.
what's that?
18. So 18 or based on what is the reserve. So if the patient has got a reserve 5. So
Reserve 5. And how to wean it? Like
So usually we sort of start removing it in the day, keep the night time on because night is easy to wear. So basically you will go from 16 to 12 to 8 and then.
that means it's either 18 years of age or
Up to 18.
reserve.
So basically you want to hold the curve. So go to and read Weinstein's study, 1986 spine. It is on the natural history of scoliosis, which have patients followed for 30 years and 40 years. 40-year follow-up. Okay, probably one of the longest follow-ups in a native Iowa population, where they actually looked at what happened to the curve if it went above a particular degree. Based on that, you want to basically control the curve below 40 for a thoracic and below 30 for a lumbar. If you are able to achieve that, then the progression will not be. Otherwise, it's 1 degree a year. Once it crosses that, it's 1 degree a year, and that is then a problem. Okay.
Thank you, Arjun. So Arjun is here. So are other faculty members. Please catch them. I'm sure there are plenty of questions that you have. You can put it on the group also if you have a specific question. A respective faculty member, just tag them and they will answer that question. All these faculty members are there on the group also, physically present here also. Please catch hold of them if you have a specific question to be answered. If you cannot, if you feel shy or if you have a question, just write it down on the group and the specific faculty member will take it up from there. Over to you, Ranjit.
Good morning, and thank you, Vishal, Dr. Chadda, and team. Nice to be here again. So you heard all the data from all the experts, what to see, how to see, what to decide, when to plan, etc. Now, once you know all these things, we are in the practice. A lot of it depends upon what you tell the patient. So among all of you, how many of you have exposed to deformity surgeries in your practice or doing training? 1, 2. Oh, good. Most of you. So can one of you put up your hands who has not seen a complication in a deformity surgery? All of you. Have you seen one surgeon, or is it a situation where you are not seen a complication? No. That means deformity surgery means there is complication. Now, what matters is how you set the goals or how you manage yourself when you have a complication. So look at these 3 patients. Do you think that all these 3 patients of AIS needs same kind of counseling? No, right? That means should be some way as to, oops, switch off. I switch the front surgeon and okay, thanks, thank you. So when you have these 3 kind of curves, you have to have different way of counseling. You should set your goals appropriately as to what to expect, because this is the outcome for all these 3 patients. Now look at the patient in the last. Her pre-op and post-op are the same, because look at their post-op pictures. She did not need surgery in spite of the curve. So you should know what to expect and how to counsel a patient when you think about surgery. Now, in counseling, the most important thing is setting realistic expectations. Never about percentage correction, completeness of correction. Set a realistic expectation. Never ever talk about percentages. Patient will ask about percentages, but don't talk percentage, because what we know is we are balancing the spine. How many of you believe that scoliosis for adolescent AIS is a cosmetic surgery? 1, 2, 3. It is the most riskiest cosmetic surgery. You can talk anything to it, but it is ultimately a cosmetic surgery. It's the most riskiest cosmetic surgery. So whenever you make that statement when you offer surgery, be very clear as to what you're setting. You should be always, you heard Dr. Abhay and Dr. Neeraj speak about shoulder symmetry, shoulder imbalance. Remember, you cannot guarantee a shoulder balance post-op. You cannot guarantee it. Never get into that topic when you counsel. If you try to don't, if you ask very clearly, we will try to, but there could be shoulder symmetry. So always be careful about it. And you should always tell what things don't change after surgery. Anybody? What are they? 2 things which don't change after an AIS surgery. What are they? Sorry? Rib hump. Okay, that should be decreased. It should change. Size of the breast and shape of the chest. They don't change. Always be upfront that most of the patients when they come to us in 12 to 15 are post-menarchal or perimenarchal, they will have that breast developed. Tell them your breast shape will not change. Even though they don't ask, I tell. You have to tell. And your chest wall shape will not change, but you will look symmetrical. So be very clear as to what will not change after surgery. Also tell about delayed complications like adding on. We will learn throughout the day as to how to decrease it, but it can happen. We should tell them. And also tell them that in the event, we'll see some cases later in which you might have go to the pelvis. So don't ever tell them that this is your final surgery. This is a surgery for now. Since you're growing, it might grow, it might add on, because I'll show you patients where I had to go later and my counseling helped me save my back. Delayed shoulder imbalance. Sometimes if a patient has a distal adding on, they will come with not necessarily truncal shift. They'll come with shoulder imbalance. So always tell them this can possible. The most important thing, back pain. This is a question which you will be asked pre-operatively, post-operatively. So anybody has to answer. Does AIS patients have got more incidence of post-op back pain? Anybody? Does AIS patient have got more chances of post-op back pain, or does AIS surgery decrease incidence of back pain? Evidence? Anybody? So it says there is no difference in back pain. You operate or don't operate. So you should never ever make back pain as a reason to operate a deformity surgery, right? Never. It doesn't happen, especially in AIS upper curves. Now, you should always be telling them that we all agree that there's going to be a complication. So you should be telling them that what you will do in the event of an intraoperative IOM alert. So I always tell them that in the event I get an IOM alert, I will be undercorrecting you, taking out the apical screws, all the possible things my patient's family knows before we go to surgery. I tell them this happen, always tell them, even if you have nothing, always tell them that immediately post-operative, they will not walk straight. They will walk with some kind of unsteadiness because all their life they have got compensatory mechanism acting. You're going to take them off compensation, so they will walk with an unsteady gait. Tell them that This is a very important thing we should remember. If you have got large type 5, type 6 curves, where in the lumbar apex, thoracolumbar apex, you do a good correction. Remember, the lumbosacral plexus is getting shifted. Your apex is getting translated. We all get apical translation. You might not have an IONM alert, but these patients wake up with thigh pain or thigh weakness. They have a kind of neuropraxia which is not picked up in your ION alert unless you do a root stimulation, which we all don't do. So always tell them that. Always tell them that in a type 5, type 6, your post-op, you'll be having a lot of abdominal dyspepsia. You'll take time to settle because they might even develop abdominal compartment syndrome. So remember all this, tell them, because once they know it, they accept it. If they don't know it, they will be concerned post-op. Tell them this thigh weakness is something which I tell them, which I have seen nearly happens to 50% of my patients. But they all recover. They all recover. Nothing stays permanent, but you should tell them. And always this about the concave and convex. Both, there is no incidence. I have seen it equally happen in both concave apex as well as convex apex. So there's no data to it. And in females especially, if you're doing Ponte's osteotomy in the thoracic region, always tell them about periareolar anesthesia. Always tell them because I tell them preoperative, especially in upper thoracic curves. I go to T2, I tell them that there's a possibility that you'll have a bit of, paralysis in your breast. Don't worry. Always tell them preoperative, because the moment you tell them you're setting the goal, doesn't happen, fine, but they'll not eat your head post-op. The most important question, doctor, will my child be normal? What is the answer? What is the answer? Will my child be normal? How would you answer the question? Dr. Arjun, I'm sure you face this very often. How do you answer the question? Babu? Perfectly. That is what always. Always, this is the first thing you should say. What do you mean by normal? Never say that you'll be normal, abnormal. What do you mean by normal? Make them tell what do you mean normal. You should never ever go, this is experience speaking. Always define what is normal. Tell them that yes, your child can do everything like a normal child will do. But remember, a child with a scoliosis is a child with a scoliosis. But your child is a child with a corrected scoliosis. So you tell this, then they bite it. Don't just say, sir, no, they are not normal. They are a child with a corrected scoliosis. Always, these questions have to be expected and answered. I tell them, you have type 5, type 6 curve. Yes, you might not be able to go in for a LSCS under spinal, but you can go for normal labor. Always explain to it. Unless I go to the pelvis, I tell them, no, you can go for normal delivery. My team is very much expert. My gynec OBG team is expert. They manage all these post-op patients of ours with normal delivery. And I already told back pain. Now, next, what Vishal said is speak about safe surgery. Now, what is safe surgery? We all know is the safety of the patient, which we all take care. The second is most important, safety of the surgical team. Now, this looks very superfluous, but remember, you are doing the most risky cosmetic surgery in the world. The most risky cosmetics in the world is a scoliosis surgery, wherein who pays the highest malpractice insurance in the world? Which surgery? Which surgeon pays the highest malpractice insurance in the world? Which specialty, I mean? Sorry? Which specialty pays the highest? General, ortho, cosmetic surgery. Remember, you are a cosmetic surgeon. So cosmetic surgeon pays the highest amount of medical malpractice. Similarly, your safety is very important. Why it says? Because the safety of the surgical team is important, because risk explanation, complication explanation. Unless you tell them pre-operatively something goes wrong, if you have not spoken, you cannot come out. This is very important. Pre-op planning, anesthesia planning, preparing for malignant hyperthermia. Have any of you faced it? MH? So today with so my hospital, when you have this deformity, the previous day, the machine gets totally flushed off all volatile anesthetics. We go totally under TIVA. Still, we have dantrolene in our theater. Dantrolene is very expensive. The most thing is not expense. It has a shelf life of only 12 months. So every 12 months, the entire dantrolene gets thrown from a theater. But they are charged to the patient. Because you have it once, you are gone. Your child, you have one MH, you will not miss it. So we have dantrolene because it's going to 2.5 mg kg. Roughly, a child needs on 30 to 40 mg. It's like 3 vials. So they are charge for every patient. You send them to, because it's always throat. Touch wood, till now we are not faced it, but we are prepared. So always have it. Minimizing blood loss, we all know that. We have all these protocols. This should be standard high dose TXA. We give it 50 mg. Early we should give 100 mg. 50 mg, prepare, repeating antibiotics 4 hours, keeping MAP about 90, especially, don't have to keep your MAP at 90, no, about 90 when you expose. It's wasting blood. Keep it only when you're bound to prior correction. During exposure, I'll keep it like at 60, 70, whatever. And you should have a ION sequence. If your hospital doesn't have an in-house IONM guy, get whoever's coming, talk to him which sequence you want. Don't just give it to his sequence. You should do it after each screw, each maneuver, asking for the run. You should take, if not, they have a system of sitting the phone and chatting, You'll keep on running, but they will not tell you. When you ask, they'll say, "Arey sir, abhi data chala gaya." No. Every sequence, keep him under hold. You're paying him for it. Now, this is a protocol which you should do. So, informed consent. I'm sure that all of you have all these things. This should be there in your consent. Consent, my deformity consent has these points mentioned that there will be shoulder asymmetry, there might be residual rib hump, there'll be deficit. We all always consent that. Then I tell them that if I get INM loose, I will reverse you. So this is all the routine. You should have a checklist. No surgery in spine is complete without a pre-op checklist. So all this checklist, all the things about, you can take a picture if you want. I always, even today, tell my patient that in the event you have an alert, I will do a wake-up test. So all patients get explained by the wake-up test, not by me, by the anesthetist, because he is the person going to give the wake-up, not me. So always give whistle and always check all these things availability. And if your surgical team is not used to doing deformity regularly, print the surgical steps, give to your scrub nurse at least 24 to 48 hours prior. I write this, I used to do it when I started off. All my scrub nurse, floor nurse, all used to know that what are the steps. Just print it, whatever you want, what you want, just write it down, give it to them, because you and they are on the same page when you start. On the day of surgery, make sure you have all these, checklist again, checklist. So nothing, this is systematic surgery. What do you think about this? What, any catch in this case, Dr. Guru? I'd like to explain opinion in this case. So she's a 13-year-old post-menarchal child who came to me like this. Yeah, there is. Okay, this is the. Yeah, so this is a lumbosacral hemivertebra. So what would you do? Anybody of you? The experts in the front, Dr. Babu, Dr. Basavada, Professor Guru, Dr. Davale. What would you do for this? MRI normal, everything normal, heart, kidney, all completely normal, nothing but for this. Naturally, she wants to be normal. She wants to be normal. Ma'am, she wants to look straight. I don't want to stand like this. I want to sit straight. In the congenital, okay, fine. Yeah, but there is rotation there, right? So I'm showing CT to you that there is no deformity up there. It is just it's a secondary curve just come up. The primary thing is a lumbosacral hemivertebra. It is getting partially corrected, but still there's significant rotation. When she stands with this hump. What would you do? Sorry? So what all will you correct? The hemivertebra and the secondary curve, right? So you will just do the lumbar, you will just do the hemivertebral excision, right? Dr. Guru? Traction, it's not correcting much. Because this is not supposed to be a case to be shown, so I'm just. Okay. Arjun, what would you do? The lumbosacral. Yep. That is right. You felt even okay. So this is what even her question was, that when you correct it, will it become up? So okay, fine. So I went ahead. I did this first. I was overzealous. I corrected the lumbar thoracic. I thought I did a good job. Ultimately, after 1 year, I had to revise her, and then the oblique. It was a hell to do a revision lumbosacral hemio excision. Whatever fusion I had done, I did all the thing what we do in a correction. That's why I got a decent amount correction. She started, but after 1 year, she began to. So she was 13. She TRC closed, was at 5. But the hemio started to progress. I revised her, and ultimately this is it. And then today, I think, what is the difference between her pre and post-op X-ray? Hardly anything, right? She was standing like this. After 2 years, she started like this. No. She has no. I mean, I have a 2.5 year, 3 year follow-up on right now. So ultimately, she's one of the most unhappiest patient of mine, but she doesn't complain because I told her, I explained to her, and then I looked up literature. The most simple thing is that in a kid in this age, for coronal deformity, don't go to the pelvis. Don't do long segments. They don't tolerate. You can argue saying we do high-grade spondylosis. That is a sagittal deformity. In a pediatric coronal deformity, like I should just done only the lumbosacral part and let alone the thoracic part. Even though I counseled her that is my plan. In drop, I got the flexibility. I went ahead. So such things, even after 20 years, 25 years, you will face it. So thank you very much. Any questions further? Painful. Again, she looks straight, she's okay, but she's unhappy, I know, because she lost her lumbar mobility. So ultimately, with all this, the most thankful surgery is deformity surgery. The most thankful surgery. Most of my long-term follow-ups, people who come and thank me are people with deformities. Because you develop a bond with them. They come with their kids, their grandkids, their kids. The most rewarding spine surgery, because rest all we know, degenerative endoscopy, all are timed surgeries. You are treating that point of time. Afterwards, the pathology progresses. But deformity, you have common sense, you have counseled well, it is a one-time surgery for that patient and that problem, and they stay forever. Remember, I want to end saying that you are doing the most risky cosmetic surgery in the world. Thank you very much. Any questions regarding counseling or risk or deficits, etc.? Just everybody will face a deficit. You have to be prepared. Tell them it will happen. And once it happens, you have your plan B, plan C, plan D. Medico-legally, you expect to have a case against you if you have a deficit. But if you see, they are the ones who go least for malpractice against you, because you have told them very clearly, they know what is to be done. It happens when you don't tell them. You are in the gist to do a surgery, you want to just do it, you tell sab theek ho jayega, kuch nahi hoga, sab theek hoga, then the problem happens. Okay, thank you very much. Back in 5 minutes, we'll be joining back again. And now we'll start the more planning part of it, about how to do the UID, the AIS, the collective evidence, and we have discussed about what is changing the program will do it. That is the also very planning. We'll do more these discussions. We'll do more planning related work. We'll do more interactive with the strategic surgical part. I hope that is okay, but if anybody wants to learn anything specific, the faculty
Recording stopped.
Hello, 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 hello. दीपक, ये वाला पोडियम जरा इसका रिसीवर से चालू कर दो. Hello, 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 hello. Check, check, check. 1, 2, 3. Hey, 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 hey. Check. Test, 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 test. Hello, 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 hello. 1, 2, 3. Hey, check, test, test, test. Hello, 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 hello.
प्रेजेंटेशन मिला ही नहीं। अभी नेक्स्ट प्रेजेंटेशन बोला ना उसने।
और ये इनका 5 नंबर साल इनका भी आया है। हाँ यही है, इसी में मेरा ही है। ये भी मैं हूँ, ये मैं हूँ, ये मैं हूँ। ओके, ये आ गया ना आपके पास? हाँ ये आ गया। Settle down, guys. We are moving into far more interesting and contentious topic about scoliosis, and it is all about choosing the right levels of fusion. I think just a couple of days ago, one of my friend was telling me about this story that a young surgeon who's equipped with robot, navigation, and O-arm, he walked into the OT of Dr. Bhavuk Garg, where he was doing a complex scoli, and asked him only one simple question. Putting in screws is so easy. Anybody can do it, and we to have robot and navigation, and we can easily put in screws. तुम तो बस इतना बता दो कि कहां से कहां तक फ्यूज करना है. And this one simple question of from where to fuse and where to end is the single most contentious topic, requiring more natural intelligence than artificial intelligence, requiring more clinical acumen, and all the summary of data that we saw this morning in the first 5 lectures of how to analyze radiographically, which patients to really fuse in which pattern. And in this session, we'll only be talking about how to make objective decision making about upper instrumented vertebrae and lower instrumented vertebrae. And this is a story. It is not something that has happened in 1 decade or 2. It's a story that has evolved in last 5 decades. The safest and the simplest would be to start in 1960s, when everything was fused way down to L4. That means come what type of curve it is, be it type 1, 2. In fact, there were no classification systems at that time. If there is a bend in the spine, put hooks above, put hooks below to L4, stretch it apart, stretch the scoliosis, balance it, make it stable, put a lot of graft, and the story is over. But the unfortunate side of it was that it was going all the way down to L4 and L5. So what is the harm in there? Why not just might as well make every spine stable? it takes away the essential motion segments. And that one single line, how to save these precious motion segments and yet give a stable spine, is the story that has unfolded in last 5 decades. So today, despite the goals of surgery remaining the same to have a balanced, stable spine, one line that has got added upon is how to save the motion segments while achieving the primary goal of surgery. For example, if you fuse one segment long, what is the harm? There is, because you're taking away the motion. But if you make that decision suboptimal and fuse one segment short of that strategic LIV, you will probably be leading to a far more unsatisfied patient. And believe me, the one thing that creates most amount of unsatisfied patients is the choice of levels. A wrong choice of level is the reason for add-on decompensations in the LIV level. In a UIV level, if you choose the wrong level, shoulder imbalance, patient will have to live with it forever. All the revision surgeries, most of the revision surgeries, if not all, are related to poor selection of UIV or LIV. And this story, as I said, has evolved over last 5 decades. Can I have, like for this particular patient, it may broadly look to you that we have to fuse from T4 to L2. Anyone who differs from this plan of T4 to L2? Anyone who differs T4 to L2? Show of hand, who differs? T4 to L2. That's T4, that's L2. Anyone who differs there? Bhavuk differs? L1. So LIV, we have started pairing levels L1, T4 to L1. Correct? Everyone agrees? Let me have a show of hand from all of you who agrees. Who agrees to T4 to L1? Okay, wonderful. So we go ahead and do this surgery, and that's what happens. That's what happens. Why did this happen? Did the surgery go wrong? Beautifully put screws without a robot, just using clinical acumen in the most rotated spine. But what has gone wrong is that now the shoulder on the opposite side is up, and this patient will have to live with it. What went wrong is a poor selection of UIV. And this comes from clinical examination, history taking, and of course, radiological evaluation. This evolution has happened from fusion into stable zone, like Dr. Abhay this morning mentioned, that whichever vertebrae lies in the stable zone becomes your anchor points, up and down. No matter how the curve is tilted here and there, but your UIV is the first stable zone vertebrae at top and the last stable zone vertebrae at the bottom. That was the stable zone criteria. And this was in the Harrington era. Nash and Moe added things to it. Kings came up with a classification and concept of stable vertebrae. Rather than stable zone, stable vertebrae. Now, stable zone was the long fusion to give a stable spine. Stable vertebrae becoming your LIV, lower instrumented vertebrae. It started saving levels, unfortunately, not to the tune of more than one vertebrae. Because invariably, stable zone starts from stable vertebrae. So this didn't make significant difference, but yes, was saving a level or two in most cases. But more often than not, the LIV or the lower instrumented vertebrae still landed on L3, more often on L4. Again, creating bigger problems and long fusions. CSVL, the introduction of central sacral vertebral line and the concepts of Lenke have changed these landmarks now. Now we know which curve is structural, definitely needing fusion, and which curve is non-structural because of these modifiers available. So on one hand, we had stable zone and rotation as the criteria earlier. Then came the chances of selectivity, which ones to fuse and which ones to leave based on CSVL. But now we are moving ahead to another concept of how to save those levels, how to preserve one or two more motion segments by leaving behind those which are not essential to be a part of the construct. And this concept is the touchability. This is about the dynamic involvement of it. Touchability is something that has recently taken a lot of attention, what we also commonly call last touch to vertebrae. It doesn't mean that these concepts are out of vogue, no. Now it has become a comprehensive understanding. Now you have to analyze all these factors together to analyze which vertebrae can be left rather than which vertebrae can be included into the construct. And each landmark that we are just speaking, and probably in the next few talks, we are going to unfold more of these landmarks. We heard Dr. Abhay speaking about end vertebrae. It remains a fixed entity. We also heard about stable vertebrae being a construct where LIV will be stable. Patients will not have decompensation, but leaving behind a longer fusion. But with the addition of a concept of how to save motion segments, these concepts have come into vogue. Last touch vertebrae and last substantially touch vertebrae. More is going to unfold in days to come. Now, on one hand, the goal of surgery remains the same. Like Ranjit mentioned, we need a stable, balanced spine. We also need to preserve the motion, because lumbar segments preserved is not only related to less back pain, but also more functional and better outcome in these patients. And that should be the goal of the surgery, added with a balanced and stable spine, where a head is centered on the pelvis, but also leaving behind as many lumbar segments as possible. In the next 5 talks, right from Professor Kwan's talk next upcoming to Dr. Sameer Dalvi's last talk, is all about how to instrument less, how to do less fusion, and how to get better correction, how to have a stable spine while preserving the motion segments, not including the lumbar segment, which are not required to be in the construct. And that is the evolution that has happened. So the goals of surgery have changed from not only having a head on the sacrum, which is a centralized spine, but also to leave behind a flexible and moving spine. And as I mentioned, the Lenke's classification systems gave us this idea of which curves are structural. This was the beginning of saving of levels. This was the beginning where the level saving or motion preservation became the first concept. We are going to be hearing about selective fusion, but this was the beginning of motion preservation in scoliosis surgery. Non-structural curves, try and save them, do not fuse them unless the criteria. That means there are certain non-structural curves which will still need to be fused, but most of the non-structural curves can be left behind, and that became the principle of selective fusion in scoliosis. This is just one case example how a double looking curve can be fused to only selectively leaving behind a functional lumbar spine. Now Lenke changed this question from where to fuse to what must be fused and what can be left. And there are criteria to it. There are criteria of ratios. They may sound complex, but as I said, these are those initial data points that on a blank sheet, if you make, you'll easily be able to get when will selective fusion work and when will it not, because it doesn't work always. A shorter fusion is not always a smarter fusion. In fact, 15% of times they may fail. And this failure is not because of a surgical technique. It is because of poor selection of these data points in which patients can selective fusion not be done. Like in this particular case example, where a LIV as per selective fusion criteria was D12, but it failed in no time. So that means there are certain factors which are working beyond Lenke's classification systems and data points, which are also leading to failures. And this was the concept that introduced that last touch vertebrae, if it is not accounted in the fusion, in selective fusion cases also, the chances of fusion are there. And this became one of the concepts in the choice of LIV. Unfortunately, it was not foolproof. Even when you go to the last touch vertebrae, which means where does the line just touch the vertebrae, that is last touch vertebrae. If you stand by there, there are still chances that it may fail. And these are some case examples where add-on and decompensation happen despite you choosing a selective fusion, preserving motion, but stopping at last touch vertebrae because it was not substantially touched, giving another concept of last substantially touched vertebrae, which again, in the coming talks, you're going to be hearing it more and more. And now the concept is that last substantially touched vertebrae, which is substantial means at least touching the perineum, not just the corner. So substantially touching vertebrae has the new concept where you should minimum fuse. That's the area where your LIV should be minimum there. If you see the stable is at L3, whereas the last substantial is at L2, and L1 is last touch. But if you go for pure selective fusion, it is standing at D12. So this is a concept that has evolved more and more. And last substantially touched vertebrae just was one case example. Unfortunately, there are more factors to evolve, which is the 5th and the 6th dimension, because even LSTV is not foolproof if you don't consider the below the LSTV disc angulation and the rotation of the choice of LSTV. So these are the 5th and 6th dimensions which you must consider when planning it in your. If you have made a decision that this X vertebrae is my last instrumented vertebrae, the disc below has to be checked. the rotation of the LIV has to be checked, because if you don't pay attention to these two parameters, and of course the one AL and R variance, which will again be discussed in the subsequent talks, the idea is to bring forward to you how from stable zone to preservation of motion to selective fusion, how they can still fail if you don't consider these all parameters in there. So today, to summarize, it is not about which vertebrae to stop upon, but the concept is which vertebrae to trust upon to consider it as a last instrumented vertebrae. That's the algorithm. Please take a photograph. I'm also going to be sharing with you. That's the algorithm that we have been following. And we are also going to be validating this in our coming up study. We are working on it to validate this. It's a simple algorithm. We just mentioned simple things. Start with leg classification, find out which is structural and not. If it is structural, both are structural fused, both, but if it is non-structural, lower one selective fusion, and in a selective fusion, these are the parameters to be paid attention to in patient where you can save levels. So this is something that is very, very important. And the fifth and sixth dimension, which is the LIV tilt, rotation, and the disc wedging below the LIV also takes into consideration. Thank you, everyone. Any questions while we check it? So we take Dr. Bhavu's talk first, and then we will have Dr. Kwan's talk. Dr. Kwan is going to be talking about UIV selection and shoulder balance, while I unfortunately touched upon the slides Dr. Bhavu is going to be speaking about in type B and C curves. Type B and C curves are the ones where CSVL is touching the pedicle or is lying away from the pedicle. Those are the double curves which may or may not be structural, the lower compensatory curve. Dr. Abhay mentioned in the morning to you that sometimes the compensatory curve, which takes over the main curve to balance the spine naturally, may become structural. Sometimes it may remain non-structural, which Lenki has described. How do we deal with those type B and C curves, Dr. Bhavu?
Thank you, Vishal. So I think the last algorithm which Vishal showed is actually the same, holds true for every curve, whether it's 1B or 1C. So I will just cover those things. Not moving.
Yeah.
So these are the Lenke curves, but they are not similar, and not all classification they serve the same purpose. So basic question remains, which curve to fuse, and if there are two curves, can we leave one, and we have to decide the fusion level. So major curve is always included in the fusion, and the minor curve is included in the fusion if they are structural. So this, I think, we are all clear from the previous talks. And the distal level LIV remains the much more controversial topic, and experienced surgeons, they break all the rules. And the same thing, actually, we published that how the existing classification guide us, and we could see that usually we don't follow, the Lenke, PUMC, and all those classification. Usually we rely on our instincts and our own experience in deciding the LIV. So the central dilemma remains that if we are fusing every additional level, it creates the another problem. So if we are too proximal, then there are problems of distal adding on, the translation, residual progression, and all those things. If we are too distal, then we are leaving the lumbar motion segments. So the LIV remains a post-alignment problem. It's not the how to choose during this before the surgery, but actually the LIV selection remains the post-operative alignment prediction problem. All we have discussed the ABC type. I'm not going to detail, but as we move from A to C, actually we are moving towards selecting a landmark rather than we are going towards the geometry. So basically the curve is becoming more rigid if we are moving from A to C, and that's how our selection of the LIV differs from these A to C. This we have all discussed. Vishal has discussed this thing. So regarding the type A, the landmarks may be enough. In type B, we have to assess the landmark as well as flexibility of the curve. So that becomes very important, that how flexible is the B curve. And in C, we have to see landmark, flexibility, how much translation is of the apical vertebra from the CSVL. We have to also see what is the apex of the curve, and we have to also see the distal disc and how the curve is going to behave after you have fused to the LIV. That how much you have to predict that how much the distal curve is going to behave after the fusion. So as the lumbar curve becomes more displaced, the LIV selection becomes much more dependent on the geometry of the curve rather than on the landmark itself. And if you look at the literature, there are so many, the types and the, the methods have been given to select the LIV. That means nothing works. Nothing is the ideal. So before choosing the LIV, you have to basically classify the problem. Which curve you are going to fuse selectively, if you can. Is the unfused lumbar curve is truly flexible, which we see on the bending films. Beware that if the proximal curve is large, then this may disguise the flexibility. And as Kshitish told in the morning, that traction films, they are much more better indicator of flexibility in those curves. Where is the lumbar apex related to the CSVL? What happens to lumbar translation, rotation, and disc wedging on the bending films? Where do all these parameters, the end vertebra, stable vertebra, last touch vertebra, the lumbar apex vertebra, they are related to each other? And will the distal disc remain, below the proposed LIV? How much and how will it behave after the fusion? So selective thoracic fusion, I'm not going to detail, but the Lenke 1C is not mandatory that we have to go for lumbar fusion. And selective thoracic fusion is more likely to behave when the main thoracic curve is more structural. And Vishal told you about the different criteria, about the clinical criteria and the radiological criteria, this thing. You have to think in terms of the deformity and flexibility relationship. So if we see this table, if the thoracolumbar curve is large and on bending it is markedly reducing, then compensatory curve is likely to remodel. If the thoracolumbar curve is large, but on bending it still remains large, that means flexibility is poor. So lumbar curve may not follow the thoracic correction. And if the lumbar translation is again marked on bending film, it falls substantially towards the midline. That means it is flexible and it is more favorable for the selective thoracic fusion. However, if it still persists, then obviously there is a high risk of residual, the coronal deviation. And then you have to choose the LIV after asking yourself that how much the unfused lumbar spine going to behave after this fusion. So touched vertebra, Vishal told you that about the last substantial touch vertebra, but again it is not magical. People have shown that even if you go up to the LSTV and the LTV, and if you are going distal to the LIV, then this is not the panacea. The evidence still supports the touch vertebra as a useful tool, but is not an absolute rule. So Lenke 2C, again, it becomes more challenging because there is a proximal structural curve also. So when you are correcting these two curves, then again you have to see that how much the proximal thoracic curve correction strategy and the main thoracic curve strategy is going to translate into the lumbar curve. And this becomes very important. And then again, if you're just going up to the safer, shorter version, then probably you are going to miss the lumbar curve and you are going to end up with problem. So again, in these cases, the safest is going to up to the LSTV or the stable vertebra. So when the lumbar curve is structural, again, you have to go up to LSTV is the safest one. But still, there are now there are certain papers where they are showing that lumbar apical vertebra can also be taken as the LIV. Now this is very important, and this is again a challenging issue because we have been taught initially that you should not stop at the apex of the curve. But now the things are changing. In type C curves, the lumbar apical vertebra is also coming up as a very good endpoint if it is a flexible curve. So again, this we just discussed. So if the LIV is above the lumbar apical vertebra, then obviously the motion preservation is highest, but the chance of lumbar deviation is very very high. If your LIV is at the lumbar apical vertebra, then again motion preservation is there and your lumbar deviation is improved. But if your LIV, you are going below the LIV, then obviously your the lumbar deviation is the best, but the motion preservation is least in these cases. So distal disc, again, as Vishal told you, it is very important to look at the tilt of the distal vertebra, distal disc on the bending films, that how the distal disc is going to behave after you have this thing. The more important thing is if any vertebra is tilted more than 15 degree, you should not stop at that vertebra. So this is just to show you decision matrix. If it is a 1B and the lumbar curve is flexible, then you can stop at LSTV or the touch vertebra. If 1C is there with flexibility, then again you can just go for the selective thoracic fusion. If there's a 1C with the rigid curve, In those cases, again, you have to go for a distal endpoint, and LSTV is a better option. In 2C, you have to choose that how the proximal and the main thoracic curve is going to behave, translate into the lumbar curve. And again, going distally is always a better option. 3C and 6C, you have to choose between the lumbar apical vertebra or the LSTV. 5C, and if the last end vertebra is before L3, then again you can individualize and you can stop at L3. If it is LEV is last end vertebra is the L4, then do not go for automatically go for L5. You can stop at L4 depending upon the rotation and the sagittal stable vertebra. So the important thing is that you have to choose the best vertebra. So as a simple rule, I go for LSTV. If you are a high volume surgeon, you don't want variability harm your patient, then LSTV is the safest and the most best, the most the thoughtful choice. So LSTV is when the CSVL is touching the medial border of the pedicle, while the LTV is the last touch vertebra is where the CSVL is just touching the vertebra. So LSTV remains the most thoughtful and the most safe choice. Just to show you some examples, this is again, I'm not sure whether it is coming clearly or not. This is again a large curve, and you can see that the LSTV you have chosen, and this is giving you good results after 3 years follow-up. This is a 5C curve, and again you can see that we had to. This is a type 6 curve, and again you can see that LSTV we chose, and there is so much tilt. You can see here that there's around 20 degrees of tilt of the last this thing. So again, by rotational maneuvers, we could end up at the L5. Again, rotational problems we have to think of. We are just looking at the 2D X-rays, but we have to think that all the scoliosis is a 3D deformity. So this is very important. If you look at this simple X-ray, this looks like very simple, and probably we can plan that we can stop at L1 here as an LIV. But something EOS which we have given us, the EOS actually gives us this view. This is called Da Vinci view. You can see the spine from the top, so you can see that how each and individual vertebra is placed in relation to each other. And if you plot these things, this is just to show you the rotation in relation to the femoral heads. So you can see actually the L1 is one of the most rotated vertebrae. So if you stop at L1, then it is going to fail. That's how the SRS new classification is coming up. This is called the SRS 3D classification, and this is how these vertebral vectors they are placed upon with relation to the femoral heads. I'm not going to detail. But this is just to emphasize that the rotational problems, again, they are very important when you are considering the fusion levels. And this is the L1 was the most resisting, and again we had to go down because if we would have stopped at L1, then it would have failed because L1 was the most rotated vertebra. And this is something which we have started doing it now to save this thing. You can just put a Jamshidi needle into the distal most vertebra, and then you can rotate it. Can we play the video? To save fusion levels, you can actually put a Jamshidi needle distal to your fusion levels, and then you can derotate, and then you can lock your the rod into this screw. That's how you can save actually the fusion levels. To summarize, the LIV is not a vertebral landmark. It's a biomechanical endpoint where your fused spine is going to meet an unfused spine, that how the unfused spine is going to be in harmony with the fused spine for the rest of the life of the patient. So again, you have to be very careful. You have to look at the flexibility. You have to look at the translation. You have to look at the distal geometry, especially when you're talking about the 1C curves. And your judgment should integrate all these variables when you're planning this decision. So where should we stop? Where the spine is most likely to remain balanced after your correction. Thank you.
Thank you, Dr. Brown. Point of LIV remains the most important. We are setting up your because it is. Point of LIV remains the most important parameter. So let us hear from all the stalwarts here. Dr. Abhay, what is that? What is your commonest LIV for type 1A curves? Like, what are the factors that you consider for type 1A curves? And when C curves come, how does it change your thinking?
Yeah. So I think I want to say this, that if you choose LSTV or SV as your LIV, you're not going to make too much of a, error. And if your SV turns out to be L3, you can safely stop at L3 and not worry about saving levels, because your final outcome is not going to be any worse than people going to L2 or L1. So I think that's a good takeaway message for us beginners, that if L3 is following all the criteria of SV, then you should just use it as LIV and finish off. It's when there's a lumbar curve that's significant, like a type C lanky, that's when the problems begin. And there again, my recommendation would be I would go to L4 rather than try to do a STV, because we do 10 scoliosis in a year. We don't do 50 in a year like Lenky does. So our capacity of executing a good selective thoracic fusion is limited. And we'd rather have a longer level of fusion and a problem 20 years later than a decompensation at 6 months.
We have been learning from you of when in doubtful situations go long. Is that fundamental that you follow still, or you still choose selective fusion in certain cases, and what is your approach for certain?
No, I think when in doubt go long is definitely not me. I don't know who taught you that. But the point is that no. The point is that, see, I primarily use King. So Lenky is actually a lot of King with a few added complicated things. But King has made it very simple, and the principles still remain the same. So I use a combination of King and bending films or traction films to look at the correctability to select my levels. When there is a choice of a selective fusion, I would do a selective fusion. So if it's a type 2 King, which means it's a C modifier, then I would clearly look at the lumbar curve and see that if I can spare it. And then I would do. The only thing is that the mistake people make, why STF has got a bad name, is that people don't do a proper STF. They always feel, let me add one more. And that one more which they've added down at the LIV is what screws it up, because you actually enter the lumbar curve and then you rotate the lumbar curve worse, and then your whole thing gets unbalanced. My thing is that if you're doing a selective thoracic fusion, then do a selective thoracic fusion. It may just look a little weird, right? You may end at T11 or T12, but that will work if you follow the principles, because the lumbar curve will correct.
What is your approach other than what these guys mentioned? How do you look at LIV selection, and what makes you worried? What are the factors that you start getting worried on an X-ray? That, oh, no, this is not the vertebra, I want to go long. That is probably.
So number one, I'm not a big fan of STFs, because when I discuss with the patient, when you look at the criteria as all that, it says patient and surgeon willingness for a revision. I'm not willing for a revision, neither the patient. So I will try to go a bit more longer. Having said that, in a typical AIS, other than type 5 and 6, you rarely have to go below L3. So it's safe, whatever L3, L2 kya farak padta hai? L3, L4, when you go before L4, yes, it matters. So I try and limit it whenever possible before L4. I'll do all the maneuvers possible to make sure that I can stop at L4, including derotation and all that. But what really matters to me is that some of them look very typical AIS to us, all the parameters, but the curve looks too huge. They actually are not AIS. That, if you understand, those are the ones in which my hands have decompensated. You get everything immediately right. In the long term, they decompensate. Having said that, yes, well, like what Dr. Abhay said, than bothering about a region change longer, right now get it balanced. That is better.
I think 2 points that Ranjit highlighted is L2, L3, क्या फर्क पड़ता है? नीरज, फर्क पड़ता है क्या?
No, I think anything above L3 doesn't make much difference. So I think it is safer to go on L3 than stopping at L2 and having an adding on. The huge difference happens if you are saving 3, 4, right? So I think, you should try to do release, try to make L4 stable intraoperatively. If you can save one level, I guess, that makes a lot of difference. Ending it at 2 or 3 doesn't make much difference.
In your counseling, if you have planned to do selective thoracic fusion to save levels, Ranjit mentioned about the patient willingness. What is the counseling that all of us should mandatorily document when choosing a STF in counseling with the patient?
Adding on and possible revision.
No, so that's the thing. My experience is different from Ranjit's. When I speak to the patient, they are actually willing for a revision. Means what I tell them is, I'm not telling them I'm going to revise you. I said I'm going to spare your lumbar spine, your flexibility, your everything will be better. But there is a chance that this may extend and we may have to go. as opposed to fusing the lumbar spine today. So you want to do that today, or you want to give it a chance? And then other page,
But this whole idea that the STFs you have to revise,
no, I've
is
never
a
had
wrong,
to.
huh? We've never had to.
I've actually never had to.
Correct.
To be very honest.
Exactly.
I think the ball is set. Selective thoracic fusion does works. It does works, and you should try to save the motion segments. There are principles laid down to choose the LIV. Dr. Bhavuk beautifully highlighted them. Even in patients with type B and C, you can still save those levels. How to save those levels? When does STF works? And when you are doing STF, Dr. Samir highlighted, don't just itch yourself to go one segment. Kya farak padta hai? Let's hear from Kshitij. When to do selective?
Yeah.
I actually want to emphasize that because that is the biggest mistake you make. The thing is that once you decide you are going to do something, then do it. Don't dawdle. Means you are doing selective thoracic. No, you decided to end at T12 or L1 wherever. You end there. On table, don't think L2 is better because that is not selective. Then you do full, go to L4. So either do selective thoracic fusion or fuse both curves. Don't do the middle because that's where it fails.
Landing in the apex of the lower curve, even if it is non-structural, you go to the apex of that curve, it will become add-on.
Two things I want to add based upon my experience, that most of the times we decide about the selective thoracic fusion on X-rays, but clinical examination is very, very important. And if you see that there is a lumbar crease when the patient is standing, STF is most likely to fail in those cases. So lumbar crease is a contraindication for STF in my practice, even if the radiological parameters are saying yes. The other thing is that when you make the patient prone under anesthesia, spine becomes quite flexible and it looks that you can stop short. But don't change your LIV based upon the X-rays intra-op. It has to be decided pre-op. Whatever you have decided on the basis of pre-operative, standing and the bending films, go for that. Don't change your plan on the OT table.
I think this summarizes these first two talks. Save motion segments. Try and save yourself from going to L4, but it is not a crime to go to L4 if it needs to be. There are criteria for it. And try to do selective thoracic fusion to save motion segments. How and when to do it and when not to do it, Kshitij Chaudhary.
So this STF business is quite controversial topic if you look in the literature. Over the years, the whole point of the Lenki classification when it was published, if you read the original paper, it was not published as a classification. It was published as a retrospective series to prove the teachings of Mo. Because Mo taught that, okay, not everything needs to go to L4. And they kind of looked at, okay, if we follow Mo's principles, then does it work? And that's how they kind of categorized the curves. And eventually it became the Lenki classification, which was not proposed as a Lenki classification. And then after that, the controversy started that who decides to do selective versus doing the whole business. So it's very difficult to cover that in a short time. We are going to have another course next month, which is a more dedicated course for AIS. So I have to plug it since everybody is here. Dr. Samir Dalvi is the president of Bombay Bombay Orthopaedic Society. And the course is organized in such, and the same guys are the faculty, Arjun, Bhavuk and all. So where we are going to have 3 weeks of a pre-course where we'll have online lectures, which are recorded lectures, which you can listen to at your own pace, at your own time. So we'll have like 6 talks in a week for you to listen at your own pace, ask questions in Google Classroom. Faculty will answer your questions. We'll have some case discussions online. And then for 2 days on 18th September and 19th September, we are going to have in-person meeting where there are only place for 20 people. So whoever registers first, we'll have like small group discussions for level selection, all this controversy about selective thoracic fusion, corrective maneuvers, and all that sort of a thing. And one day is a cadaver course. It's bioskills specific for deformity. So all those of you who are interested kind of can join that course where we'll have more such talks. So coming back to selective thoracic fusion. So I have put the boss's case, right? This is Lenki's case. from the paper 2003 spine. So you can see this is a double curve. Thoracic curve is 88 degrees. It corrects to 56 degrees. Lumbar curve is 64 degrees, corrects to 30 degrees. Very interesting case. This is a 3C curve. Classification tells you that, okay, big curves both sides. Ranjit will say 64-degree curve, big curve, you know. Lenki himself, 3C, Lenki does selective thoracic fusion, right? Doesn't go all the way down. So the lower instrumented vertebra is the stable vertebra of the thoracic curve. The vertebra that is most closely bisected is the end of the vertebra, which is this, which is L1. Nice balance, 2-year follow-up. Lumbar curve has spontaneously corrected, you know, his own case. So he's broken his own rule, right? So this is very often the case. And this was what Dr. Dalvi was talking about, King 1 versus King 2. So my recommendation is, if you really, really want to understand selective thoracic fusion, you need to read the original paper, 1983. So the false double major curves is where the selective thoracic, and a lot of people use this word selective thoracic fusion very loosely. Anything that is in the thoracic spine is selective thoracic fusion. That's not the case. Selective thoracic fusion was meant for a very specific kind of curve where you have two curves and the curves cross the midline. That's the definition. It has to cross the midline. You know, so CSVL, it's cross. The upper one crosses the C7 plumb line. So unless you have two curves which cross the midline, it's not selective thoracic fusion, right? So that's the teaching of John Moe. A mobile lumbar spine is better than a stiff and a straight lumbar spine. And because the King classification, the problem was differentiating this. They did not define that thing about how to clearly say whether the curve crosses the midline or not. The paper just mentions the curve crosses the midline. Now, after that, people understood their own interpretation, whether the curve crosses the midline or not. So they included a lot of King 3, which are the usual King Lenki 1A curves, as even if you have like a B modifier, a slight curve also they considered as King 2 type, right? So that's why the Lenki came up with the B modifier just to differentiate those curves in between. These are the curves in between where the curve is somewhere not crossing the midline, but not like this as well. So this was the B modifier. Actually, if you look at the Lenki classification, the B modifier does not add anything to the decision making of the choice of area of selection of fusion. So B modifier curves are almost always treated like A modifier curves. It's not never a selective, it's always a selective fusion. This is not, lumbar spine is never included in the fusion for a B modifier curve. It's always the C modifier curve. So that brings, and also in the Lenki classification, like Bhavuk said, clinical part is not considered. So selective thoracic fusion is for C modifier curves only. It doesn't apply to A modifier curve. It does not apply to B modifier curve. So you have all these kinds of C modifier curves. 1C, 2C, 3C, 4C would be selective thoracic fusion. 5C, 6C, you may consider a selective lumbar fusion and not consider thoracic into the fusion. So that we will discard. We'll see 1C, 2C, 3C, and 4C. So your question to ask is selective thoracic fusion possible, right? So we will see, like these are the 4 criteria that you would use. One is radiographic, second is clinical examination, which Bhavuk just said. For that you need a scoliometer, because you need to measure how much of rotation the trunk has caused in the lumbar spine versus the thoracic spine. So the new classification, you will get this as the Da Vinci view. I don't know that. I think that's the next step. We'll discuss in the course next month. But if you don't understand the 3D classification, a good proxy for understanding the transverse plane is a clinical examination. Because like I said in the first talk in the morning, that assessing the transverse plane in the AP X-ray is extremely unreliable. The transverse plane assessment is on an Adams forward bending test. The third thing to consider is the maturity. And the fourth is the expectation of the patient, whether they are going to like that lumbar crease or not, whether they are going to have the residual cosmetic problem or not. So the radiographic criteria are curve basically, where how much is the thoracic curve with respect to the lumbar curve. So for selective thoracic fusion, the thoracic curve is about 20% more than the lumbar curve. So that's why the ratio is 1.2. This is kind of an arbit thing. This is Lenke's criteria, but in general, the thoracic has to be larger than the lumbar curve. The apical vertebral translation of the thoracic has to be more than the lumbar. So here you see from the C7 plumb line, the thoracic apex is 8 centimeter away, whereas the lumbar is 3 centimeter away. Thoracic is more translated than the lumbar. So again, in this kind of a situation, selective is possible. If this was reverse, it's not a good idea to do that, right? Now, lateral X-ray, thoracolumbar kyphosis should not be there. If that is there, then again, selective thoracic fusion is out. Now, this is flexibility index, how much the thoracic curve bends with respect to the lumbar spine. So how do you calculate? Percentage correction. So thoracic curve, percentage correction is from 64, lumbar curve, percentage correction 64 to 30 degree. So that is about 53%, and thoracic is 88 degree to 56 degree. That is 36%. So for you to do selective fusion, the lumbar spine has to be much more flexible than the thoracic. If your lumbar spine percentage correction is like that of thoracic or lumbar, usually it is not worse because lumbar spine is much more flexible than thoracic. But let's say if it is like close to each other, then also you should not do a selective thoracic fusion. Then it is clinical examination. So you need to do Adams forward bending test and look at the trunk rotation. So you need to have a scoliometer, and everybody has a scoliometer on their phone because now you can get that angle on the phone itself. So this is 25 degree, this is 7 degree. So that's why this is possible. If these prominences were equal, or if this is more than this, then you can't do a selective thoracic fusion. Right? So like for example, in this patient, you see how much this lumbar prominence is. Thoracic prominence is much lesser. This is more, this is lesser. So in this curve, you cannot do a selective thoracic fusion, even if the lumbar spine is more flexible. The other thing is how the C7 plumb line falls. Look at this patient. The C7 plumb line falls to the left side of the body of the patient. That means that the lumbar curve is causing the decompensation. If the thoracic spine is the reason for the decompensation, usually it is C7 plumb line falls to the right side, correct? So in this situation, selective thoracic fusion is possible. So whenever your decompensations occur to the left side for typical curves, be careful of doing selective thoracic fusion because left side means your lumbar curve is larger than thoracic. That's why the body has shifted to the left side. Then immaturity. The ones who are like Rhesus 0 or 1, be careful because their lumbar spines can progress. Still, you can do a selective thoracic fusion, but sometimes you'll have to brace their lumbar curves until they kind of mature. And then you'll have to individualize because some kids, play sports, they require like a flexible lumbar spine. And like Dr. Dalvi said, that many times when you explain to the patients that way and choose the right fusion levels, you can get a really good outcome. So again, example, 71 degree thoracic bends to 50, lumbar bends from 54 degree, 28 degree, double curves. And then other thing you need to do is not to overcorrect the main thoracic curve. If you overcorrect this, beyond the ability of the lumbar spine to correct, you're going to throw the patient off. Right? So again, this is another such curve. But here you can't. 57 degree, both curves are almost similar. This is 35, this is 22. Becomes a 1C curve, but still you are doing a non-selective fusion because of the size. We will skip this because this is lumbar selective fusion. All right. So I think basic framework is, look at all 1C, 2C, 3C, and 4C curves and see whether you can do a selective thoracic fusion. And there are 4 criteria for, choosing that. Any questions?
Maybe in the rules of selective thoracic fusion type 1C curve.
The lower instrumented vertebra for a selective thoracic fusion has to be the stable vertebra of the upper curve. And that's usually T11 or T12. Sir said that, so remember that. So moment you start going into the lumbar spine for LIV, that's the commonest mistake that is made, and then your selective thoracic fusion is going to fail.
So the same thing for the third time, sir. Like not waffling. When it is T12, फिर भी ठीक है. But believe me, to end at T11 requires guts. But
yeah.
you have to have courage of your conviction to end at T11. Ki bas, it is T11 means it is T11.
No. If you look at the original King's paper, okay, go back, look at original King's paper, look at all the King's 2 they did, okay, and they did with Harrington instrumentation and stopped at 12 or 11. It's extremely common, and not even with pedicle screws. They did it with Harrington instrumentation. So that's what.
Actually, with STF, there is another problem, which is in the hands of these guys who are like more experienced now than me. Because I do a very, like he said, he did it with Harrington. I do a very low implant density and I use hooks, etc. But the newer generation tends to use screws almost at all levels. If you correct one of the mistakes which I've said 3 times or 4 times now is ending too long. But another bigger mistake is correcting too aggressively. Now, if you put screws at all levels, and then if you use even titanium, but then if you use cobalt chrome and you use all the maneuvers you learned, your thoracic curve will correct so well that the lumbar curve cannot compensate. So one of the principles or one of the tenets of doing a selective thoracic fusion is to not overcorrect the thoracic spine. Yeah, to not overcorrect. Now, to willfully undercorrect is not easy. But using the kind of implants which I use, it happens automatically because I do not use that as much implant. I mean, unfortunately, I don't have a talk on posterior, but you would see that I don't use that much implant.
Shoulder balance also. You don't necessarily always go to T2. There are always some hidden non-structural curves above and below. If you are not including those hidden non-structural curves either above or below, make sure that you are under-correcting the main structural curve to the magnitude of the hidden non-structural curve. This line is extremely important because, for example, if the bend of the lumbar spine comes to 15 degrees, from 40 degree to 15 degrees, that means lumbar spine is left out 15 degrees. Now, if you correct the thoracic spine absolutely straight with a bend of 15 degrees at lumbar spine, you'll be thrown off. And same stands true to thoracic spine also, the proximal thoracic curves also. If the proximal thoracic curve on bending is coming to 10 degrees or 12 degrees, which makes it a non-structural and a hidden curve, definitely will not fuse it. So you will have to leave that residual curve in the correction curve. That means the structural curve that you're correcting, you should not bring it to zero. You should not correct it. So how much to leave behind is what is left out in the bending films of the non-structural above and below curve, so that the balance can happen and the head remains centered on the sacrum. This is willful undercorrection whenever you're doing a selective fusion, particularly in flexible non-structural curves. So how to undercorrect? Babuk, how to undercorrect? So how do we analyze how much to leave behind and how to undercorrect? For example, if a curve is completely straightening on cross rotation, so how do you leave and assess how much to leave behind?
So basically, you have to see again on the bending films pre-op that how much the flexibility is there, and accordingly you have to see, when you correct, if you are doing just selective thoracic fusion, then you have to see that on bending films whatever the maximum you could achieve. This thing accordingly you have to leave that curve into that thing, and in situ rod benders actually they come very handy in those scenarios.
Yes, Ranjit.
It's a question to the Dr. Kshitij and do you ever take a supine AP X-ray? And does it change your LSTV, LTV?
So for not for the double curves, but for like single curves, the supine AP LSTV, if there is a difference between a standing LSTV and a supine LSTV, then you can probably choose the supine LSTV and still get away. I'm not sure that applies to selective thoracic fusion though, because that's little tricky. Because selective thoracic fusions, you don't end at LSTV. You try to do stable. That you are doing now. You are standing LSTV. So most of the time your standing LSTV and your supine LSTV will match, or it will be LTV and LSTV, like last touch vertebra or last substantially touched vertebra. But if it is like different, last substantially touched vertebra on supine is different and standing is different. Supine is shorter. You may.
How to choose the LIV? In the last 3 talks, if I have to summarize, type A and B curves, LSTV, supine or standing, becomes a very important parameter to choose a LIV. Whenever you have fixed upon a LIV, look at the disc wedging below and the rotation of the LIV itself. If the rotation of the chosen LIV is high, go below. If the LSTV is the stable vertebrae best, but if not, go for LSTV, looking at the 5th and 6th dimension. That is type A curves and B curves. For type C curves, there is the option of going all the way down to L4 if the criteria of selective thoracic fusion are not met. But in type C curves, if the criteria for selective thoracic fusions are met, successful correction can be done. Under correction is a principle in those cases. These few lines will help you to determine your lower instrumented vertebrae selection in type A, B, and C curves, where thorax is the major thing. Now, LIV selection, if you do it properly, you can prevent add-on, you can prevent post-op decompensation, and you can prevent patients having unnecessary fusions. You can save motion segments. But a larger segment of unsatisfied patients are not because of poor LIV selection, but because of poor UIV selection, which has led to shoulder imbalances. There have been situations where patients come pre-operatively with a right shoulder up because of a right curve. Right major thoracic curve will give you right shoulder up. But post-operatively, many a times, due to overcorrection, left shoulder goes up, or due to poor UIV choice, also a shoulder mismatch can easily happen. Overcorrection, poor choice of UIV can all lead to shoulder imbalance. And how to prevent that? We have none other than the stalwart himself, Professor M.K. Kwan. He was keen to join us. Unfortunately, because of his executive meeting, he's joining us only virtually. And the questions will be taken care by Dr. Kshitij, Dr. Samir, and Dr. Abhay. So we go on with Professor M.K. Kwan.
And shoulder balance. So at the end of this presentation, I hope I'm able to enlighten all the participants here with regards to shoulder imbalance in scoliosis surgery. Post-operative shoulder imbalance, also known as PSI. Structural main thoracic curve ranking 1, 3, and 6. Structural also ranking 2 and 4. Overcorrection of main thoracic curve. Important to have a poor satisfactory outcome. Next, I come to type shoulder imbalance. Although actually have reported that there are 2 distinct types of shoulder imbalance. Lateral shoulder imbalance is reflected by clavicle angle, whereas medial shoulder imbalance correlates with T1 tilt and first grip angle. However, if you look at medial shoulder imbalance, one will notice that there is presence of neck tilt. Our group study has shown that medial shoulder and neck imbalance correlate with T1 tilt and cervical axis index. whereas lateral shoulder imbalance correlates with critical angle. So in conclusion, we know that shoulder imbalance can be are in the critical angle, whereas medial shoulder imbalance measure parameter T1 tilt and first sweep angle. Neck tilt is evidenced by cervical axis. So what are the current recommendations for UIV selections? Numerous studies have reported the importance of UIV selection in achieving a good shoulder balance. The following are the algorithm. Provisionally recommended that T3 will be the UIV of choice for main thoracic length at 1, 3, and 6. For proximal thoracic length 2 and 4, T2 will be recommended. Studies has also shown that UIV selection alone is not a definitive solution for preventing PSI. Bush and colleagues have reported, despite using the current existing algorithm, they could not identify a set of UIV selection that can predict PSI. So what does it mean? It means that besides the appropriate UIV selection, there is still another important factor which contributes to PSI. So next I'll come to how do we prevent medial shoulder imbalance and neck imbalance, the importance of the new parameter called UIV tilt angle, how to calculate the optimal UIV tilt angle before the operation, and more importantly, to use it during the operation. Our colleagues have reported that leveling T1 will prevent medial shoulder imbalance. This can be achieved by maximizing the correction of osteoporosis curve. However, we think that post-operative UIV tilt angle play a very important role in leveling the T1 tilt. As you can see here, a good post-operative UIV tilt angle will allow us to have a good medial shoulder and neck balance. Whereas a wrongly tilted UIV tilt angle to the right will result in severe medial shoulder and neck imbalance. Our data show post-operative UIV tilt angle is an independent factor which has a significant correlation with post-operative T1 tilt and cervical axis. Many and colleagues have reported in 92, approximately 70% suffer from medial shoulder imbalance, and one of the significant predictors for MSI is post-operative UIV tilt angle. Our research showed patients with positive post-operative UIV tilt have increased 15 times odds of having medial shoulder imbalance. These are some of the radiographs taken from the literature showing that UIV to the right will result in significant medial shoulder imbalance. Our research have shown that an optimal UIV tilt angle prevents medial shoulder and neck imbalance. The question is how to calculate the optimal UIV tilt angle before the operation so that we can use it intraoperatively to prevent medial shoulder imbalance. Our data show that a preoperative supervised cervical supine side bending film can be used to calculate the optimal UIV tilt angle before the surgery. This is by assessing the C7 flexibility above the selected UIV. And by using a simple mathematical calculation, one will be able to calculate the optimal UIV tilt angle. This is an example of the X-ray, right and left supervised cervical supine side bending film. And from this, we should be able to calculate the optimal UIV tilt angle, in this case, the blue vertebra, which is negative 5 degrees, means 5 degrees to the left during the surgery. Here I'd like to show you and share with you a surgical strategy with illustration of two cases. Case study 1. A lengthy 2AI curve, main thoracic 57 to 33 side bending, proximal thoracic 47 to 41. This case has a significant high risk of developing medial shoulder imbalance. UIV T2 was selected, and from the side bending film, the optimal UIV tilt angle calculated was 0 degree. So these are the surgical strategy. UIV tilt angle 0 degree. Under general anesthesia, the UIV tilt angle was measured at 7 degree, means 7 degree to the right. And at the end of surgery, the UIV tilt angle should be 0 degree. Surgical strategies we maximize the correction of proximal thoracic curve, followed by harmonious correction of main thoracic curve. Occasionally, for lengthy 2, we may need to let go the main thoracic correction if required. To the end of the surgery, aim is to correct the UIVT angle from +7 to 0 degree. Notice that the UIVT angle needs to be corrected anti-clockwise in this case. Here I'd like to illustrate using a diagram in surgical video. Please pay attention to the UIVT angle to the left. So before surgery, the UIVT angle was tilted 7 degrees to the right. First, you want to measure the rod and bend the rod accordingly. Insertion of the right rod and correction of the concave proximal thoracic curve. Insertion of the right rod will bring positive 7 to positive 4 degrees. Only that, dissection of the concave proximal thoracic will bring the positive 4 to a negative zone. First, we will tighten the UIV screw on the right side, followed by dissection of the proximal thoracic curve using a compressor. If the UIV tube is not negative enough, one can let go the main thoracic curve correction by bending the rod slightly. Reduction and compression of convex main thoracic will give you a coupling effect to reduce the root count, and this will bring the UIV tube angle to the positive zone, in this case, 0 degree. Following that, a left rod bending was performed, and insertion of the left rod will bring the UIV tube to the positive zone. And finally, compression of the convex proximal thoracic to fine-tune the UIV tube angle back to 0 degree. A crossbar is used to check the UIV and LIV. A UIV tube angle in T1 tube angle can be confirmed during the surgery by using crossbar with the help of Ortho. And in this case, UIV tube angle is confirmed to be 0 degree. Pre and post-operative radiographs and pre and post-operative clinical photos. Clinical case study 2. Lengthy 1 AM. So UIV of D3 was selected. Completion of UIV tube angle D3 was negative 4 degrees. This is a surgical plan, UIV D3 with tube angle negative 4 degrees. Under TA, the UIV D3 tube angle was negative 70 degrees. At the end of the surgery, the final target was negative 4 degrees. Surgical strategy is to maximize the correction of main thoracic curve to achieve the UIV tube angle. UIV tube angle before negative 70 degrees and final target after the surgical correction is negative 4 degrees. Notice that this is a clockwise correction of the UIV tube angle for this case. Left rod will be inserted in this case with dissection of the concave main thoracic curve to bring the UIV negative 70 degrees to negative 7 degrees. And the insertion of right rod will further bring the UIV tube angle to approximately negative 4 degrees. UIV tube angle and T1 tube angle can be confirmed intraoperatively by using crossbar with the help of OrthoTV again. Pre and post-operative radiograph, pre and post-operative clinical photos. Next, we come to lateral shoulder imbalance. At this point, there's no solution to overcome the lateral shoulder imbalance. 30% normal adolescents have lateral shoulder imbalance of more than 1 cm. Our colleague has reported how to achieve lateral shoulder balance is still unclear. And Brooke and colleagues have reported even the selection of T2 as UIV does not guarantee lateral shoulder balance. What we know from literature is lateral shoulders imbalance change significantly from pre-op to up to 6 months post-surgery. and only the colleagues have reported that improvement of lateral shoulder imbalance will be noted at 2 years post-operatively. Matsumoto and colleagues have reported this term add-on may be a form of compensatory mechanism to prevent lateral shoulder imbalance. Conclusion. There are two types of shoulder imbalance: lateral shoulder imbalance and medial shoulder imbalance with neck tilt. For lateral shoulder imbalance, it can happen in normal population up to 30% of the person. Spontaneous correction can occur during post-operative follow-up, and this term add-on might be a form of compensatory mechanism. Whereas medial shoulder imbalance, with or without neck tilt, besides UIV selection, an optimal UIV angle is important in order for us to regulate the T1 tip angle to achieve a good shoulder balance. So based on the current literature nowadays, we have evidence to show that how to select the UIV selection. And at the same time, we also have enough evidence to show that the importance of UIV tip angle, which can be calculated before the surgery and to be utilized during the surgery to prevent medial shoulder imbalance and neck tilt, so that we can avoid this problem. Thank you very much for your attention.
Thank you, Professor Kwan. Any questions for UIV selection? No, he's not around. He's not around. So my question to Kshitij and Dr. Samidalvi. So a patient with right thoracic curve with a neutral shoulder pre-operatively. What is your take versus a same patient, right thoracic curve with a right shoulder imbalance pre-operatively? Does your level of UIV change or not? Consider this as only main thoracic curve with proximal thoracic being non-structural.
I mean, obviously, you have to look at the X-rays also, but in principle, I would get worried. So for me, a patient who has got a right thoracic curve but the shoulders are level is a bit of a worry, because then I have firstly, the patient is used to level shoulders. It starts with that. And the other problem is that that patient, I have a high chance of unbalancing that. So if you look at the first and the most, I shouldn't say brainless, but where you don't have to use your brain at all, then if the shoulders are level, then you end at T3. That is one way of looking at it. But of course, you need to look at the X-rays and what way the curve is and the bending films and see how it corrects. But I just want to say one more thing. See, the shoulder level also is, it's very complicated because there is something known as the shoulder hump, which is very difficult to correct. And that is the web. So shoulder level means one of the things is you look at the outer shoulders or the tips of the clavicles, which if you can follow these rules and all of that. But if somebody has a shoulder hump, those are the things which are very, very difficult to correct. And there has been a lot of literature and a lot of papers, but actually nobody has the answer for that.
Get the right level. Dr. Abhay, in your clinical examination, you highlighted about watching the shoulder. What is it that one should watch for? Consider a hypothetical situation: 13-year-old female with right-sided thoracic deformity. What are the things that one must watch for to choose the right clinical exam?
Yeah, so that's a good question because you want to see the medial shoulder height, and the medial shoulder height or the shoulder hump, as was spoken of, relates to the T1 rotation, not T1 tilt. So I strongly differ with Professor Kwan here, who feels that if you correct the T1 tilt, you get your medial shoulder height. According to me, that's incorrect. T1 rotation causes a rib hump of the first rib. And it's impossible to derotate the T1 because your instrumentation never goes to the neck and you can't derotate your UIV. So that's your first marker. And if that is off, you got to tell your patient that, boss, I'm going to leave you with some of this. The next is the lateral shoulder, which we all understand. So if you look at me, so if my spine was like this, okay, technically my right shoulder should be up. But now you say, can you move your shoulder? I can easily move my shoulder.
Recording in
Believe
progress.
that the lateral shoulder matches the curve of your spine is a very naive belief, because the joint of the shoulder is attached to the spine through 4 different joints, unlike the pelvis, which is a part of the. So to believe that you can get your T1 right and then your shoulders will, you got to get the spine balance right and your shoulders will fall in place. So that's something that you got to take home. The third is the scapula. So how the scapula looks. Is the scapula flat and symmetrical, or is the scapula standing up? Because that's the trunk rotation, the rotation of the torso, the chest wall. And if the chest wall is rotated, unless you get a very heavy derotation maneuver, your scapula will still remain off. And then the fourth is how the arm is from the chest. So you'll find that on the side of the convexity, the arm is close, and here the arm is away from the chest. Again, for that, you need to get the truncal balance right rather than the derotation. So if all these four are evaluated in your mind's eye, then you're able to deliver, or you're able to say what you're not able to deliver.
Understanding this clinical examination and the same hypothetical situation, right-sided main thoracic curve with case 1 having right shoulder up, case 2 having balanced shoulder. Choice of UIP.
So right shoulder up is easier to deal with than equal shoulders. If it is equal shoulders, be very careful because they are kind of a precursors for imbalance. And like I showed in my slide also in the first talk, all this proximal thoracic business and thoracic curve business and classifying it and understanding it is very, very unreliable when it comes to radiographic assessments. So the curves that are borderline, like say a proximal thoracic curve that bends to 15 to 25 degree, not in less than 15 degree, but somewhere near 25 degree, many times behaves like a curve that bends to more than 25 degree. You got what I'm saying? So that this margin of error, that 10 degree between 15 and 25 degree, is be careful of those curves, especially if shoulders are level. The other thing you need to consider is the same logic what applies to selective thoracic fusions. So we discussed that over-correcting the main thoracic curve beyond the lumbar spine's ability to correct is going to throw the patient off. The same logic applies when you have two curves in the thoracic spine. If you overcorrect the main thoracic curve, stopping at T4, beyond the ability of the proximal thoracic curve to balance, you're going to throw the shoulders off, correct? So that another logic you remember, that if you are correcting your main thoracic curve aggressively and your proximal thoracic curve is 15 to 25 degree correction on benders, you might end up going to T2 even if proximal thoracic curve is non-structural. With me so far, right? Now, the other thing to understand from this talk is there are two shoulder balances, medial balance, lateral balance. One take-home message from this talk should be medial balance, you have some control over in AIS curves. Lateral shoulder balance, you have no control over as much because, you know, it's quite far away. So if you have medial shoulder imbalance, the thing that has been shown to correlate with leveling of this trapezial prominence is the level of T1. Now, how you get the T1 level is complicated business. It's not as easy as he showed to measure it. So he showed that you measure the UYV tilt and then reproduce it intra-op. Now, if you notice the numbers that were shown, they were 5 degree, 10 degree, 4 degree, you know. Now, imagine that you want to reproduce a 4 degree UIV tilt intra-op. It is very difficult because you don't know what 4 degree you can measure. No, so that's what I'm saying. So you are trying to predict the T1 tilt on the basis of a UIV tilt, and intra-op you are trying to get a 4 degree UIV tilt on the basis of a T tool that you put at the pelvis, and the line is drawn up to that UIV. So your horizontal line is on the iliac crest, and that it moves a little bit also, that whole thing is going to move, and you are trying to measure 4 degrees. So you see, practically to apply this in real life is extremely hard when you are trying to get like a 4 degree or 5 degree thing. Yeah, so it is not as easy as that. So yes, you can use those tropish criteria and this criteria and that criteria, but it is not so easy as that. Remember that whenever you have level shoulders, when you have left shoulder up, so you are going to T2. There's brainless. But if it is level shoulder, you might still end up going to T2 if your curve is borderline. You know, your proximal thoracic bends to 15 to 25 degrees, somewhere in between. Your main thoracic is super flexible. You are going to use screws at all levels. You're going to use cobalt chrome rods and straighten the whole main thoracic completely. You will go to T2.
The message is very clear. There are hidden, innocuous looking proximal thoracic curves which have to be clinically evaluated by all the parameters mentioned, where on a right-sided main thoracic structural curve, if the right shoulder is high, stop at T4 or T5 or the vertebrae, whatever it is. If the left shoulder is high with a right-sided main thoracic curve, that means there is a proximal thoracic structural curve, go to T2. But with balanced shoulder, you are in fix. You will have to choose the UIV with a lot of important data points which need to be measured, like we discussed in the previous talk. So with this, we move on to thoracolumbar curves and the advancement in technology. We have with us Dr. Appaji Krishnan there. Appaji, we have shared you and made you the host. You can share your slides. Dr. Appaji Krishnan is joining us from Apollo Chennai, and he's going to be helping us with understanding on non-fusion in scoliosis surgery, following which we are going to come to a less touched type of curves, which is type 5 and type 6 curves, the thoracolumbar and the lumbar curves. So far, we were talking about main thoracic and proximal thoracic curve and choice of LIV and UIV. We are now shifting gears to non-fusion for these curves, and then we go on to the last but most important, the thoracolumbar and the lumbar curves by Dr. Dalvi. Dr. Appaji, over to you.
Hi, all. I see a very bright and gamut faculty around, stars around, and I saw Abhay doing his salsa as usual. Yeah, without much this thing, this is something which is a controversial topic. We keep on discussing. We've fought, and Abhay has questioned me so many times about, is it true? Is it working? So it's a newer thing. So let's hear what it is. So non-fusion is this is a little different from what we keep hearing about VBT. VBT is growth modulation. What I'm going to talk about is a non-fusion anterior scoliosis correction, which is not growth modulation. Growth modulation is actually for a younger patient who still has growth left. So if you are doing an anterior growth modulation, adjacent level degeneration is actually much lesser. Better sagittal compensation you get, and hypothetically you still have mobile spine better than a fused spine. So this is a mechanobiology of differential growth. We all know about the Hooter-Walk-Falkman law, where if you apply a compressive force, the growth stops, and then a traction appears, and then there is a correction of a curvature if there is a lengthening on the other side. So here the tether is used. This is in the tether form, that is the non-fusion or the vertebral body tethering. So this is how an younger patient is treated. If there is a distraction-based method, then there are compression-based methods. Okay, so we have traditional growth rods. There's magnetic growth rod. Then we have fusionless bipolar construct. These are those Sheila type construct. Then we had this Webster, which used the pelvis and the ribs to correct. Then we had anterior compression devices, which is nitinol staple, which I don't know how many of you have seen or even heard of. It was there in the late 2008, 9, 10 types. It was a shape memory alloy staple, and then the vertebral body tethering came into in 11, 12. So in the last decade, also early part of last decade, as a treatment for growth modulation. So in growth modulation, what happens is you subtly don't correct the curve. You do a compressive force on the convexity, let the concavity increase in length, and then thereby achieving a correction of curve. Same thing the nitinol alloy was doing for the vertebral body stapling. So in most of these now we have moved on to doing lots of hybrid constructs. We can have concave MCGR, that's a magnetic with a concave growth guided, like you just leave a non-fused segment up and down, or a spring distraction aided guidance. Or you can have a modern Luke trolley. That is, you have these wires or not the wires. Wires can cause metallurgy. So you will have these bands which are there in the top and bottom, and you just let the patient grow. And there is this famed apical correction of ALA also. And then there is fusion. So where do this thing comes? So if you have these, this is the growth curve, this is the curve, and riser, as you can see here. If the triradiate cartilage is open, no fusion, no tethering works. So it has to be either bracing or growth rods. Tethering is in grade 0, riser 0, where the TRC is closed. Then riser 1, till then you can do a vertebral body tethering. This is where vertebral body tethering stops, where brace, growing rods, BBT. Then comes the anterior scoliosis fusion, where the curve is less than 60 degrees, which is, correctable, and riser 2 or 3. A very mature patient, you may not do a anterior non-fusion scoliosis correction. Most of the things which I've experienced is with this only one system which is available in our country, which is the Reflect anterior scoliosis correction. So it has a HA-coated screw, a monoaxial screw, which goes into the body. Then you have this polyethylene terephthalate tether, which is actually put onto the tulip and then secured with this soft locking screw nuts. So, and then you correct it by using a tension, like the Dwyer system. If you people have heard of the Dwyer anterior correction, there used to be a thin rope-like structure, so that wherein you pull it. So this is the thing which is used to tension the convexity. So you compress on the convexity, leaving the concavity to do better. There are two issues here. One is you are actually correcting not the curve, you are actually metabolism of the disc itself is getting varied because the disc already was in compression. The fibrous annulus fibrosis was in compression on the concavity. Now we are going to stretch it. So how the disc is going to respond, as well as the bone which is going to respond. So where the tether is usually used, VBT, that is for growth modulation, AIS, or even in some other cases, there have been positives, negatives about it. You can read about lots of papers from Wangikate and Peter Newtons and so many people about growth modulation. The second one is anterior scoliosis correction, which we are talking about, and VBT non-AIS cases, which is, I will say, we'll not discuss about it in much here. So this talk is going to be on non-fusion anterior scoliosis. So the ideal zone is, this is for the growth modulation. This is for the VBT ideal zone where there is a correction. That is a non-fusion scoliosis correction, which you can see. So an example of a patient where she was 11-year-old, pre-menarchal, the riser was 0, and then the triradiate cartilage was just fusing. So we used VBT to growth modulate. We left her thoracic curve at 16, and a 2-year follow-up and 4-year follow-up, you can see the curve is almost corrected to 0 degrees. So we extrapolated this to our AIS cases, where we usually choose a good case, which is between, the initial days we used to do between 45 to 65 degrees. So this was a 58-degree riser 4, slightly mature girl. 12 ribs and Sanders was 8. Usually Sanders above 4, yes, you can do a non-fusion anterior scoliosis surgery. So you can see we do this traction supine traction film for most of our patients to assess flexibility. So here the flexibility is come down to less than 50%. So the curve is corrected to less than 50%. That is the first criteria which we use is the curve magnitude, which is less than 65 degrees. Then next one is the correctability. So in your stress film, if you can correct the curve to less than 50 degrees, less than 50%, yes, you can go ahead and do a non-fusion. So these are the bending radiographs again showing the same clinical pictures. So we went ahead and did a anterior correction. You can see the scar there. And this is a girl 4 hours after post-op. 1 year follow-up, and we have a 4-year follow-up on her. She is a Bharatanatyam dancer, which she sent us this video later, and she said, "Sir, doctor, you can go and present it anywhere because I'm so happy with what has happened to us." And in few of the cases which we have been doing now, so this is one of the patients who insisted on we don't do this anymore now. So this you can see is a 55 and a 65 lumbar curve correcting to, this is before bracing. After bracing she has increased. She was correcting in our cases to 11.5 to 17 degrees. So we could do a two-staged correction. One is first we do the lumbar curve and then we do the thoracic curve so that we leave a little curve on the top. So this is how we do. So we do sometimes in the lumbar curve in these mature patients a double tether, which is called, there are two, you can see two screws. So it's a bigger curve. It was nearly 68, 70 degrees. So we got it down to 16 degrees, as you can see. And also people question about like anterior surgery is kyphogenic, but you can see here, it is little kyphogenic, but it has come down to a nice, good lordosis, which the patient requires rather than an hyperlordotic spine. You can see here. And also the sagittal profile, as you can see, the thoracic kyphosis and lumbar lordosis are in good harmony. This is and again, this is a girl who wanted to gymnastics. So she came specifically from Australia telling, I don't want to have a fusion. I want to be flexible. This is a 2 years follow-up video, which she sent us again. So as I said, in few of our cases, we have stopped doing those in the 6 CNs where we don't do a double fusion. We now, where the thoracic curve and the lumbar curve is high. This was a doctor's child, and the mother was insistent that she requires flexibility in the lumbar spine. So we could convince her because we didn't want to do this was not correcting. This was a very high 106 degree curve. So we didn't want to do, which was correcting to less than 60 degrees. That is not 120 degrees, that's wrong. So we didn't want to do a tether here. So we did a selective fusion. We have, you can see her at 1.5 months follow-up, and then you can see how balanced she becomes from this to this. We did a selective thoracic. Here we stopped. Most of the selective thoracic you can see here is stopped at around 11 or 12 because the lower down we are correcting and giving an harmonious curve at around from T11 to L4. And here we are not bothered about going to L4 because we are not fusing the disc here. There are two issues here because the tension which we create in the tether at the lower level, because the curve was 75 degrees pre-operatively, we can fail at the apex. That is what the paper of Per Traubisch is about, where he fuses these apexes where he cannot create a parallel disc at that apex in the tether. So this is what we are doing now as a hybrid technique. So this is a one-off case which I will skip, where we did an excision of it's a very young boy. You can see even that the triradiate cartilage was not fused. 9-year-old or 10-year-old boy. So we did an hemivertebra excision, put tether on both the sides. We actually growth modulated to become, you can see that immediate post-op he was hyperkyphotic, and at last follow-up he had a good sagittal balance too. So what are the complications? The thoracic duct injury, which we have not faced since we are not doing most of the right-sided. Atelectasis pleural effusion, yes, we have had a few cases, but if you go in for an aggressive chest physiotherapy, we don't have it. We have not had ureteric injury. Incisional hernia, we had to wait and watch. We have at least more than 167 patients who have completed 4 years with no incisional hernia. And fingers crossed, no vascular injury, and whatever said and done, there's no neurological injury whatsoever. To summarize, vertebral body tethering is an option for a select group of patients. Now we do most often when we say we do it for a type 5 linkage. It's a very beautiful system. We also do it for type 3 and 6 if the curve is like you saw the hybrid techniques. It's a very powerful technique with, I mean, I do not know the presumed benefits. What Trowbridge, Peter Newton, everybody has published is that the lumbar spine is mobile even after the tethering. And we are beginning to understand most of the whom we can offer to, and we do not prescribe to every patient. Thank you. Open for questions, yeah. Vishal, I'm not able to hear you. Your audio is not audible to me. They have to share their screen.
Yeah. Thank you, Dr. Appaji, for being around with us and sharing your experiences. The talk is open for questions. Anyone, please? Non-fusion techniques in scoliosis. This is one of the most evolving sciences in scoli.
Abhay has a question, yes. No? Abhay is not here.
What is the longest? One second.
Yeah, I'm Dr. Neetu from Guwahati. What's the longest follow-up of these kind of cases you're doing?
So the first of the papers came in 2012 by Peter Newton and Wongikit in 2014. We started doing it in 2016. So we have 10-year follow-up on patients. We have at least 28 patients who have finished 8 years.
So Dr. Appaji, one question from me. Screw loosening is something that was noted in even dynamic fixations, Dinesis, wherever this tethering was used with these flexible cables. Have you noticed lucency around the screws, screw loosening or rod breakages in your series?
So the tether breakage, what you mean is cable break. So cable break is quite common. It can be up to 30% of the tethers which break. So the logic of this surgery is that you have done a non-fusion surgery. There is a thing which is mobile and it is not going to, even your cobalt chrome rods break, right? So these tethers will break. So the most common breakage is at the apex of the curve. And if the tether breaks 2 to 3 years beyond your surgery, the clinical outcome, that is, if you measure the curve magnitude, pre-operative, immediate post-op, and if you have not lost more than 10 degrees of your correction, you don't have to do anything for these kids. Most of these kids are clinically looking very well balanced. And so we have had at least 17 out of our 200 patients who have broken tether. We have revised only one of them because she decompensated. She was a very young girl. She was, in fact, an EOS. She was like, when we operated on her, she was 10-year-old. She broke it when she was 12. And at 14, we have revised because she broke at every level of the fixation. Regarding the screw loosening here, the posterior screws loosen. We have had very rarely, even in our anterior scoliosis correction series, which we used to do olden days, like till 2009-10. Those anterior scoliosis screws have not loosened out. And here these are HA-coated screws for integrity.
Yeah, thank you.
It's very difficult to remove.
Yeah, anyone? Any question? Any more questions for Dr. Appaji? Okay. Thank you, Dr. Appaji. While you open the door for anterior surgeries in thoracolumbar scoliotic curves, we really appreciate you sparing your time on a Sunday afternoon and sharing with us your experiences. Thank you, Appaji.
Bye. Thank you for having me all. Thanks.
Thank you, Appaji. Dr. Sameer Dalvi. So thoracolumbar curves and lumbar curves is a completely different ballgame. Here we are not talking about selective fusions. Here we are not talking about only saving the lumbar spine levels, but also about how to achieve good lordosis, good fusion, derotation, which matters a lot, and of course, saving the levels, all by none other than Dr. Sameer Dalvi. Dr. Dalvi.
Slides?
Yeah.
I know this is slides. Is this mic on or this mic? Hello. So I know this is a very difficult time. It's just before lunch. Everybody must be hungry. And there's so much of knowledge thrown at y'all that y'all must be blank now. I'm just wondering how much is going to get into you. But the only difference between this talk and the others is completely different. We are looking at it from quite the other side. I mean, I'm leaving out the previous one. So I'm talking about the thoracolumbar lumbar curves of type 5. And basically, this is the sort of curve that you're looking out. And what are the different challenges here? Like one is, of course, trunk balance, because it's very disfiguring. One of the important other things is to preserve lumbar. So somebody would have told you in the morning, or I can tell you, if every scoliosis patient you fuse from T1 to sacrum, you don't have to measure levels, you don't have to classify curves. But the aim is to spare levels because you want to give mobility. And last but not the least, you must look at the lumbar lordosis. So this anterior approach is something which I really like. And what does it do? You get a direct anterior access to the curve, and you do a discectomy. You are doing a complete discectomy. So it's a total release of that segment. The fusion level is always shorter, and therefore you preserve levels, and you can get a very good coronal plane correction. Because in an anterior surgery, you only need to fuse the primary curve. So this whole planning of levels and where to end and all doesn't come into play. You are just fusing the primary curve, and it has the shortest fusion level. So basically what you do, you also get the best correction of rotation. And the reason for that is you get the best correction of rotation. Now, why do you get the best correction of rotation? Because number one is you select entry points in such way that when they line up, your entire spine derotates and you get a very, very efficient grip. And also you do a superb release. You're removing the entire disc. So the correction of rotation is by far the best with anterior surgery. The principle is compression on the convex side. So there are different principles of instrumentation. There is distraction on the concave side, there is translation, there is rod rotation. But this principle is compression, and the compression is on the convex side. So it started with Dwyer way back in 1969. So that's when anterior scoliosis started. And what he had is this, which is just a screw with cables. And he used to crimp it, he used to compress and crimp. Obviously, that was weak. So therefore, Zilke came. Zilke had a threaded rod with nuts, which was a little finicky. So he used to put the screws and then put a threaded rod like an Elizarov and have nuts which used to turn. That was flimsy as well. So now we use solid rods. One problem is a kyphogenetic effect, which means that when you compress anteriorly, you lose lumbar lordosis. But that is corrected by two things. One is by using cages, and the other one is by using dual rods. So these are the two ways to not have a kyphosis. So this technique is, it actually depends a lot on whether you're skilled with anterior surgery. And in my era, when I was in KEM, we were doing a lot of anterior surgery, like 40% of our surgery was anterior, because we used to do all TB spine anteriorly. I used to do trauma anteriorly and then scoliosis. But now I think everybody is so comfortable with posterior that this becomes a completely different learning curve for them. But if you are, then you can do this. So the approach is an anterior approach from the convex side. And this is the approach. It's a thoraco-abdominal approach. So it's a trans-diaphragmatic approach, which means you connect two cavities. You do the thoracic cavity, which is a transpleural, and the lumbar spine, which is a retroperitoneal, which are connected by the diaphragm, and you cut the diaphragm. So it sounds very difficult and very dangerous, but it is not. One of the reasons is in scoliosis, actually the spine is coming up towards you. So it's right in front of you. You don't need to do much. So I'll just show you this approach. So that's how it is. You open the rib. It's usually the 10th rib. And you open the thoracic cavity. And then you cut the diaphragm along the periphery. And then you connect both of these. You connect the thoracic and the lumbar spine. So in the thoracic spine, it's this way. You are bang on the discs and on the vertebrae. And that's the pleura. And then you incise the pleura, take it away, and you're straight on the discs. And that's how you do. So when you do a complete discectomy, that's what it looks like. It's a complete discectomy. You can remove the entire disc along with the end plates, and the vertebrae are literally hanging loose in front of you. So that's what it looks like after a discectomy and a release. So the thing is that you have to also take down the vessels. So the intercostal, these vessels are here, the segmental vessels are here in the middle, but that's where your screw goes. So you need to take them down. And at the end, this is what it looks like before you do your instrumentation. So this is the kind of release which is there. And then you put the screw, and this is how the screw goes. It has to be a bicortical screw, and it has to be exactly in this direction, parallel to the posterior border. Obviously, if you angle it, it will go into the canal. And it has to be bicortical, and it has to have a staple or for a better hold. So a staple or a washer, at the very least a washer, but best is a staple to prevent what is known as the windshield wiper effect. Now, once you put these screws, you then put in the rod sequentially. So like I said, you put in the screws and then using a cantilever, you start at one end and you start capturing the rod, and then automatically this corrects because it's already extremely flexible, and then you compress it. So it's by compression, you get the correction. So this is, it's very difficult to show it in photographs, but you can see right now the screws are put and the heads are all, each one is pointing in the curve. So they're all pointing away from each other. And then when you start putting the rod from one end, you start correcting one level after the other. And at the end of it, the rod is straight and all the heads are in line. So it gives you a really superb correction. Like I said, it's a better correction because you have a complete release, you have a full efficient grip on the vertebra, and you get a very good derotation for reasons which I mentioned to you before, and you spare lumbar fusion levels because you don't need to go into the secondary curve. It's compression, so your distraction isn't there, so your neurological injury is very low or almost absent. Plus, on top of it, the fusion is an interbody fusion. So it's the best quality of fusion also. So there is, pseudoarthrosis is very rare. So I think in every which way, this forms a criteria of an excellent surgery. So I think we've done all this. Of course, there are drawbacks. I think one of the main thing is the familiarity with anterior surgery. If you're going to struggle with anterior surgery, it is a problem. But you can take an access, like you can get a thoracic surgeon with you or a good general surgeon, and that is the thing. And if you're going to create a complication, you can create a very deadly one. Like if you're going to damage the aorta or something, that's going to be like a deadly one, but you can do that in posterior as well. So this is just to show you for these sort of curves, you can see in a very short, with a very short levels, you are able to get an excellent correction. And the X-ray speaks for itself. And as you can see again, for this kind of curve, which is a thoracolumbar curve, with just 4 screws, we've got like a full correction, right? And the cosmetic effect also is very good because the trunk correction is absolutely excellent. There was a time when I was doing more anterior surgery than I should have, and I was using it for thoracic as well. But that's a little scary because you have to do a double thoracotomy, and I don't do that anymore. But like for something like this is a thoracic curve where through one incision, I do a double thoracotomy and then correct it. But the correction is excellent, truly, including the rotation. Now, even for double major curves, you can use this because you can spare a level. So I would do the lumbar curve anteriorly first and then turn and do the posterior like this. And so these are just some, just to show you how this works. Again, this is a pure thoracic curve, which is done anteriorly. So thing is, I do these posteriorly now. I don't do these anteriorly, but there was a time when I was doing this anteriorly. Actually, unfortunately, Lenke presented a paper where he did this anteriorly, so I started doing them. And then he published a paper saying that it makes no difference. Then I started doing it posteriorly again. But the point is the ability to do it, and the kind of result which you get from this is excellent. And like I said, you only have to do the primary curve. So there's no question of measuring curves. So you can see even on follow-up, the balance is excellent and maintained. And see these curves, which are, these are quite high magnitude curves, but because of the release and other things, they line up completely straight following the surgery. Right? The only problem is a little kyphogenic effect, which you have to sort of deal with. Again, this is another one. And you can see this. So these are things which are often put on the group and everybody argues for posterior, but I'm one of the guys who's steadfastly doing anterior. It doesn't mean that I don't do posterior, because for this patient, I could have easily done an anterior and ended at L2. But as Dr. Abhay said, L2, L3, kya farak padta hai? No, first Abhay said it, then Ranjit copied him. Means Abhay said what difference, and he said kya farak padta hai. So L2 and L3, you can be out, the jury can be out. But then here I suddenly felt like not doing anterior on that day. And then with posterior also you get good result. But like I said, I ended at L3. If I had done anterior, I would have ended this at L2, right? So why I prefer, so there are a lot of theoretical reasons for it. But the question comes why I prefer anterior. In my hands, left fields are definitely saved. So I'll explain to you what I mean by that. Where I'm ending at L2, the D11 to L2s, the very hardcore posterior surgeons can do that. So Lenki can also end at L2, but you have to do a huge posterior release for that. Lot of time. Your screw, you have to have obviously screws at every level, and you have to work very, very hard with all the tools available to derotate and to correct it. And then you may still go wrong. In my hands, I feel with this anterior surgery, I definitely save the level without much struggle. The derotation is much better. Cosmetically also, it's one lateral scar, which is quite good. The fusion is very good. I like the fusion. And it's a good teaching tool. So sometimes I just do it to I ask the fellows, have you seen anterior? No. Okay, chalo, next one anterior. So that's good. And of course, the last one, I love to do it because we keep on doing posterior surgery. So there has to be some change, otherwise you'll get bored. I cut the slides because Vishal gave me only 8 minutes. So there's a lot of literature there as well on anterior versus posterior. And what it shows that the literature, this the review, shows that both approaches are effective, but anterior is superior for motion preservation and fusion, and posterior is superior for sagittal correction and surgical simplicity. So this is the core of all the papers which I have studied. So I think that's that.
This is open for questions now, and I'll play the devil's advocate, Dr. Abhay, while the next talk sets up IONM. Guru, set up. Dr. Abhay, I have heard your debate with Dr. Dalvi. Can I have you on stage and have few words of debate? Why you like to do it posterior, even in thoracolumbar curves, and to counter, we have already heard Dr. Sameer's point of view. Posterior approach for thoracolumbar and lumbar curves, why? If there are so many advantages.
I think, first of all, let me submit that for a pure lumbar curve, there's nothing like an anterior surgery because even that one level saved can make a huge difference. Remember, these kids are going to live for 60 years after your surgery. So if you have 2 extra discs available compared to only one, you're going to make a big, big dent in their long-term future. And then you can't excuse yourself by saying that I don't know how to do anterior, so I'd rather do posterior. Having said that, my problem with anterior is the scar because it's not as cosmetically efficient as it would as a posterior scar for a girl, especially because it comes around here. The other is it doesn't restore lordosis as well. So in the past, I tried to move from anterior to posterior, even for Lenki 5s, and the lumbar lordosis that they got. And this is equally important. The butt coming out is equally important for the girl cosmetically as the scoliosis correction. And then the third is the security of the instrumentation because you got like 2-level pedicle screws at every level. So it's a really strong, solid implant which gets you going. For the thoracolumbar curve, I think I have no debate in my head that you would want to go posterior because you can get a much better sagittal balance. It's an efficient surgery with a better scar. So I think that's where I rest my case. Even then, we recently did a very bad adult scoliosis where we had to go anterior. So please don't use inability to perform anterior surgery as your excuse to not do anterior surgery. If you're a spine surgeon, the least you should know is an anterior approach to the spine.
Now, since you have been doing posterior surgery also so very well, do you genuinely feel that in all those cases you have saved significant levels of lumbar spine, preserving motion at lumbar spine?
I've told you, even these 5 cases I showed you, seen how much, how many levels are saved. There is a minimum of 1, if not 2 lumbar levels which are saved.
That's the message that is driven around, that saving lumbar spine levels, saving motion segments has been in past one of the most important points on the goals of surgery. And that applies to lumbar spine even more. Just because posterior surgeries are safer, simpler, doesn't give you a right to take away that one motion segment like Dr. Abhay highlighted. Posterior surgeries do wonderful corrections, but if you can save even one level, that will really add on to a lot of functional benefit for the patient. Thank you, Dr. Dalvi. Be around. We are going to be having interactive case discussion sessions. We have learned about the principles of level selection, UIV and LIV and selective thoracic fusions and anterior and posterior surgery. And then all these masters are going to be sitting right in front of you while our outstation faculty is going to be grilling them with the cases to actually see the planning and execution, how it happens, before we move on towards the end of the day with hands-on workshop on how to put pedicle screw in rotated spine and the correction maneuvers. How do they use it? We have enough number of tables for you all to play and commit mistakes on these sawbones. And we have real lifetime sawbones available today to play with. So before we move on, the last talk of the session by Dr. Gururaj Sangonimak from Delhi on how to enhance safety. On one hand, we are saving levels. We also have to ensure that these surgeries end up safe without any neuro deficit, neuro monitoring. Dr. Gururaj.
Good afternoon. So doing a deformity surgery in spine, especially scoliosis and kyphosis, without IONM is like a drunken driving. There is no excuse medico-legally if you don't use intraoperative neuromonitoring for these surgeries. So whatever you have learned today, if you want to apply them safely and do these surgeries safely, you need to have you need not have a in-depth knowledge of neuromonitoring, because you have these neuro technicians. They can ultimately perform these neuromonitoring during surgery, but then you have to know the basics of surgery for to understanding the neuromonitoring. So why neuromonitoring? It is to prevent iatrogenic spinal cord injury, and this is the one of the most dreaded complications which you can have in scoliosis surgery, especially AIS, where you think that it's a very safe surgery. Neurological deficits are very, very minimal, to the tune of less than 1%. But then if you have it, then you cannot be pardonable in any court of law. Okay, so you can see what is the incidence of neurodeficits according to the SRS. You can see that in AIS, the deficits are less than 0.5 and 2% when you have idiopathic scoliosis. The maximum, if you see, that is in congenital kyphosis and dysplastic listhesis. So what we think of listhesis as a simple surgery, but the dysplastic listhesis as one of the highest incident of neurological deficits. So how does the neurological injury happens? It can be direct mechanical disruption from your manipulation. It can be a thermal injury from your cauteries. It can be a pressure injury from patient positioning. This actually a reversible neurological damage when you do scoliosis surgeries. And ischemia due to hypoperfusion. Again, it is a reversible nerve damage, which is indicated by the neuromonitoring, which can be reversible. It's a valuable technique. Without this, it's going to be difficult. And all of us sitting here, we have done these surgeries without neuromonitoring and after neuromonitoring, and we all vouch for it that once we started using neuromonitoring, our corrections have become better. Our outcomes have been much, much better when we started using neuromonitoring. So what is neuromonitoring? It's an evoked potential. Basically, you stimulate and you pick up the signals to know that your neural connections are intact, and that is why you have a stimulus, you have a conductor, that is the spinal cord, and then you have a receiver at the lower limb. So you see the responses in terms of latency, amplitude, and pattern. So you have motor evoked potential, that is transcranial motor evoked potentials, and somatosensory evoked potential. These are the reverse. You stimulate the lower limb and pick up from the cranium. And then you have EMGs, that is, it can be a spontaneous or a triggered EMGs. So combination of all the three has been found to be more sensitive and more specific when it comes to neuromonitoring technology. So motor evoked potential, you stimulate at the cranium, at the motor cortex, and you pick up at the epidural area, that is called as D wave, or you pick up at the muscle MEPs, that is motor evoked potentials. D waves are more to be more sensitive and more specific for motor injuries. You have in that, you have a trained stimulus technique or a single stimulus technique. What do you mean by that? That you stimulate or give pulses almost 3 to 12 for 0.5 milliseconds, and you pick up the signals from the lower limb. So you can do key muscles, they are called, from the belly of the key muscles. You can choose according to the location of the pathology, a location of the deformity correction which you are going to do. If you are doing a lumbar spine, you might want to monitor each and every nerve root. But if you are doing at the thoracic spine, then you will have to do a monitoring at the key muscles. So that is how you pick up. The reduction in the amplitude of more than 50% is usually taken as a significant reduction of neuromonitoring signals, and you want to see for a reversible spinal cord injury. Where all you take, because this is a time in the sense you stimulate and you pick up. So you start with after induction, baseline, That is the baseline which ultimately guides you whether your signals are decreasing. Once you position, because just at the position also you can lose your signals. And then after the exposure, after the screw insertions, especially you want to do after the apical screw insertions where you can have more breaches. And once you correct with the one rod and then the second rod, if you have done any osteotomies, after the osteotomy, after any significant correction which you are doing, and final correction. And the last one, once before you start turning the patient from the prone to supine, you have to do, because there have been incidences, there have been late neurological deficits or late signal problems after surgery, after even after 1 hour, 2 hours. So then the somatoevoctive potentials, they are basically reverse. You stimulate from the leg and you pick up signals from the cranium. And these mainly monitor the posterior column. But the disadvantage is you pick up the, it's not instantaneous to know the neurological injury because of the SSCPs. It takes around 3 to 5 minutes. It's not a real time signal which tells you. And you here you see for latencies, that is from stimulus to picking up the signal. If that increases, again it indicates there is a neurological injury. EMGs, they are continuous and triggered. A flat line is the one which you always want to see. If there is any disturbance or any signals you pick up, that means the nerve root is getting irritated or it is under stress. So you want to take care of that. So we'll just skip for want of time. For anesthesia, very, very important. Most of the false alarms are due to your anesthetic technique. So inhaled anesthesia is big no-no. All intravenous anesthesia is used for this. That's called total intravenous anesthesia, and short-acting muscle relaxants just before your exposures. So wake-up test is still the gold standard to prove that whether there is a false alarm. Stagnera wake-up test, you want to do it if you think that everything has gone right, but still your signals are not appearing. So, but then quickly we'll go through some steps. If you lose signals, what you want to do? First, check with the neuromonitoring technician that it is happening. All your connections are proper. Then you want to see whether your mean arterial pressure is maintained more than 80. If it is less than 60, you can have false alarms. And release any traction which you have put. You will start with that. And then you will see, is there any impingement of the cord which has been exposed or at the osteotomy site, especially at the end of the osteotomy sites, and reverse any corrective maneuver which you have done just before the signals disappeared. And then confirm absence of any subluxations, especially when you have done VCRs. Consider implant malposition and check for if you have any intraoperative 3D imaging. You would want to use it and check for any implant malpositioning. And then do a wake-up test. If that also says there is signal disappearance, that really confirmed elevated mean arterial pressure throughout this signal. If the signal comes back, well and good. If doesn't, then you will have to stop and abandon surgery at that moment. So there are a few examples. This is, you can see the complete VCR is being done, but then there is no temporary rods being placed. The signals lose. That is what happens. There is a subluxation. Once you correct, the signals come back. The same, if your MEP is less than 60, you lose the signals. Once the MEP was elevated more than 100, you get back the signals. Again, over correction, you lose the signals, and then you undercorrect this kyphosis, you again get back the signals. So that is where you have to see whatever correction maneuvers you have done. If that is causing the signals, you want to undo those steps. So it has been the game changer, and it is mandatory present times. If you want to do any deformity surgery in spine, you have to have neuromonitoring. Combination techniques of MEP, SSCP, and EMG is the gold standard, and it has got a high sensitivity and specificity for detecting injury which is reversible. So that is very, very important. Irreversible injuries, anyhow, you cannot do anything. But then if the neuromonitoring tells you that there is an injury, you can reverse that nerve injury. Thank you.
were giving lunch. A few announcements before we move on. The Zoom link can be off now. We don't have to relay. So,
So we move on to the action now. Now, all the knowledge that we earned about that clinical evaluation, the importance of radiological parameters that you have to look before thinking about surgery. What are the parameters that one has to look into? All the CSCL, the last substantiated vertebrae, the end vertebrae, the corpse angle, how to determine the structural versus non-structural curve, and whether we can really save levels or not. In live case scenarios with clinical and radiological pictures, we have our panel with Dr. Samir Dalvi joining us, Dr. Abhay Nene, Dr. Babu, please, and Dr. Arjun Dalvi. So while we have our outstation faculty members to come and present their case and the dilemma on your behalf, please don't hesitate to ask the silliest question that you think. The one that you think is the silliest is the most important question, because only that will bring the most meaningful answer. So don't hesitate. They'll present the case. They will have questions on your behalf, but your questions will have more meaning to get the right answers from the panelists here. And we have all the panelists sitting here for next 5 cases, 1.5 hours, only discussing about how to execute knowledge into skill set to get better outcomes. Guru, start with the first case.
Okay, so this is going to be a simple case. The kind of case you should start doing your AIS. 14-year-old boy, noticed deformity at the age of 10 years, progressing rapidly since last 2 years. Right-sided thorax. This is the X-ray. Bauk, let me start with you. Are we allowed to ask questions to them or only the panelist only? Okay. Okay, so Bauk, first of all, when you see this, what comes to your mind and what all you see in this X-ray? You have neutral, standing AP and lateral.
Normally, I start looking at the identification marks. I mean the details, the name of the patient. I also look at the date when this X-ray was taken, whether it is a recent X-ray or not, because many of the times, these X-rays, they're quite old. So first you confirm the identification. First you confirm the date of the X-ray. Then I look at the areas, whether the area wise the X-ray is okay or not. That means my skull and the pelvis, everything is included in it or not. And also look at whether I'm able to see all the vertebrae and everything. And then usually looking at the deformity, it looks like that this is a Lenke 1 A curve. And to be more precise, it is Lenke 1A R curve because the L4 is tilted into the towards the right side. So, and I also look at the sagittal profile. So it is a hypokyphotic curve, so it's a minus curve. 1A R minus curve.
No, but
RS, the L4 is tilted towards the right side. So,
Why is it important?
so if you look at the L4, this is the 1A R curve. So the 1A R curves, they require ideally, more distal fixation as compared to the 1A L when the L4 is tilted into the opposite direction. So the 1A R curve, you have to go at least LSTV or the stable vertebra.
okay. So, but then maybe Arjun, can you just identify the end vertebrae and the apical vertebra, strategic vertebra? What is your stable vertebra?
So basically here, if you draw the stable vertebra here is going to be L3. Okay, and the end vertebra, the lower end vertebra will be L2. And the L2. And the upper end vertebra will be
Levels of the UIV, LIV being solved. If we can plan everything of this, is there really a need of any bending pins? If we can all plan everything here, is there a need of bending pins or traction pins or something? Would you like to do this, or here only we can plan everything?
No, but we are not planning the surgery now. We are just identifying the end vertebrae right now. He didn't say the levels.
Hello.
So
we are just identifying the curve. And what Dr. Bhavuk was trying to make a very important point that type 1, it can be 1A can be R or L, which is much simpler because King had identified this hundreds of years ago, which is a type 4 curve. Basically, after that, when people went to Lenke, they made a mistake of fusing too short in what what King had said long ago, which is a type 4, right? So identification wise, this is a King 4 curve or a 1A R and this neutral or minus. No, it is minus, I think, yeah. And the other thing to look in the X-ray is the reserve. And I don't know, I didn't get her age because she's either 0 or 5.
He's boy 14-year-old.
14. So this is
0. Riser 0 actually, but he's 14.
We have to maybe look at the wrist. I don't know. Yeah.
So T4 is the upper end, and L T4 and L1.
Any difference of opinion
L1
about
maybe
L1
L1 or L2.
Yeah, that is why. Yeah, L1 end vertebra.
So I think to identify, this is a very basic thing, of course. Like, how do you identify the end vertebrae? And the definition of end vertebra is the one which is maximally tilted in the curve, right? That is the end vertebra. But that is a definition which you have to give in the exam. But practically, how do you do it? Like, for instance, here, suppose there's a confusion between L1 and L2. How do you do it? Practically, very simple. You measure the curve using L1, and then you measure the curve using L2, right? And whichever is worse, that is the end vertebra, right? Because you have to see the one which is maximally tilted. Because L2 has started going to the other side now. But if you cannot make that out, then you measure the curve, and the worst curve is the curve.
There's one more simple trick that if I'm looking at the LIV and there is a confusion between L1 and L2, you draw a line along the inferior end plates of both the L1 and the L2.
LIV or end vertebra?
LIV.
We will discuss about LIV.
Not the end vertebra, sorry, the end vertebra.
Yeah.
And then if you look at the both the lines, if they are converging, then the lower one is the end vertebra. And if they are diverging, then the upper one is the end vertebra.
Yeah. Okay, so D4 to L1. And what else? What other strategy, Dr. Abhay?
No, I think two more things that I will not miss is one is ask whether there is a standing AP X-ray.
Yeah, standing.
It's one of the commonest mistakes I see in the clinic that, and that would be then potentiated by the second thing, which is the clinico-radiological match. Like truncal shift here happening to the right side. On the other hand, the rotation doesn't seem a lot, so this kid may not have a big rib hump. So cosmetically, how does he look? I can see there's costopelvic impingement already. So, is there a collapsing element to this curve? Is there hyperlaxity? So I would put all that together to decide whether I want to proceed and think of doing, bending X-rays, MRI scans, etc., or to just, sit him down and call him after 6 months.
Okay.
So I have one very basic question for all the faculty. I want to poll the faculty right now. So I will tell you what, and then you say what, where you'll do. So what I have been taught and what I always do is when I put up the X-ray in the OT, I always put it up the other way around in a right-sided curve so that the right side comes to the right side. So as if you're looking at the patient from behind. And my mind now only thinks that way because I've been doing it for
That's about your training.
25 years plus. So my question is, in your OPDs, how do you put up? And the other thing is the lateral has to always be like this, pointing this way. I do not tolerate anybody keeping the X-ray pointing the other way. So in your APs, how many keep it this way and how many keep it the other way? Like I keep it the other way. Other way. So Guru Raj, you're the only one.
I don't do this. I usually the way we have taken AP, I put it the same way.
So you put like this?
Yes, same. It's
Actually, one more thing that you always order a PA view for the scoliosis to minimize the radiation towards the breast tissue.
Okay, so this 50-degree curve, 25-degree TL, 28-degree PT, and 20 degrees thoracokyphosis. So these are the bending X-rays. You can see most of the curve, lumbar curve is reducing and it's derotating also, and less than 5 degrees, and PT is less than 10 degree.
T4 to L1.
Yep.
And now, Dr. Bhavuk, you said it's a AR curve. Now, with these bending films in picture, do you think your assessment will change and you will now think it of as a different, you will do a long fusion like earlier you were asking for, or you would now stick to a lesser, smaller fusion?
So I think this much correction, I will also look at the patient clinically now, that this patient may be having some ligamentous laxities and all those things. So that's very common to have, if this much correction is happening.
So, but
I mean, the thoracic curve is also correcting too much, the main thoracic curve.
Okay.
So we have to be very careful about the Brighton score and all those things in these patients.
Let's assume the patient is normal. There's no ligamentous laxity.
Can we have the word of Ranjit and
Dr. Ab.
One AR curve. Does it really makes you start thinking going down to L3 or L4 already?
Not with this flexibility.
Okay, we'll come to that, Vishal. We'll come to the levels. Dr. Abhay, you wanted to make a point.
Yeah, I mean, my question is that if the patient says, I don't want to get this treated, how will you counsel him, Dr. Dalvi?
Okay.
So how much is the primary curve measure?
50.
And the age is?
14. Riser 0.
So if he doesn't want to get you treated today, that it's okay. I'll tell him, we'll follow you up. There aren't too many patients who I would offer surgery at the first visit anyway. So ideally we should document, like unless it's 60, 65 degrees. I'll tell them that given that you still have age to grow and this curve is likely to worsen, you are going to need surgery. But we'll call you again after 6 months. We'll do follow-up studies and we'll see. And then if it progresses, we can operate at that time.
I mean, what is your argument to operate this kind of a curve besides cosmesis? Like if he says, I'm okay with the cosmesis.
No, the cosmesis at this point. So I would tell them that your final cosmesis is what you will be when you finish growing, which may be 17 or 18 or whatever. And if at that stage, so I don't mind, I'll conserve this patient till the age of 17 or 18. And at the age of 18, I'll ask him, are you okay now? And if you're okay now, then we don't need to operate. And boys may not. There are many boys who will say no.
Yeah, Abhay, and to that question, if a patient says, doctor, I don't mind waiting. If I keep waiting, should you or would you have to go longer? How do you answer that time?
Yeah, so for me, it's very easy. There's some curves that are sitting on the edge where my LIV is going to push down to maybe L4. This is not that.
Yeah, this
so
is not that.
If there was one, I would tell him that, you should make a sooner. Of course, you want to document progression and the basic rules, but there I normally inform them that by waiting, this is the only thing that I might lose. So if you're thinking in those terms, then the sooner the better. On the other hand, in this one, I would do exactly what Dr. Dalvi said, that you sit on this if you want and come back when you want. And if he comes asking for surgery, would you offer him surgery with this one data point, Dr. Bhavu?
Yes, I will offer. I will offer surgery.
Yeah, that's what I'm saying. If he comes already motivated for surgery, I will not demotivate. I will not tell him that you don't need surgery. So I will say, yes, this is a good decision. This is a good decision. You're going to eventually need it anyway.
And does a hyperlaxity, a Beaton score being high, does it really change your decision at this point of time? You're saying that patients got hyperlaxity.
But I'm not very surprised with this X-rays.
It can have, actually, it's going to correct very flexible. With 50-degree curve can reduce always.
Yeah.
Okay, so the want of time.
I also want to say one thing for the benefit of the students. Because we made it clear, the AP X-ray is standing, the bend films are supine. Understand? The AP X-rays are standing and the bend films are supine. Just remember that.
Okay, so Arjun, yeah.
So if it's a boy, you should always get an MRI. So there is Sukato study in GBGS.
Understood.
So
Understood.
always a boy with a, even if you're going to observe.
No, I wouldn't say this is a atypical curve, but yes, usually common in girls, but this is a boy, but that's not an atypical curve. Yes, definitely.
So we did a study when I was in Stanmore. There are 4 solid indications for obtaining MRI in AIS. One is male sex, second is left-sided curve, third is asymmetric abdominals, and fourth is all patients taking for surgery. So these were the patients who we got MRI on.
Okay. Sir.
On the flip side, I would do an MRI in all cases. 100%
Same here,
scoliosis,
I do in all cases. So how many of us will offer surgery? How many for conservative in this patient? Offer surgery? Surgery first, raise of hands. So all of us are doing surgery. That's good. Okay. So what is your LIV and UIV in this case? Dr. Dalvi.
So I am following that King and Lenky's finally he understood it.
Yeah.
So I will consider this as a type A1R. I will not get fooled by the bending X-ray. I will still do the LST, which probably here is 3, L3, L2, whatever. I'll have to measure it, but yeah, L2. Sorry, that is the 12th rib. So I will not get fooled and just end at 12 and get into trouble.
So if there is no laxity, then I LSTV. If there is a laxity, I will go to stable. That is L3.
So you here, if there is no laxity, it's L2 for
L2
you.
LSTV.
T3 to L2, I think.
Same.
T3, so proximal, because shoulders sort of seem almost kind of, balanced. So T3 here, you have to be careful of what happens to the shoulders after the surgery. So you have to check that. And lower down, because of it is of this 1AR, I mean 2 or 3.
2 or 3.
3, yeah.
2 or 3. One of them.
I mean, to play safe, 3.
3.
And I think it's also the age you operate. I mean, it's an older patient or it's a younger patient. If it's a younger patient, it's better to air distal because
L2. T4. Same. Okay. So let's move ahead. I'll show.
Any doubts? T4 to L2 versus LSTV, L3. The point here is, do MRI always before doing a surgery? Last substantially touch vertebrae, not a selective fusion in this case, despite the non-structural upper curve and the structural above curve, you go only selective, not permitted because of being an R variant, where the L4 is tilted into the right side of the curve. Then R variants don't fuse short, fuse long. Long doesn't mean going to L4, going to LSTV.
Okay, so this is what I did in 2011. Any problems do you see here? L1.
You never trips, so you went to deeper.
No. L1 it is. L1. Any problems?
Already showing.
Please.
I think it will, as per the rules, I think this should cause you a problem distally.
Distally, it should cause adding on.
Your shoulder also is a little, but maybe that will come again.
Shoulder was okay.
I
T3 to
think you can
L1.
wait. You can wait, and sometimes that adding on which is happening, it kind of may on its own also autocorrect with time.
Okay. I think it's okay. 6 months. So I think hindsight, I agree. We should have gone to L2. So this is one of those in my earlier careers.
I'll brace. So what would you do? Brace. I would brace.
Actually, luckily it got corrected again. So.
So let's just start. There'll be 9 months you see this. Would you want to follow it up again in 6 months interval or?
Of course. I think any scoliosis, whether operated or not, has to be followed up till maturity at the least. And then after that, every 5 years. So there is no patient who you operate to tell him go and never come back.
No, but then when you see this kind of adding on, will you?
Even brace. I would brace the patient.
Directly go for surgery or you will watch?
No, I would not go for surgery. I would not go for surgery, but
No, patient did complain.
I think if I see this thing, I will go and intervene, because I will go up to maybe up to L3 now, because this is going to progress.
So, but if you
And
wait and if you do
This
it
will not
later-
correct. This will not correct. After 6 months, it is not going to correct. Huh? Whatever it is, this patient is going to degenerate his disc and.
Okay, thank you.
What is called add-on?
Unexplained add-on, I agree with what you are saying. Okay. This is a rookie mistake. 1983, he told rookie mistake. Okay. Dr. Dalvi said, na, you should know the linking classification. So because it's already been proven since a long time that you should not stop short. So if you know that's the level selection error, then you should correct what Bhavuk is saying. I understand. That is unexplained level selection. Level selection problems will.
When do you call it like that?
Increase in the angle of the original curve that you operated is an add-on.
Immediate post-op after 6 months?
Yeah, it's a dynamic statement. But if, for example, here they've gone to L4 and the curve was straight, but the lumbar curve actually increased, that would have been a decompensation, not an add-on. So that's the difference between the add-on.
I'm not sure. I think adding on is adding the number to the primary curve. Whatever is your primary curve number of vertebrae, adding other vertebrae to that is an add-on. So if your first curve was only till L1 and then now your L2 is also involved in the curve, that's an add-on.
Increase in the angle of the main operated curve is add-on. Increase in the angle of a compensating curve is a decompensation.
But I have a question for Bhavuk. And if you operate immediately or operate after 1 year, what is the difference?
Because you will add more levels.
In both cases, you are ending up anyhow at L.
No, the curve changes because what happens is that you let a level selection error allow to progress. Right now, your level might be L2, but after a year after growth, your level might become L3 or L4. But later you will end up going lower. Yes.
Despite having major consensus, the debate continues, the fight continues, and I'm sure in 6 months from now, after having learnt all this, you will also be on this side fighting with each other. Wonderful. So the message is, there are typical variants of 1A curve also, and this R versus L, King explained, lanky, objectified, has to be paid attention, and never fuse short in these kind of curves. Add-on can happen. The definition of add-on should be very, very importantly remembered, and follow-up has to be extremely long because things can change before the maturity is really over. So this message, please, from this case, we move on to our next case.
So we have similar case. I think, me and Arjun had discussed this case in SECON. So this is a female of 13 years. These are the clinical pictures. You can see right shoulder is higher. This is the image pre-operative for the patient. One thing is, it's borderline type C curve. Somebody would want to, just term it as a B also, but it is a borderline type C because, this is which is line is not touching. So in my definition, this is mainly type C curve. Lumbar curve is completely flexible, and thoracic is from 64, it is coming down to 33. So this is the scenario. So, Abhay sir, shoulder lateral.
So she presents herself for a selective thoracic fusion. I see this as a S-shaped curve. I don't look at Lenki ABC. Since it's an S-shaped curve, my decision is, should I fuse only the thoracic curve or should I fuse both the curves? That decision is based on multiple things, but purely radiologically, I think she's fit for a STF. Clinically, I guess she's post-menarchal.
Yeah,
So she's grown up. There's not a huge flank crease there. It looks largely like a thoracic, rotation is worse. So yes, I would actively consider STF here.
Selective thoracic fusion.
Yes.
For this.
Same.
Selective thoracic.
About selective thoracic fusion, type 1A, 2A, 1B, 2B are the ones which can easily be used short. It is the one C curve where the selective can be done or not to be established.
So, Sir, what about the L4 here?
No, it's immaterial. Like, going to L4 or going to L3 in my algorithm is if it's a C-shaped curve. In an S-shaped curve, it's either going to be T4 to L4 or a selective thoracic, which will be, in this case, I think will be T4 to T12. I think
Sir.
that would be the...
This for me is selective thoracic.
Selective thoracic fusion. Ranjit? Selective. Okay.
So the tilt of T4, which Dr. Bhavuk explained, is relevant to a C-shaped curve or a Lenki type 1 curve. So it won't be, L4 tilt is not relevant to a S-shaped curve.
Okay. Okay. So this is just to show, just quickly I'll take you through some of the slides where we have, this was a very challenging pedicle for this patient, very thinned out pedicle. We had done MRI was normal. I'll not go into much detail, all those things. So this is where it just Vishal asked me to include, how this navigations and OAN things work. So this is exactly for the same patients where we are doing, you can see almost a thinned out pedicle and we are doing a navigated thing, probably would have been a little difficult to do, or you will have to do a lot of in kind of a technique. So today's time when you have OARMs, navigations, all those things really makes your life much easier. This is another patient. This is another patient. This was not AIS. This patient has neurofibromatosis, and you can see this canal is completely gone. And in all those cases, your navigation would really help you to go ahead. So this is what we did. I did not go for complete SCF. Yes, Bob.
As per me, I also would have chosen this one because as per the definition, the ratio of main thoracic versus lumbar is more than 1.5. I mean, it should be more than 1.2, but it was already much more, more than that.
But honestly, if you ask me, I disagree with this cob angle. Just go back. I think you over your upper end vertebra, you have overmarked it. So I don't agree with that. I don't think this is 64. That red line, I don't think it's supposed to be that tilted. I think this angle is less than 64.
No, it was 60, 60,
Yeah.
64.
So even then, sir, it is more than 1.25.
But this is a classic. So I think here again, this is again, let's see the follow-up, because here again there is this.
So
no,
this is
here again it's rookie mistake. He's ended L3. He should have ended L4.
L2.
Where is he ended? Yeah.
L2.
So I think he has ended.
So I was actually discussing with Arjun that should I end at L2 or L3? That 4 was, I think, for my, it was never.
Have a follow-up of this.
Sorry. So I have now 6-month follow-up this.
No, this patient is going to tilt 100%.
So this is immediate.
This patient will 100%.
I'll show you. This is, I have 6-month follow-up X-ray also. I mean, agreed.
So if you go back to the old, to the pre-op.
This is 6 months.
Yeah.
Barabar. So this patient is going to tell you have stopped short. You have done what is known as the cardinal sin of. Cardinal sin of who? Mo ki Lenki? Mo.
What should be done, what should not be done for
No. Either, like I said right in the beginning, I'm telling it for the 5th time. Either you do STF, means you make sure that the level is STF, or barabar, or thoracic, selective thoracic. Or if you don't, then don't waffle in the middle. Then fuse the lumbar curve also. Then don't end in the middle, because he has now ended in the middle of the lumbar curve, and some of the rotation also gets transmitted if you do a derotation maneuver. So
if you go back to the pre-op, go to the pre-op.
Takes a lot of time to reach.
So see the pre-op, if you look at the sort of last significantly touched vertebra actually is D12.
L3.
D12.
Yeah.
D12 for the thoracic.
Thoracic.
So you can actually stop at D12 here.
Yeah, but I was not, rotation was quite significant in lumbar, so I was literally scared for doing it. So L2 is not most rotated in this. No. No. This is pretty.
So D12 is neutral also and stable also on the thoracic.
That's got more shorter.
So if it is more than 1.2, you can go for SCF. That is what you can easily go for SCF. Even in type C curve, you can go for SCF. This is what, we have now 6-month follow-up of this patient. Fortunately, still holding very well. I have not got this complete standing X-ray because we have to stitch. So I did not wanted to go for multiple X-rays for this patient. So maybe at 1 year, we'll again get the complete scanogram for this patient. So another thing was, you see this in immediate post-op, shoulder was still slightly higher on this patient right side, and 6 months, it's completely balanced. So I have this. Not really, I guess. Patient, if you look at it, is completely fine. Not on brace from day one. So this is what it is. Let's see, what happens. So I wanted to go to this screw, the upper screw, the other side, not gone to T2 only because, pedicle we violated. Despite having navigation, I could not put screws. So I had to remove it. It was loose screw. So I just removed it on the other side.
I want to poll the faculty. How many of you all use hooks? You all do use, no, still? I love hooks because it avoids all this kind of thing. And at the upper end, hooks are very good. They are low profile. They don't damage anything. And you can put a transverse process hook on one side and pull that shoulder down.
That's PJ.
So I use a combination of pedicle hook and the transverse process hook. On the concave side, I put the pedicle, and on the convex side, put the TP, and it gives me very fine tuning, which I can do towards shoulder balancing.
It's known as what he does, and I use it in all my cases, known as a pedicular transverse claw. So it's a pedicular transverse claw, which gives like a full claw-like grip. It is also very good for correcting I just love using hooks.
Faculty, what's your think about UIV here? Would you have gone to T2 or attempted to go to T2 or stopped at T4? Four, no, mostly. So why 2?
So it was because right shoulder was quite high and I just wanted to balance it out. 4, sorry. So this one is.
I wanted to go to finally stop at 4. Yeah.
It was just, on the other side, other screw, I had to remove it. T3. Yeah. Hooks are not available. You really have to specially order if you want to use hooks. Thank you.
Whenever I'm doing a case, the hooks come. You all know.
So, like controversy is there in every case. You can judge, is my case a error or a learning? Can I have? So this, you saw all the experts, seniors here. Still there is argument or there is confusion. That means there is no solution. So there are only principles, no rules. That's why Dr. Shri always speaks about rule breakers. There are no rules, there are concepts. So you have to get them right. And again, whatever you do, post-op might not behave the way you want it. That's why you really have to speak about. You should not. So this was a 14-year-old female, post-menarchal more than a year, TRC closed, Viscer 5, came with this deformity. These are the standing AP X-rays. And these are the standing lateral X-rays. Anything of concern to anybody of you in this X-rays?
Yeah,
This
rule out.
AIS, MRI normal, everything workup done. No. So if it is giving you all lengths, will it change your decision? So let me go. So fine. This is how she looks clinically. Absolutely non-syndromic, normal milestones, no family history. MRI normal, no cutaneous markers. Rest all full workup. Like it looks like okay. So this rotation, yes, she knew that she had deformity since almost 5 years. 4 years rather, sir. This is it. So to have the measures, this is 80-80, right? And I also have in my practice, I also look at this very carefully because this, I have got a lot of respect for the role of pelvic incidence and how it matters my corrections. So I do look at it. I thought somebody would, or the faculty would want it. So I look at this. You can see it's a very vertical pelvis, with the pelvic tilt is very low. So this really is not something is not normal, but then I could not find what is not normal. So with this, okay, these are the bending x-rays to the faculty. Dr. Abhay, what would be your levels?
No, I'd do a traction film and not a bending film, and I would not look at the pelvic parameters
Okay,
in an
traction
AIS.
films is almost looking like the slightly, there's much more
But
flexibility.
assuming
in the lumbar
everything
spine.
is normal, I would offer a surgery and do T4 to L5 posterior fusion. 100% density and 100% pontes in the lumbar. Work very hard on the lumbar and get her centralized.
certain degrees,
Ah.
for bending x-rays are not that useful.
Only tractions is useful. Yeah, fine. Traction is giving that lumbar is mobile. Dr. Dalvi, so what would be your levels for this?
Yeah,
T4 to L5, right?
No, I think L4 I would do because I think scoliosis you should try to end at L4.
Okay.
Right, because you can always extend later, but I think I would end at L4, and I would do a huge amount of posterior release for this.
Okay.
So like really honestly ponte type osteotomies.
Go to L5.
For me, the L4 is much to just to leave at L4 even after correction.
Okay.
And I would discuss to leave L4, but then I would see that.
Dr. Arjun?
To stop at L4, I would need an anterior surgery and then do a posterior balancing.
Arjun, what would be your levels?
So your L4 is out. It's because it's out of the staple zone. It's completely, so the whole big construct is going to be on a, where there is already a tilt. I would go to 5 here.
5. Kshitij? 4. And you will do an anterior for this first?
Because, I mean, my teaching has been that, for even normal curves which go to L5, you might as well do it. They are not going to stop.
So you will stop at 4, Dr. Vasavada, Professor Vasavada, where would you? L5. So maximum for L5. Bhavuk?
I have to see, no, L5 is a must. I'm thinking of going beyond L5.
Why?
Because I have to see whether the facet, what about the facet? The facet of the L5 S1 seems open on this side. If on the supine films, on the prone position, it is not getting corrected, that means the facet is dislocated.
Okay.
It's called open fracture, open dislocation, which is similar to degenerative scoliosis.
Okay.
Then I have to go to the pelvis.
Okay. Dr. Yes.
So before we talk about what we will do, can I hear from all of you what are the specific challenges that you anticipate in this case, and how is this case different from the principle that we have been studying since morning? Dr. Samir, and then every one of you. Why don't you tell us about your challenges that you anticipate that is making your surgery more aggressive and difficult, and how is it different from the other case?
Firstly, it is extending over the entire spine, right? We are not even selecting a level. So the whole surgery is good. Just the exposure is going to take 1.5 hours or 2. The second thing is that it is very severe and rigid, right? So the number of levels, etc., much more. I think that would be the main thing.
How do you make this surgery better? Like, what are the preparations that you do?
So theoretically, if you ask me, you can try halo gravity and all those things, but practically, I don't use them in my practice because I can make it supple by using different osteotomies. I mean, small osteotomies. I'm faster. I can do it, and I can achieve all the results, with the halo, which I could achieve intraoperatively. So I have stopped using halo for all these deformities. I have my own indications, but otherwise, for this thing, I can achieve everything.
So majority want to go to L5. Vishal?
Different ballgame. Blood loss is more, time taken is more, anchor constructs is different. You have to make them supple, otherwise you will transfer the implant stress on the cord. So this suppleness is all about relief, and then comes the reduction maneuvers, for which you heard from the masters. Halo pelvic traction is one among them. Traction view tells you about beforehand. Pontes release, somebody spoke about, and of course various kind of osteotomies. before you attempt any reduction group. Dr. Abhay, what challenges do you think?
I think the lumbar rotation is the biggest challenge. The lumbar spine is apex is way off. Even to get screws from the back is not going to be easy. So I'll be very conscious of that, and like that's why I said I'll do 100% implant density in the lumbar, 100% Ponte in the lumbar, and maybe uniaxial screws.
As Bahuk said, he doesn't use a halo gravity or a halo in these patients. But for the beginners, like Dr. Abhay was saying, to get those screws in those lumbar apex will be very difficult. But if you use halo gravity traction, they will, once you put on them a traction, they derotate. And then it becomes easier for you to get anchors into these highly rotated vertebrae. And it doesn't require or like any other case like neurofibromatosis or someone which has a very rigid 120 degree curve in thoracic spine. Here you require hardly 2-3 days of traction, and then you can get a much better, and the surgery becomes much safer with halo gravity traction applied pre-operatively. So for Bahuk, he used to use when he was not that confident. So that's what I would say for all of you, for beginners, halo gravity traction is a boon in these patients, and all of you should know how to put a halo and how to use a halo gravity traction.
Sorry?
Yes.
Yeah. I mean, all 100% cases MRI and neuromonitoring.
Yeah, should it? He had some, what are you saying? 4 pelvis. Okay. So there are smart, so this is what I did. You think it is right or wrong?
No. This is.
Yeah. So I got all the.
So there is a dictum that we should not be stopping at the apex of the curve.
Yeah.
So whether we talk about the coronal plane or we have to think about the sagittal plane also.
But we just heard Shriji was saying that that's an error. There's no problem stopping at D12 or for the matter.
No. I'm saying that your PI was less. That makes the L4 the apex of the lumbar curve, sagittal curve.
Yes.
So stopping at L4 is a mistake for
That's
me.
exactly what I want to highlight when I showed this X-ray in the first. I was expecting somebody to catch it up. So you always don't just look at the AP X-ray. Look at this lateral X-ray. So this patient had a very high PI. So I should have respected that more than my coronal plane. So as science goes it, like you say, rookie error. So I went ahead, I got all osteotomies right, everything massive, beautiful correction in the AP plane. And this happened after 1 year. Now what? 1 year she comes back. You can see very well my screw was plowed out of L5 because look at my PI.
You stop at L5.
L5.
The problem is not because of the sagittal plane. The problem is because the facet joint of the L5 is still open.
This is a point which I realized in retrospect that there is because till I faced this couple of years ago, I did not know that there is a value of L5 as one facet opening in a case of AIS. Next, if you look at my X-ray right now, look at the lateral X-ray. The pelvis has become back to vertical thing. So I did not respect the pelvic incidence, and hence I had to go ahead and I just revised the lower part after 1 year and got her balanced. If you see right now, I've got my pelvic incidence balanced. My apex right now is well respected at L5 and my whole plane is balanced. So always just don't go in and see a curve and think that, well, you will correct everything by all osteotomies. Okay, I totally believe like what Dr. Bahuk said right now. I believe in only releases. I got everything right, but this point is very important. Look at the 5S1 facet and please respect the sagittal plane because they can give you boomers like this. And if you look at the whole thing, the whole picture, right from pre-op to immediate post-op to 1 year post-op to after second surgery, now she's balancing. Again, look at the pre-op X-ray and the last X-ray. Look at the how the sacrum is. This respects it and that respects it. This did not respect, it failed. It failed. So this is an important point. Always look at this. Oops.
Time's up.
No. So just he has asked me to cover my correction manuals thing. So for a correction manuals, anybody in the world only has these 5 things. All of us do only compression, translation, all these things. Nothing new. The way you use is more important. So this is again, I'll not spend time on this. Release is everything. But what Dr. Abhay mentioned right now, please respect this. Remember these few tenets. Always concave is the lengthening side. You don't have to do a total facetectomy there. Just take out the IAP as what Professor King mentioned. Convex is the shortening side at any level. So remove both facets. You can ask me why? Because it is bleeding. I do have admit it's going to bleed. I won't avoid the bleeding. So convex side remove both bones because that's a shortening side. Concave side just remove only the IAP. Lumbar spine is lordosing. So always remove bilateral facets. If you go to L3, L4, no gastrosegmental segmental screws there. You have to put screws every level because you're going to create the lordosis. You're going to respect the sagittal plane. Lumbar spine always lordosis. So you have to have posterior column osteotomy. Severe rotation, I start with the convexity because it is easy for me to put the concave screw if I put the when I put the convex side. So in type 5 types lumbars, I call convexity. Rigid curve, you release and you can rotate, but stiff curve, release, no rod rotation, it is sequential reduction and final DVR. Flexible curve, you do anything is going to correct, but when you have a rigid curve, release, sequential reduction, and respect PI whenever you go to the lumbar curve. So like what he said, when in doubt, do STFs. Don't try and go down because you go down, your pelvic incidence plays more importance and you might end up with failures. So again, this few surgical tips in production. So I always use this when I put the lumbar screw first, and when I'm in worry, I put the concave UIV screws and I distract and keep it. The technical tip is that the moment I keep releasing, gradually I keep distracting the concave side and keep monitoring the IONM. If IONM changes, I stop. So do this and do it only after you do a convex release. Don't, surgery in scoliosis is a surgery of releases, not force. So release the convex side, put concave, distract the apex, and gradually keep on doing it. In the meantime, you can keep doing the lumbar spine. So this is how I've got 2 screws out here. So then I do the pontes and do the final. So look at this. So you see, this was a larger lumbar curve. So I put convex screws on the lumbar side, put my convex rod inside. That derotates my spine. I can put my concave screw easier. Meantime, I have put the thoracic concave. I am gradually distracting it and under constant ION monitoring. So if anything goes stop, I can stop there. Once this is done, I got a fairly good correction. Then I did my costotomy, and Kshitij, I always follow this. It is not with the pelvis. I do the T and see if it is balancing because that gives me what I have done to the fusion mass, not to the pelvis. So I see and balance this, and this is my ultimate correction. I think I'll stop this. Thank you.
Thank you, Anjit. Three questions for the speaker so far. There are 3 cases so far, 1A, 1C, of course, the result was 3. Yes, please. Any role for acting display anterior?
Any role for anterior, all the speakers. Dr. Samir sir, anterior, role of anterior in such rigid cases, and then the speaker.
Yes,
Actually, there was a time when yes, but now with posterior release also you are able to get good correction and all pedicle screws. And the problem is anterior release means what? You have to do both sides. For this patient, for Ranjit's patient, you would have to do a thoracic on one side and then the lumbar on the other side. Yeah, you could have.
So in today's surgical expertise and armamentarium, the role of an anterior release or anterior fusion is only for TRC open, younger patients, large goes more than 90 to 100. Rest all you can do from the back. If you have TRC open, don't. There is still role of anterior surgery. There is anterior release, anterior fusion role, but TRC is closed. Whatever rigidities, you can go for the back. Just think of it. Only 2 things are going to hold the vertebrae. It is the disc, the annulus. You can release everything else, right? But one thing you cannot control, that was vertebral body wedging. Body wedging you cannot control. So in my osteotomy talk, I had a picture. You can do extra vertebral releases and make rigid curves flexible. No, so it's possible. The TRC open. Yes, you have to go anterior.
Yeah, I wanted to ask Dr. Bhavuk, can you explain that L5S1 facet open? How does it?
So I'll tell you. So when you have lower, Bhavuk is loading. Okay. It's okay. So whenever you have got lower lumbar episis, like this curve, which ended at 4, but the other thing was tilting, you should always expect there is facial tropism. This is facial tropism. They are so-called AIS, but they behave differently. This patient of mine failed because I forgot to look at, I did not realize the 5% tropism, plus I did not respect the sagittal plane. I stopped at L5 with a vertical pelvis, bound to fail, failed. So these are things which don't come routinely. You get it once. If you see, the eye does not see what the mind does not know. So if you know it, you will pick it up, you will let it not happen. What's pelvis? Pelvis.
Okay, we move on to, we change our gears now to a, yes, please.
Yes.
The first case was at 10 years, it was noticed. One, I wanted to ask, can we would have done an growing anterior, so which sir was mentioning, at 10 years, so we could have balanced it before he took a very rigid one.
Arjun, we have Arjun, who's been a pioneer in pediatric scoliosis, and Dr. Abhay to back this question. What is your cutoff point when you would not consider growth rod? Because the first case was detected at 10 years of age. Would growth rod not be a better option rather than doing a definitive surgery?
So growth rod is a good option, but it may not be the good first option. So, I mean, if you have a child and the child comes to you at like 4 years, probably not the right time to put a growth rod. Probably good to sort of try to defer the growth rod till the child is a little older and try to manage with either casting, which is the first treatment option. And then after that, try to bridge with the bracing and then go for the growth rod. Doing the growth rod early has disadvantages because one is there will be a diminishing lengthening with time. So there's a law of diminishing returns with each lengthening. So you will achieve your whatever, and then after that it's not going to budge much. The risk of complications is very high.
So what age is growth rod like the ideal?
So I think that 8 to 10 years is when you want to implant, not earlier if you can avoid.
Dr. Abhay, what is the cutoff that after this no more growth rod?
Basically, don't do growth rod. Full stop. Though I've done 100 growth rods, it's a surgery fraught with complications. It's an imperfect surgery. It's not a solution. It's a necessity. So don't choose growth rod if you can avoid choosing growth rod. Once you have a 10-year-old kid, and what you mentioned was that it was noticed at 10 years, but clearly it was not 50 degrees at 10 years. So 20-degree curve at 10 years doesn't become an indication enough for growth rod. At 14, even if a curve is 50 degrees, you don't want to do a growth rod. The VBT is only mentioned to be condemned. Yeah, so VBT is again not what you're mentioning is what Dr. Appaji's solution was, right? So again, that's a very edge of the science solution right now. They themselves, I mean, Appaji does a great job and everything, but as far as we are concerned, who are ordinary surgeons, you should not be working on the science or a new product that has not been proven in the test of validity.
It requires a longitudinal follow-up to really come up with results. The concerns are about screw loosening. The concerns are about teether going on. Yesterday, Dr. Bhavuk mentioned me something very interesting. You should put a implant only through that path to which you can bring it out also. Only those implants should go in which can come out to the same path. Screw loosening anteriorly, thorax 1 or 2, it's a challenge to bring them out. And how do you reconstruct that? So that challenge, if it's a bigger challenge, you better don't put an implant. So I think found that was learning from our yesterday's talk.
And another thing is that this mobility is so-called spoken about. We have a patient going to L3 during one market portion. You cannot say that that's the argument to use this modality. It is because it was at 10 years. Yeah. If you have done it at 10 years, child is still growing. Yeah. They have a
Growth modulation.
Yeah. That surgery has been helped and it would have been good because okay, so your question was that does doing a cross motion at earlier age prevent a larger fusion leg? The right question.
Yeah, Mike, please.
Right? So doing a surgery earlier to prevent a larger surgery is not rational unless that curve is known to progress. So most of us, if want to wait, would have waited for some more time and fuse the patient than going in and doing a growth rod now. Right? If there is documented fast progression, yes, worthwhile. If not, there is no harm in 50
Also, there is something called.
Actually, can I just put it in perspective? Let me just put it a little in perspective. So see this vertebral body tether, okay? The way it was, and he's not there, so maybe it is not fair, but whatever. The way it was presented by Dr. Appaji, or the way it is done, is completely unrational, unscientific, unproven, and can be challenged at any place in science. So you cannot do the vertebral body tether for the cases which he has shown, and he's just made excuses of results, right? Whatever results are the excuse of result. You follow up those patients, they're all going to fail. Simple thing is, if this tether worked, why would people be doing fusion for the last 50 years? Super scientists and thought pro. See, this has been tried earlier. So earlier they thought of the same thing, tied with ropes, tied with this. It failed, and therefore people started fusing. Harrington also didn't start with fusion. So therefore, in the larger picture, this VBT is a rubbish. Having said that, if at all, in your specific instance, if you have a 10-year-old child with a thoracolumbar or a lumbar curve of say 45 to 50 degrees, that may be the slimmest possible indication for a VBT today. Do you all agree that if at all you want to do a VBT, then that would be the slimmest indication, but nobody else, right? Nobody else. Not a 14-year-old and not a 40-year-old curve, because a 20 to 40 curve will go for bracing, and more than 40 goes for observation, and more than 55 goes for surgery. So in this specific instance of a 10-year-old child with a 45-degree curve, you may consider the VBT. May consider.
No, sir, her question, the reason why she had a, as a reason why I think you have a confusion is because you are thinking that a VBT can be removed. Correct?
The VBT cannot be removed.
No, it can't be. All right. So the how it works is that there are screws and there are tether, and only way for it not to work is the tether breaks. You cannot go inside and remove it. So it is growth modulation. So what it means that you have to plan in such a way. Have you seen growth modulation in the limbs? You have to calculate कि कितना growth बाकी है, so that the limb will end up being straight. Correct? In genu valgum. So here you have to do it for a 40 to 60 degree curve with the right amount of growth remaining, so that in the next 2 to 3 years the spine ends up being a little straighter. What will happen if you do VBT for a curve that is much younger? You will overcorrect, because the growth is going to go beyond, and the right side curve become a left side curve. What will happen to a VBT with no growth remaining? Nothing. It is going to remain the way you have corrected, or the tether will break because it's non-fusion. Cob will get added.
Okay.
So that's how it works.
Okay, thank you. I will move on to Bhavuk's case.
I think I have kept it simple. The standard type 2, Lenke type 2 cases, double thoracic curves. So
double thoracic. Now we are looking at a challenge of selection of UIV. So refurbish and reflect upon what we spoke this morning about how to select UIV. The question is coming back.
Yeah, anyone from the audience, delegates? Fusion levels.
Right shoulder up.
Here, I think the left is up.
The X-ray should be reversed.
Right is up.
If it is right-sided curve.
Yeah, right side. Right go right up.
At the same level.
So that's why the X-ray should be opposite, because it's a pattern recognition thing that you keep seeing again and again.
Fusion levels.
Yeah. So double thoracic also, there's no lumbar curve to explain that the shoulders are almost neutral. So, and the apex of your thoracic curve is slightly low hanging, which gives the proximal curve a lot of mileage to produce itself. Long story short, I'd like to include the PT in this fixation.
Proximal level, UIV.
So maybe 2 for me, T2.
But right side is up. Right side is curved up. Right shoulder is up.
I think they're at the same level. I think they're at the same level.
No, this is bending. These are bendings. This is bending.
That's right. And that right shoulder is up.
So almost at the same level. Lateral shoulder is little higher.
So the what Kwan's lecture was, you have two balances. One is the medial and the other is lateral. Lateral you don't have much control over. Medial you have some control over, because you can control the T1 tilt. So called you can control the T1 tilt. But
so here you can go D2 to D12.
Anyone? Anyone from the audience? We can actually see LSTV is going to L1 or D12. D12. LSTV is good. So LIV is sorted here. We are not looking at a C modifier. So the LIV is sorted the UIV with level shoulder, right-sided curve. Again, Dr. Abhay has mentioned about this. Level shoulder, right thumb. Whether to go to T2, to T3 or T4. And under correction or correct it all. Sabi sir?
No, 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 1 second. But Bhavuk, this is a standing bend film. Huh? This is not a supine bend film.
Yes.
Look at so that is anyway. So what is your question?
Yeah, levels.
Because I'll tell you, because it's a standing bend film, because see the lumbar is barely corrected.
These bending films, they are supine.
Supine, but then it's not been taken properly because the compensatory lumbar curve is hardly got corrected. I mean, normally one would.
So, I mean, in Malaysia, I think this group who was speaking, they actually do supervised X-ray for the bends. They do a supervised side bend with the maximum effort to judge, because, like I said before in the morning, assessing proximal thoracic curve is notoriously difficult. How you check it on lateral, because lateral shows white out. Bendings you can't judge. True flexibility of proximal thoracic curve is really, really hard to judge. So, 30, so then it's like
But the
kind
important
of
thing
tough.
is that you have to look at the shoulder levels.
Yes.
If they are same, then you have to think that probably there is a proximal thoracic
Proximal,
curve.
yes,
So,
correct.
So the upper one will be T3 for me in this.
Why not T2? When do you choose T2 and when do you choose
No, if the shoulder was completely like this, I would have used T2. But I think because this is just above the cutoff. Now 25 is the cutoff, and this is 30.
Yes.
So, but as Kriti is saying, proximal curve, whether it is structural or non-structural, is very difficult. Any base for me, if it is level shoulders, it is a structural curve and T2.
Yeah.
Because stopping at T3, sometimes it's very difficult to control. So level shoulders T2. If you have a right shoulder which is little higher than the left shoulder, then T3, maybe significantly higher than T4. Otherwise, if level shoulder, PT is always structural, because you have other criteria to have structural curve or not. Wedging of apical vertebra.
Recording in progress.
Profile whenever possible. Going to T2.
Recording in progress.
Profile whenever possible. Going to T2, it's more. Third is cost, adding on screws to it. PJK is higher with T2 than T4.
And there is a chance of manipulating the T1 tilt, in the opposite direction also, if you're going it a little bit higher.
So this is not published, but I mean, I worked at Stanmore, which is a very high volume scoliosis center. And they said if you end at T2, those patients come back with a lot of neck pain. But I didn't see it published anywhere, but they used to always say that there is more neck pain if you don't end at. Maybe.
But then, the other thing with going to T2 is we don't leave out enough compensatory curve above to itself. Whatever shoulder imbalance has been left out, that can actually compensate. But
So this is the debate. Ultimately, the debate is all about between the three, choose one. T2 or T3 or T4. If the right-sided main thoracic has a right shoulder up, go to T4. If the right-sided main thoracic with a level shoulder, go to T3 or T2. But if the left is up, which means right-sided main thoracic and left shoulder is up, then definitely go to T2. How?
So I have gone to T3 here.
T3,
yeah. T3
level shoulder,
yes.
And is that
T3 only. T3 transverse process and the T3 pedicle.
Perfect.
See the lateral view.
T2 के ऊपर है ना वो.
नहीं वो सुपर पेडिकुलर है इधर ये.
T3 के ऊपर. T3 का TP.
This is another type of type 2, almost the same. Here now you can see that the left is up. So the message is that we have to go to T2 here. Okay.
Again, this is atypical AIS. If you see, for his kyphosis and
Yes. So, but it is type 2 plus. This was the MRI. It was normal. But here I have gone up to T2.
Yeah. Thank you. So we have seen that. Yes, please. Question.
So fine. So fine.
उसको he can go first. कर ले.
So we have one Kshitij's case, but because Neeraj has to leave, we'll have him give his talk on pedicle screw in a rotated deformed. Yeah. Rotational maneuver. Yeah. So you do pedicle screw in a rotated spine. How to put pedicle screws in rotated spine. That's a part of workshop also. The challenge is not only limited to the rotation of the vertebrae, but also they are and then any questions so far? Anything that you want to hear more? Our faculty can actually have a breakout session with you guys. If there are 4 to learn a specific technique, specific concept, or anything specific that you want to see, the laptop or faculty is there, please utilize their presence.
Extend mode में ये रहा मैं करती हूँ नहीं लग रहा है ऊपर डायरेक्ट So उसको दिखाना पड़ेगा. Okay. So basically, this is a talk on pedicle screw in scoliosis. I'm sorry to break the sequence, but I have to leave. So the learning objective out of this talk is to learn safe freehand insertion, entry point, trajectory, palpation, how to do it, understand what navigation actually is, and how an O-arm can run, decide pedicle by pedicle, and when guidance is worth. So these are all basic things, which we all need to learn from this talk. Intraosseous or not, and you want to achieve your reduction via DVR or a very manipulative maneuver. Sometimes you are not screws up, so it's more or less very important that you don't miss out on all those things. Particularly apical screws where there is a rotation which is maximum. These are 4 gradings of how the pedicle screws should be. The large cancellous channel is grade 1. The small cancellous channel, which is around 30% of cancellous channel, which is grade 2. Type C, which is cortical channel, and finally the absent pedicle channel. So why scoliotic pedicle is different? Because pedicle width is limiting dimension, and as your curvature grows, pedicle's length or pedicle channel start narrowing and narrowing. So type C and type D are about 10% of pedicle in a scoliotic curve. And rotation sometimes moves entry point, but it does not move the pedicle. So you have to keep in mind that your pedicle remains more or less static as compared to your vertebra, but your entry points does move. It is always difficult, probably one of the most difficult part, to insert a concave rotated vertebra pedicle screw in your spine. But you have to perceive your spine as a column. You should be having a 3D anatomy, that how your
pedicle is related with regards to your posterior structures, because you are only be able to see the posterior structure. So you need to have a 3D reconstructing anatomy in your mind, pedicle by pedicle. So sometimes we do keep, CT scans of our patients when before this OAM came into operating room, and every pedicle were marked, from where we want to start entry and how should we go. You also need to keep in mind how is the rotation of your pedicle in your spine, so that you know that at which angle you really want to enter. Not only that, you will have to study your pedicle anatomy of your patient. Every pedicle will be different in scoliotic spine. Sometimes it is convergent, and if you see, sometimes it will be divergence. This is a divergent pedicle more or less. So you will have to study each and every individual pedicle before you start your freehand entry point. Not only that, the angles will also be different between two pedicles. So these are some of the very difficult pedicles which I have actually shown in one of my talks. So want of time, I'll just go into quickly. So the importance to know that pedicle is, if you are far lateral in thoracic spine and your spine is rotated, the most important structure lies there is aorta. So if your freehand pedicle screw is going misplaced laterally at apex in particular, you endanger entering into aorta. And if medial at the concave end, most of the time spinal cord is abutting the pedicle screw, and even a minor breach can lead to neurodeficit. So always try to be within these 5 points of a cylinder, considering your pedicle as a cylinder. Topmost is entry point, anterior is anterior wall, and then the four walls of your pedicle, so that you are always into this cone. So the base of freehand entry point is, as I said, you must know that what is your pedicle looks like in a particular patient, and where are your entry point and what is your angle. Without that, it will be very difficult to use your screws. So thoracolumbar pedicle screws, there are different techniques to use. One is freehand technique, which we use routinely without just by entry point. Then modification of it is a funnel technique, then a ball tip technique, and finally it comes the image guided technique. And now we do have a 3D reconstruction model, 3D models also available. Dr. Bauk himself has published a paper on 3D jig, wherein they form a jig beforehand if you don't have an OAM, and you can use that as a guide. You should know your entry point in freehand technique and trajectory of the patient. This chart is probably everybody has known that where the pedicle lies. Roughly to remember, as you go proximal, the more lateral and distal entry point starts coming out. Keep more or less the midline of your transverse process in your view to start your entry point. And as you go downwards, I think the pedicle entry point becomes much easier to do as you go in near the lumbar spine. We always use gear shift. Gear shift is a lanky probe, which is a blunt tipped curved probe. So you always take an entry with your blunt tip going away from the canal, and once you enter 20 millimeter, or roughly you have crossed the pedicle, you turn it as a gear, and then you enter the vertebral body, so that this blunt tip will never cross the cortical bone, and it will try to remain within the cone of the pedicle. The ball tip maneuver, which I personally always prefer to use, wherein around your entry point, you use a diamond bar and open a large portion of your posterior cortex, and you find that soft spot in the cancellous bone. Then you use your ball tip. Gradually you keep on crushing your cancellous bone, and that ball tip automatically guides you from the bone. So it is something like this happens. If your ball tip is such a not very flexible but not very rigid tool also, you start entering into their cancellous bone. If it touches the hard cortical bone, it will automatically get diverted into a cancellous bone, and then you can use your tap and screw over it to have your thing. So you always have to keep your exposure in your mind. You want to expose complete. Actually, I always do a capsulotomy, and most of the apex you will be doing your Ponti's osteotomy. So you will be able to actually feel your pedicle in those cases where you want to enter. You always have to keep the sagittal orientation of your pedicle in mind. You can use either a direct lateral straight technique or a anatomical technique, depending on. You will have to keep your angulation. Rough rule is, your pedicle probe or the sagittal angle has to be at the perpendicular with the angle of your lamina. So that is the principle you have to use, that your pedicle more or less will go at the angulation of your lamina. This is what So these are the situations where actually your freehand things just runs out, the pedicle width which is below 3 mm, or a cortical or absent cancellous bone, severe apical rotation where the entry landmark no longer sit where the eye expects, the concave apical thoracic pedicle screw specifically between T4 to T8 with the aorta displaced posterolaterally. The congenital and dystrophic anatomy, revision surgeries, the surgeons early in the learning curve, and these are indications for a navigated guidance. So intraoperative safety, what actually protects the cord, the palpate the track with a ball tip probe on all four walls, and in doubt, use your trigger EMG as much as possible. Use your multiple monitoring. SSEP is very important. Most of the time we only use MEP, but in scoliosis always also combine it with SSEP. Monitoring changes is a stop signal, not a note to record. So if any change in your monitoring, always stop, evaluate whether your screw is going right or not. Have a bailout for pedicle that will not take a screw in out in trajectory, which is most of the time we use. And as Dr. Dalvi Baug, they all said they keep a hook ready if you cannot negotiate pedicle inside. So the guidance spectrum is freehand mainly uses the tactile feedback, no setup, no radiation to the team, and entry is more or less operative dependent. If you want to go fluoroscopy assisted real-time 2D confirmation, radiation to surgeon and team, and only in two planes. 2D fluoroscopic navigation, again, in no axial information, and that's where the OARM and 3D navigation comes into play, where you can have a true axial anatomy. Robotic assistance further increases your accuracy. So this is how it looks like. I'll not go much into detail because I've already shown this OARM thing. This is one thing which you always keep in mind whenever you are using a C-arm fluoroscopy. You are exposing yourself to a higher radiation. But as you move towards navigation, radiation goes to the patient also more. So use your spins and your 3D navigation very judiciously so that patient is also not much harmed in your patient. So these are just the example that how we have been able to successfully complete this scoliosis in a very difficult form. What navigation does not fix is it does not choose your fusion level, it does not correct the deformity, it does not replace neuromonitoring, and it does not teach your anatomy. So you have a free hand also as a bailout option, even if you have a navigation in your armamentarium. Finally, a type A or type B pedicle where there is significant cancellous bone, free hand is quite easy. Concave apical thoracic type C, type D, try to use navigation as much as possible. Congenital dystrophic or revision anatomy, in today's time, I think it is not right to use freehand. Use 3D navigation possible. Use as a whole case, mix and match. You cannot spin every level, so use mix and match. Lumbar spine, easy to do your freehand technique. Apex, use the spin and reduce the exposure to patient. So whenever you find it difficult, check with your 3D imaging. So take home, the scoliotic pedicle is not a small normal pedicle. Plan every level on preoperative CT and keep your freehand technique sound. Navigation adds three-dimensional information at the moment of insertion. Every navigation error is a registration error or a movement error. So you will have to recalibrate at that time. You have to touch point on a known anatomical landmark to see where is your accuracy, and use guidance where the anatomy demands it. Palpate every track and have a rehearsed response when monitoring changes. Thank you so much.
We are going to be doing all this on the pedicles out there. Thank you. Suresh, you please, sir. So we are going to be seeing a similar kind of discussion about level selection and approach in a thoracolumbar oblique lumbar curve. And the principles of what we heard is how to navigate through a rotated dysmorphic pedicle is what we are going to be doing on hands-on while faculty will be supervising that thing. So be ready for the action on the models there. Also, many a times we will not be able to put a pedicle there. So sometimes we have to choose an extra pedicular in-out-in technique. After this, we are going to be hearing about the in-out-in technique. The Neeraj and everybody else, the tea and coffee will be served in 10 minutes after this talk. We have Mumbai Vada Pav from Lilavati Hospital Canteen, and of course the Gujarati Dhokla of the Mehta family from here. So please don't go. We have a tea break after 5-10 minutes after this case.
So Lenki 5C curve, okay. 14, 15-year-old girl, adolescent idiopathic scoliosis. This is how she looks from the back. That's the forward bend. This is how she looks from the side, right? This is her curve. Lateral X-ray, thoracolumbar spine is not kyphotic. It's a lumbar curve, right? These are the benders, quite flexible, right? So this is how the curve is. So if you have to choose fusion levels for this patient, what are the rules for selecting fusion levels for a Lenki 5C? Rules means guidelines. Anybody? No, they listen to the talks, no? Anybody?
Goals are simple. We want to stay.
See, it's very easy in lumbar curves, okay? Or 5C or 6C, everything is end vertebra to end vertebra, correct? So you get which one is the lower end vertebra? This is the end vertebra. Most tilted to most tilted is your levels for fusion. Whether you're doing an anterior surgery or posterior surgery, it is most tilted to most tilted. The problem for the most tilted at the lowermost, then you check whether the lowermost level, how is it with respect to the central sacral vertical line. So that's the next step. So when you have chosen the lower end vertebra, how is it in relationship with the central sacral vertical line? So that is the coronal plane displacement. And how is it rotationally, right? Most of them it is rotationally neutral or yeah, correct. So many times the lower end vertebra is not touched by the central sacral vertical line. No, it's little off. Still, you will be able to stop at the lower end vertebra for Lenki 5C as long as this comes in the midline on the bending. That means this part is flexible. Got what I'm saying? So when you bend this way, this comes in the midline. If it can come in the midline and derotate, then you potentially can stop here only at L3. Correct. And in Lenki 5C curves, always your idea is, are you going to stop at L3 or are you going to stop at L4? Correct. That's your controversy. So how do you make your decisions? You have L4 as your end vertebra, then there is no controversy. You will have to go to L4. Whether you do it from anterior, whether you do it from posterior. Because the recommendation is go from end vertebra to end vertebra. You'll have to fuse it. So if L3 is the end vertebra, then you can potentially stop at L3 provided the L3 is either touched by the central sacral vertical line, or if it is not touched by the central sacral vertical line, it can be brought to the middle. Okay. So how can you get it to the middle? Either you check it on bendings, or sometimes you can do tractions also, right? To see whether it is derotating and bending forward. So here you can see when you bend, if you draw the line, L3 is coming in the midline. See how it is looking a little neutral, nice neutral. So L3 potentially can be a LIV, satisfies everything. Situations, sometimes the L3 is too far off. So some papers say that if the central part of L3 is more than 3.5 centimeters of the central sacral vertical line, it is a bit too far off for it to get in the midline. But these are all guidelines, these are not rules, right? Some people would still be able to stop at L3, even if it is very far off from the midline. But there are this thing is a controversy in literature, okay? What I'm talking about is not a written rule, and all 4 or 5 of us will do it differently. But these are just different ways the thought process is. So first thing is always the end vertebra to end vertebra. Lower end vertebra is the question. Is lower end vertebra L3 or L4? If lower end vertebra is L4, go to L4. If lower end vertebra is L3, see how far away it is from the central sacral line. If it is touching, you can stop at L3. If it is not touching, then see if it can be brought in the midline on benders or tractions. If it can, then you can potentially stop at L3. Some situations, in some situations, you will find that the L3 and L4 both are the lower end vertebra. That means the disc between them is parallel. If the disc between them is parallel, then the cob angle that you draw from here to here or L4 to here is the same. It won't be different. No, then that is kind of a controversial situation, but that also sometimes can occur. This patient had a lysis at L5. All the more reason for you to stop at L3, correct? So she had a lysis, right? So the other mistake that is made is, going higher than the upper end vertebra. If you go higher than the upper end vertebra, you end up in the thoracic spine. That's the same problem what would happen in a selective thoracic fusion if you go lower than what you intend to. So that causes more problem. Here is the DJK that happens if you go higher than the upper end vertebra, right? So, okay, so what would be the level here? L3, most, yeah. D10, right?
D10 to L3.
Okay. So this is how she is. So we stopped at L3, horizontal, lateral profile. So here again, it's lumbar spine. Again, you cannot have a good AP X-ray and have this flat. Okay, it would be terrible if your lateral X-ray looks flat. So you need to have good lumbar lordosis when you are correcting the curve from the back, right? So this is how she is. This is how she's standing. So all this is okay. Anything question? Divya.
How do we bring the chosen LIV? Now, during our planning, if we have
video
chosen
play
L3, do you have video?
There is a video.
If we have chosen that L3 is our LIV, but it is not really centralizing well, then there is a technique called DVR, which is direct vertebral rotation. It is one of the reduction maneuvers, one of the correction maneuvers that surgeons use it by using implants, reducing the rotation to again save the level and stress on the lower implant, which can lead to decompensation or add-on. So this is one maneuver that every surgeon handling scoliosis in lumbar spine must know how to derotate the spine, because this one maneuver can not only save levels, you may not have to go really down, but also can prevent the stress on the implant, can prevent the add-on chances happening. And that is why derotation, particularly at the apex and the LIV, is something that we all must learn. We are going to be seeing a video of, in the same case scenario, how to do a DVR.
So this is how you take that horizontal plumb line, sorry, the C7, CSVL, how you create interop, the bar, which Dr. Kwan also showed and Ranjit also showed, because you want to know how your LIV is with respect to the pelvis, and Bhavuk mentioned 15 degrees. So remember that, you in the lumbar spine, the lower part, your lower instrumentation, if it is tilted more than 15 degrees, that's a problem, because all the discs get wedged down. So you can show the video. So this you can recreate by, taking a rod and then connecting it to a vertical rod with those connectors. Video hai na usme? Right. So the steps in this would be, all right, so that this is the concavity, that's the convexity. In the concavity, you can put polyaxial screws, but convexity is your main side for correction for Lenki 5C. So I'll use uniplanar screws on the convexity. And remember what Dr. Dalvi said, getting a correction from posterior is much harder than doing an anterior approach. So you'll have to do, even though this is a flexible curve, you will have to do kind of quite a bit of things from the back to get the L3 completely horizontal. So you use uniplanar screws, use high implant density, at least on the convexity you will have to use, because you want that forceful correction to get the LIV horizontal. Do ponties at every level. Now, you would think that this is a flexible curve, so it doesn't require ponty, but the ponty really helps to get the lordosis as well, because this is a shortening procedure. Plus, you are going to get the correction to get the LIV horizontal. So you need that hexagonal thing at the end for it to not derotate. And this is a convex rod. So the convex rod has to be given a little bit excessive lordosis than what you want to create. So that's a little bit more. And this is a cobalt chrome rod. And the concave rod is a little bit more flatter. So convex rod is more curved and the concave rod is a little bit more flatter. So you put that hex here, right? So that it is in the normal sagittal profile. You can see that how it goes into lordosis, right? And then you connect it here and then start pushing the rod down into the tulip. So what will get?
Cantilever.
Correct. So you cantilever it down. As you cantilever it down, the curve will correct. But what is happening in the sagittal plane is the lordosis is also being created because you have put the rod very hyper lordotic. And these are uniplanar screws, right? So you're connecting like that and then going, that's the head end, right? So
This maneuver is called translation, pulling
right?
the screw to the
No,
rod.
I'll show translation. This is cantilever, like I pushed it down and captured everything, right? And then somebody is holding this so that this doesn't rotate out because it is in normal plane, and you lock this lower screw. These are all loose. Up are loose, this is locked. So now your concave rod you take, which is a little bit more flatter. It's not as lordotic because you want to drag this apex out. So that's the translation maneuver. So you put the nut here, put the nut at the end, and then drag this to the rod. So you see what is happening is the spine is derotated. Got that? So you want to pull the apex out. So you drag by rod reducers, or you can put reduction screws and drag them out. Again, cobalt chrome rod. So once you have done that, so now most of the derotation has already happened. Most of the correction has already happened. After this, everything is fine tuning. So how do you do fine tuning? The fine tuning is done with DVR and a little bit of compression distraction. So you start at the lower end, put your towers and connect them cross like that, and then bring them to neutral. So when you rotate, then that gets neutral. Somebody locks them in, and that's your reference. Then you go to the next level up, get that in neutral, then the next level up, then that in neutral, like that. So this is called segmental DVR. So you get so the important thing to remember is when you are putting the concave rod, those tulips were loose. Otherwise, the derotation will not happen. Correct? And then as you go one level higher and higher, that's how the derotation can happen. In the end, to do fine tuning, you can compress and distract the lower levels so that you can get a horizontal LIV. So that you can judge on the X-ray when you get that CSVL drawn. If you feel that there is some tilt left, you can, the lowermost level, you can, compress, distract, try not to distract. If you have to choose, do compression because distraction reduces the lordosis. So try to do that. So this is how you use the rod. You make horizontal, see vertical, and see how the LIV is with respect to the vertical. And that's how you recreate it, right?
Thank you.
So those are the steps.
Thank you so much. I think this video not only showed you how a direct vertebral rotation is done, but also showed you different type of reduction maneuvers, which we are going to be seeing in the next session also. And we are also going to be doing hands-on on the reduction maneuvers in a particular sequence. This sequence may not remain the same in all cases. The sequence will change case to case basis. But the sequence is almost like cantilever, translation, rod rotation, DVR if needed, and last but not the least, compression and distraction, based on how horizontalized the vertebrae you want to do. The next talk is by another international faculty, Professor Chris Chan from Malaysia. Again, he couldn't join us earlier, and he sent his video already to us. This talk highlights about the importance of when we are not able to put in the screw in the derotated, either a apical segment or in the upper thoracic segment, or some or the other way you have burst the pedicle. All these things matter doubly or exponentially important when this is at the end vertebrae, the upper anchors or the lower anchors. It can happen easily. A pedicle can get burst either during early maneuvering or during the reduction maneuver, it can get pulled out, and the salvage does not necessarily mean putting a screw one level up or one level down. You can still salvage the same screw by something called extra pedicular technique of pedicle screw insertion, and that's what we are going to listen from Professor Christian. Again, this is one of the very important talks you may want to carry home from here, because many times this may be the primary way of putting screws rather than a salvage way. So starting with extra pedicular fixation in AIS.
And Dr. Vishal Pudani for the presentation. So the topic of my presentation is on extrapedicular fixation in adolescent liver scoliosis. This is the scope of my presentation. So why do we need extrapedicular screws? We need extrapedicular screws because the incidence of abnormal pedicles in adolescent liver scoliosis is very high. In our study, which was published in 2023, which recruited 6,494 pedicles in 181 AIS patients, we classified the pedicle morphometry into type A pedicles, whereby the cancellous channel is more than 4 millimeters, type B pedicles, where the cancellous channel is between 2 to 4 millimeters, type C pedicles, where the cancellous channel is less than 2 millimeters, or corticalized pedicle more than 4 millimeters, and type D pedicles, where the corticalized pedicles are 4 millimeters or less. Type B, C, D are considered dysplastic pedicles, whereas type C and D are considered neurodysplastic pedicles. From our study, the incidence of dysplastic pedicle is 62%, and neurodysplastic pedicle is about 22%. So the occurrence of dysplastic pedicle is as high as 84%, particularly over the T3, T4, T5 region on the right side, whereas neurodysplastic pedicle is as high as 34% over the same region. In contrast, on the left side, the occurrence of dysplastic pedicles was up to 61%, whereas neurodysplastic pedicle was about 12%, around T6, T7, T8 region. So before we learn the technique of extrapedicular fixation, we must understand the anatomy of the pedicle rib unit, which was well described by Hastert in 2004, whereby he studied 98 patients and 1,916 pedicles. He reported that the pedicle rib unit is wider than the thoracic pedicle width, with a mean of 15 millimeters and all thoracic pedicles were included, and 14.5 millimeters if we consider T4 to T9 pedicles. A similar study was carried out in the Korean population, whereby 6 adult cadavers were studied. The results of these Korean studies were comparable to the results published by us. So how strong are extrapedicular screws? In a study which was published by Bruxelles et al., whereby he studied 11 thoracic vertebral 4 male cadavers, he compared monoaxial 4.5 millimeter screws compared with intrapedicular screws versus extrapedicular screws. He reported extrapedicular screws had a pull-up strength of 80% of intrapedicular screws. However, if used as salvage, the strength reduced to 65%. However, in a meta-analysis and literature review, many authors found there is no significant difference compared with intra and extrapedicular screws. Now I'm going to demonstrate the technique which we use in our center for extrapedicular fixation. So in our technique, compared to the traditional trajectory, we have a more medial extrapedicular entry, and the direction is along the pedicle axis as indicated by the red arrow. So this trajectory is less convergent. It has a shorter cord time. However, it offers the surgeon an easier path of insertion. And in our technique, we routinely use the cannulated screw system for extrapedicular fixation. We have previously published a paper on the advantage of using a cannulated pedicle screw system for extrapedicular screw placement, whereby we can compare these two techniques in 104 AIS patients. So the use of a screw system was found to reduce the overall operation rate from 15.6% in the conventional technique to 4.5% if we use the cannulated system. And the overall anterior operation rate reduced from 8.8% to about 2%, whereas the overall critical progression rate reduced from 6.8% to 2.6%. So for the surgical video demonstration, it will be a case of adult idiopathic scoliosis in a 25-year-old lady. So the extra pedicular screws will be inserted on the right T3 pedicle, which is the type C pedicle as shown on the CT scan. This is the intended trajectory of the extra pedicular screws, which is along the pedicle axis. So the entry point is the conventional entry point for any thoracic pedicle screw insertion. And the entry point is initially projected as shown in the photo. Subsequently, we will enlarge the entry point medially with the carousel roger as indicated by the white triangle. The rationale for enlarging the entry point medially is to enable us to identify the medial wall because the insertion of the screw is guided by the medial wall. So we are using a pedicle probe which we use to actually palpate the closed channel as shown in this video. So the pedicle probe is directed laterally, and this is the movement which we perform to palpate the medial wall, which will lead just to the closed cancellous channel as shown in the video. So after we have identified the closed channel, we will actually tap the pedicle probe laterally up to a depth of 10 to 15 meters before we rotate the probe 180 degrees and then touch the probe at the other point. The position of the probe is then checked using image intensifier, and we will rotate the gantry of the probe 5 to 10 degrees less than the trajectory of the pedicle probe. And this is the image intensified image showing that the tip of the probe is up on the lateral border of the pedicle. Once we achieve this, we will advance the pedicle scope into the vertebral body up to a depth of about 35 to 40 meters. We will then palpate the track to appreciate the transition from the costal vertebral joint to the vertebral body. We will then insert the wire for cannulated pedicle screw insertion. The position of the wire is confirmed again using image intensifier, and the RF position is rotated along the trajectory of the wire to obtain this image to show that the tip of the wire does not reach the medial wall of the pedicle. The cannulated screw is subsequently inserted, and this is a post-operative CT scan showing the position of the extra pedicular fixation using the medial entry point. So what are the pitfalls and complications? Number one, the first mistake which we always perform is that we always aim caudally or have a too inferior entry because of the perception of kyphosis. The inferior part of the costovertebral junction is unprotected laterally. So we must always carousel superiorly and aim the pedicle probe towards the contralateral screw entry point and confirm the position of our probe with image intensifier. Secondly, we must understand the anatomy of the thoracic vertebra, particularly over the proximal thoracic spine, whereas the structure at risk could be the trachea or esophagus. So if we do not aim medial enough and use the screw which is too long, then it could impinge on this structure at the apical main thoracic level, the L5 on the left side. So the solution is to use a line of 25 to 30 mm screw over the proximal thoracic spine if you're using a medial referencing line, and 30 to 35 millimeters over the main thoracic spine, and always confirm whether there's any anterior progression using the oblique views and of course the use of cannula screws. Third is when we encounter a non-favorable medical rate unit as shown on the image on the right side. So the solution is we have a pre-operative CD to study the anatomy, and if you use a cannula screw, it will allow you to check the position of the wire before you insert the screws, and in such cases, we will use the shorter screws. So in conclusion, mastery of extrapedicular thoracic screws is important in AIS because of the high prevalence of dysplastic pedicles. The pedicle rate unit is favorable to accommodate pedicle screws given up to 6.5 millimeters. Biomechanical studies have shown that they have reasonable strength, about 80% of intrapedicular screws. The technique which we propose allows an easier path for entry, but limited by a shorter cord line. And you must understand the pitfalls of extrapedicular screw insertion, and you must be very familiar with the use of cannula system and checking using image intensifier. Thank you very much for your attention.
Any questions so far? So we saw about freehand pedicle screw insertion technique in rotated spine, which is simpler on slides but difficult in actual. Difficult not only because the vertebral body is rotated away from you, but also the rib cage is prominent, and to get that angulation in a concave rotated vertebral body is not easy. And that's why to prevent perforation, which is on the concave side, it is extremely difficult to perforate into the cord, but it is extremely easy on the concave side to perforate into the vessel. To have a lateral perforation, very easy. To avoid that, in a rotated spine on the convex side, the screws actually go away from you rather than convergent. So imagine a vertical body rotated like that, they go away from you. And that is something that this changes from top vertebrae to apex and from apex to LIV, because the vertebral body is neutral above, neutral below, but keeps rotating like this towards the apex and vice versa. So this consideration is extremely important, and by chance, if you get a perforated screw, it is absolutely nothing to worry about. If your neuromonitoring is saying that you have not done any neural damage, there is always a salvage mode. Extra pedicular screw fixation comes extremely handy, and today we have live looking models to put in pedicle screws in the concave side. After this, we will divide into 4 batches, because we have only 4 hands-on tables, 2 for pedicle screw and 2 for reduction maneuvers. The reduction maneuvers, 2 batches, will have a shift over to the pedicle screws. And that is why it is important that the first batch which goes into screw the bones there, they save something for the coming batch. And that is why only from T1 to T6 concave pedicles for batch 1, and batch 2 T6 to T12 concave, so that the next time also we can use the same model there. This model is pretty costly, so I request batch 1, whoever goes on the pedicle screws, T1 to T6 concave side pedicles, and batch 2 T6 to T12, the one that comes later. Before we move on to hands-on table, we need to have 2 more last talks. The most important talk is we heard about planning. Since morning we have been hearing about LIV, radiological evaluation, clinical evaluation, how to determine the LIV, the UIV. We also heard about how to put in screws. But all these maneuvers, despite putting in screws, you have to make sure that before your correction maneuver happens, like Dr. Kshitij shows in a flexible curve, to push cantilever, a rod into screws is easy because it's a flexible spine. But imagine situations which is more often a case that the curve is rigid. It is not a flexible curve. And in a rigid curve, if you do this cantilever maneuver, or you put a persuader and put this and try to push the rod or bring the screw to the rod, the first thing that will happen is the screw will give away. This screw will give away. It will leave the bone. Why? Because screws can only withhold that much amount of force, and that force has to be brought down to bare minimum. This is where precisely the role of release mechanism comes into picture. And releases start with anesthesia. The moment you put the patient prone in anesthesia, partial release has happened because the muscle tension has gone away. Exposure is another form of release. Capsuloryxis, the capsules of each and every joint when you remove, that also releases and makes the spine a little bit flexible.
Partial facetectomies do another aspect of release. Partial interspinous ligament removal is another form of release. Many times this is not enough. And that's where we depend upon various kind of osteotomies, which will help you to make sure that every bone is like a moti in a mala and free to maneuver during your correction maneuvers. And how do we do osteotomies? Which all osteotomies to do, particularly rigid cases? Dr. Bhavu, over to you.
So let's start with the management principles, and I will be quick and I will be covering the basic things. So basically, what is severe and rigid curves? So if there's a less than 30-degree flexibility, and if any major curve is more than 90-degree, we classify it as a severe and the rigid curves. So what are the challenges? Stiff deformity, you need the radical releases, you may need osteotomy of the spine, there is a higher risk of neurological injury, and there are chest-related complications also because you're going to take out a lot of bone and a lot of releases. So chances of causing injury to the pleura and pneumothorax is very, very high in cases of stiff and the rigid spine. So hello gravity traction is number one thing which you can use for especially for the beginners. Hello gravity is very useful, and there are various studies. I'm not going to detail, but they also improve corpse angle. But the important thing is that in my practice, I've seen that they also improve your respiratory capacity. And if there is any pre-existing neurological deficit because of any, the cord kinking or this thing, it improves with hello gravity. So in my practice, I use if there is any respiratory problem or if there is a neurological compromise, I put the patient on hello for at least 3 to 4 weeks so that it improves their respiratory capacity. And if there's a neurological deficit, it improves their neurological the power, and it makes cord less sick to deal with. Anterior surgery, it was a classical, this thing where the people used to do endoscopic or the open releases from the front. But again, there were a lot of complications, and we started as anterior surgeons in my training. But nowadays, we can do everything from the back, so it's not released, not being done anymore. Posterior surgery, basically, these are the steps which we use. We go for pedicular instrumentation, high density pedicular screw we go for. Then second is we also reach the concave rib head resection. So again, this concave rib osteotomies remains a very powerful tool for the severe and rigid scoliosis. Then convex transverse process resection. The moment you take out the convex transverse process, you also release the rib and the TP connection. So it also releases the ribs from the convex side also. And then you move to osteotomies. And there are something called satellite rod constructs, which we are using a lot of these nowadays. And then costoplasty is something which you can do to improve the overall cosmetic, the appearance, especially in rigid scoliosis. So implant density, again, the more screws we put, the more the correction we can get, and there is enough literature into this thing. The ideal one for rigid is more than 1.5. Ideal is around 1.7 screws per level. That means if there are 20 screws, so you have to go at least the 1.7 screws per level. So coming to the concave rib osteotomies, these are again very powerful tool, and this is how we do it. Can we run the video, please? So you can see that I'm just dissecting the with the cautery the concave rib sites at the apex. So this is how I do it. I don't go for the full the exposure. I just try to identify the rib, expose it fully, very carefully with the cautery. And then I just use a sharp nibbler to grasp the rib, and I just break it. You can see that I've taken out the rib from the concave side, and depending upon the number of rib sections required, we usually take out 3 or 4 ribs from the concave side. It actually removes the concave tether from the rigid side. Osteotomies, there were a lot of osteotomies have been described for congenital and this thing. We used to do a lot of the osteotomies for including PVCRs, but nowadays actually we have also given this modified posterior vertebral column dissection. It's same like you can we run the video? There's a small video here. So in PVCR, actually, the first step is laminectomy. That means you take out the laminectomy. But this is our technique. Now, see this is the picture. Okay. So basically, we preserve this posterior column till the end. We have completed the VCR, and this cord is actually, you can see here that it's pulsating. So it remains very healthy because cord keeps on remain hanging from the posterior elements, and it doesn't fall on the vertebral body. So the chances of neurological deficit while you are taking out the vertebral body remains very low. So this is again our data. I'm not going to detail, but we have not seen a single neurological deficit. Once we started doing this modified PVCR. This is HiPod technique. After this thing, we have stopped doing any osteotomy, major osteotomies for adolescent idiopathic scoliosis. So HiPod stands for high density pedicle screws, Ponte's osteotomy, asymmetrical rod contouring, and direct vertical rotation. And this is described by Caldini in AIS. Nowadays, we have also published this thing that this also works for congenital selected cases. This was recently published, I think, 2 months back. Can we run the video now? So this is just to show you that in a rigid scoliosis, how these Ponte's osteotomies, so this is, you can see that I've done the Ponte's osteotomy, and this is how much flexible you have to make, at every level. And this you can check with the help of a laminar spreader that this is moving. This has to move. This is some of the cases. You can see that how much correction we can get. This was again a very severe case, and this was a little bit atypical AIS because you can see that there was a rotation which was actually going to the cervical spine also. So there are hardly any cases in the Lenkage classification also. There is no mention of these cases. And this was the severe rib harm, and this was the X-ray. This looks like syndromic, but we ruled out everything, and this was nothing but the idiopathic curve, and there was 105-degree curve. So again, we have to use these HiPod technique, multiple, the screws, and you can see that I use these laminar screws here to derotate the spine in the cervical spine. So again, this was some of the new technique which I have to use, and we could correct from 105 to 32 degree, and this is from pre-op to post-op. And you can see that I had to put the chest tubes because there were pleural tears when we were taking out the ribs. These are some of the cases, very stiff cases, which we could do with the help of the HiPod technique. Satellite rod construct is something which we are using it. Satellite basically when the rod is not connected to the main construct, we call it a satellite rod. If the rod is connected to the main construct, we call it as accessory rod. So there are two types of extra rods: the satellite rods and the accessory rods. Okay, so this is satellite rod, and these again they have help us in maintaining the good sagittal and coronal balance. So you can see here that this is a satellite construct. So if there is a sharp curve, and if I use the big rod here to correct the deformity, there are chances that there is too much pressure and too much, the forces on that particular area, and this causes the chance of neurological deficit. So I separated this segment. I just distracted it, did some releases here, so that this segment remains fixed now, and there are no major distraction forces across this apex, and then I can rapidly span the rest of the curve. Again, this decreases the chance of neurological deficit. This was another curve, which was a very severe curve. And this girl came us at the age of 10 years, but then she lost the follow-up. And then she came with an angle of around 127 degrees. The more important is that this curve has actually rotated like this. And if you see in the 3D plane, actually this has become an omega. So this was again very severe curve. And when we looked at the CT scan, so this was the actual CT scan cut. Now you can see here that at a single level, this is D4 and this is D6. Now at D4, this is looking like this, and at D6, this is looking at this. So at a very short span of two vertebra, there was a rotation of 180 degrees. So again, correcting them requires a lot of the thinking and the newer techniques you have to think of. And there is no category in Lenke, PUMC, or whatever classification you use for these cases. So again, for these cases, I had to use multiple satellite rod constructs. So the vertebrae which were rotated in the same direction, I derotated them in the same direction with the satellite rods, and then I used these multiple satellite rods, and we could get this much correction. So this is the post-op for the same girl, you can see, and we could get good correction. The another thing is for this thing, for the coronal decompensation, like in this case, you can see that there is a slight coronal decompensation. So we use something called Z-rod. Z-rod is a type of accessory rod. So basically, we connect the lower end of the one rod to the side of the side so that it brings the coronally towards the same side. So it helps us in giving the coronal balance. And this is some of the, again, very atypical idiopathic curves. And we had to use the, the kickstand screw to correct the deformity here. Thank you.
Thank you, Dr. Babu. So, osteotomy. So far, any questions? For the last talk, we come up to it. Morning with clinical evaluation, how to differentiate between a typical AIS versus a atypical AIS. There are clinical features, forget the radiological. Clinical features you can actually make out that are you dealing with a simple idiopathic scoliosis or you're dealing with an atypical curve which does not follow the rules that we have studied today. Radiological evaluation, strategic vertebrae, structurality of the curve, and classifications. They help us to understand, document, communicate, and also to plan the surgery because they also help us to understand the role of CSPL, the structural versus non-structural curve. Then we discussed about the evolution of how the surgery has evolved over ages. Safe spine surgery has become the norm. The goals of surgery are not only to have a balanced and stable spine, but also to have preserved motion segments. We heard about different type of parameters, CSVL, LST, LSTV, rotation, fifth dimension of wedging below the LIV, the rotation of the LIV, which influence your choice of LIV. The shoulder imbalance remains an enigma unless you really plan it well by understanding clinically about which shoulder is high when there is a right-sided curve. If there is the opposite shoulder going high, that means there are innocuous, hidden, though they may be non-structural, but contributory curves which need attention by choosing a UIV to a better level. Professor Kwan did highlight about the UIV tilt angle also and how to ensure that a UIV selection makes sure that shoulder imbalance doesn't happen. All these planning measures, along with the maneuvers we saw in case discussion sessions also, we heard about different type of planning that is required. We heard Dr. Samir Dalvi speaking about the role of anterior surgery. We saw different type of thoracolumbar and lumbar curves which do not follow the principles of LSTV merely. They actually want to centralize the LIV back on the sacrum. And that is what the principle Dr. Kshitij highlighted wonderfully, showing how different reduction maneuvers can come across. Now, all these things, along with the instrumentation that we are going to do hands-on right now in a while, we also heard about extra pedicular screw fixation, how to put pedicle screws in a rotated spine, and of course the osteotomies to make the spine supple before our actual reduction maneuvers can come in. Because your surgery after reduction maneuvers is only closure. It's only putting graft, laying over the graft there in closure. So before the closure comes in, after your screws goes in, how to ensure that the spine now gets reduced, how the spine gets that reduction that we have come here for. Ultimately, we have come here to reduce the deformity. We have come here to make the spine stable and centralized. That depends on this one talk that we are going to, we saw it in previous slides also, but here I'm going to be going down to it about what are the different type of maneuvers. And before any maneuver, like I highlighted, releases make an immense difference to your efficacy of these reduction maneuvers. We all know the goals are very simple. We want a balanced spine, but it has to be safe. You get a good straight spine, patient lands up into neurodeficit, the surgery is failed. A good, nicely chosen UIV, LIV, good correction maneuvers, but patient with neurodeficit has no meaning at all. Right? On one hand, we want a balanced spine, we want a mobile spine left out, we want to preserve motion segments, but we also want that the patient should have a safe surgery at the end of it, and patient should have good functional outcome. And this requires solid anchors. So the prerequisites to do this surgery safely in the effective manner is to have solid anchors. That means your upper 4 screws, lower 4 screws, the hold on the apex, the apical area, the most rotated area, you should have solid anchors.
And while doing this, neuromonitoring should be there. This is something absolute prerequisite. And release before reduce. This is the norm that we always follow. So there are principles laid down. Never aim for total correction. Try to have maximum 65 to 70% of correction, because that is the norm that is established in most literatures, that 65 to 70% correction is safe correction. It is optimal correction. Even if a patient comes with 100-degree curve, aim to give him a residue of 30 to 35 degrees left out. Don't aim to correct it to 10-degree residual curve, because the stretch on the cord will be intolerable. And it is said that the cord can only tolerate 75% of stretch in a deformed spine. And that's why optimal correction should be our goal. And the forces have to be gradual, and use reduction maneuvers in a particular sequence, not necessarily the same sequence what any other surgeon would do. You have to choose and pick and choose and make your own methodology over the years. What you saw Dr. Kshitij showing you was his own technique. What Dr. Bhavuk does is his own technique. He has made his own methodology. He uses cantilever, he uses reduction maneuvers, he uses release maneuvers. But all this sequence he has learned over years, and this skill set we all may acquire, but you can actually devise your own also. Now, what is very important is we heard about traction and bracing. Dr. Arjun highlighted about the role of bracing before doing any surgery to ensure that the deformity is supple. That reduces the stress on the implant, and your implant failure rates go down drastically. Same happens in severe rigid scoliosis. If a patient is more than 90-degree deformity, less than 30% of flexibility, it's a severe rigid scoliosis. Try to make it supple before taking them in for surgery. Not only does the neurological complication rates go down, but also the pulmonary complication rates go down if you release them and make them supple before the surgery comes up. And halopelvic traction, halofemoral traction actually plays the same role there. Now, bracing, we heard about this morning. To be efficacious, it has to be worn at least 16 hours a day, and it has to be a full bracing with pressure points at the deformed side. Traction has its own protocols. It primarily serves one purpose, is to make the deformity supple. It releases that stiff concave tissue structures. And once you're released, even partially it happens, the stress on the implant, the stress on the reduction maneuvers drastically comes down. So it may not necessarily increase your correctability, but it will reduce the risks to achieve the same correctability of a deformity. And that is why some case examples where very, very severe curves put on halopelvic traction had a safe result, though the correction may not be extremely impressive, but 60% correction without any neurodeficit is super correction there. So these are the releases. In normal situation, where it is not a very severe curve, these things will actually do the most of the job, which is positioning under GA makes it 25% release already. Your muscle traction, muscle tone goes down. Soft tissue releases during the exposure part will take away not only the muscle tout to the spinous process and lamina, but also will make it supple that the spine will start falling in place by itself. And then comes the partial facetectomy and the various type of osteotomies Dr. Bhavuk just highlighted. This is something that I want you all to understand, that this release is something that we don't emphasize very often. After proper exposure, make sure that every vertebral body should be seen from the tip of TP on one side to tip of TP on the other side. This is called adequate exposure. If you have not done this, you have not released the muscle tension on the bones, and then the stress on the implant will surely be higher there. We all know that bone to bone linkage is through capsule and joint. So the first thing you burn after this exposure is burn down the capsule. So you denude it, burn down the capsule. And then a partial oblique Roy Camille osteotomy of the facet not only exposes the cartilage, which you can erode to have better fusion, but also these partial osteotomies can actually make the bone a free bone to move, and the implant stress will be very, very less. After this also, sometimes just removing the interspinous connection further releases it. And if coupled with ligamentum flavum release, like on the other side, it will further make it an independent bone unit. If you want to do further release to it, then do a complete facet resection and superior overhang facet resection. So this much portion of bone gone away is called, anyone? Pontes osteotomy. And this usually helps a lot at the apical region. Remember, every osteotomy, be it a small facetal osteotomy or a Pontes osteotomy, not only increases your blood loss, but also enhances the risk of neurological deficit. So do it only when it is genuinely needed, when the curve is not very flexible despite having done all these partial releases there. So this is something that we just spoke this morning. Anterior releases of discectomy particularly comes very handy in patients with very severe rigid kyphoscoliosis, where anteriorly releasing 3 or 4 discs and at the convex side here will result in the mobility of this before you take the patient up and convert prone posterior long segment fixation these patients. So bony releases, we spoke about partial facetectomies and complete bilateral facetectomies, which are asymmetrical, will give you a cord exposure, of course, increasing the chances of blood loss and risk. But this kind of removal of bone contact between the two bones is called Ponte's osteotomy and gives adequate release before your correction maneuver comes in. Very useful, particularly in patients where there is kyphosis already there, because the posterior column shortening will also lead to a correction maneuver and correct the kyphosis also there. So in patients who have sagittally more than 20-degree kyphosis, this comes very, very helpful, particularly in patients which are rigid at the apex. You release them this way, they'll be extremely released very clearly. Bhavuk spoke about pedicle subtraction osteotomy and VCRs. Rib releases. This is called chevron osteotomy, oblique rib osteotomy. Easier said than done, because your osteotomy can actually puncture the pleura there. And that is why do a subperiosteal dissection of the rib completely, put a gauze piece inside and do a oblique osteotomy of the rib. On concave side will make further release easy, and your correction maneuvers will take less stress on the implant, and your correction maneuvers will lead to a better correction there. Once all these releases are done, the curve has become supple. That's when your reduction maneuvers come into picture. Without going into much detail, we are going to be doing the hands-on thing. Cantilever is the first thing, which involves after your screws have gone in, after your releases are done, you anchor the rod, which is a pre-bent rod, because ultimately it depends on the rod. It just means a pre-bent rod going to the screws. This is called cantilever. So you bend the rod properly and make sure that this pre-bent rod, which is hard to bend, we usually do a bending of the concave and convex side in the manner the curve is, not how the curve is looking, but how we want this curve to behave. If we want this curve to become 40-degree kyphosis from T2 to T12, that portion should be 40-degree in kyphosis plane and the lumbar lordosis, and then you engage it, because this ultimately will get rotated to bring the kyphosis to that segment. So this pre-bent rod, getting it to the screws using force rod pushers is called cantilever mechanism. You saw Dr. Kshitij showing you how cantilever can not only lead to engagement of the screws to the rod, but also leads to half the deformity correction already. So by the time your rod has gone on all the screws, your half the deformity is corrected already. And that's when translation, because while doing this, don't try to engage every screw to the rod. Many times the apex may be so deep inside, so you try to get as many anchors the rod will hold on the screws, and let the other screws be aligned or misaligned, which will then, with the help of persuaders are instruments which clamp on the screw and have a space for the rod, and once you reduce it, it will pull the spine up. These kind of instruments, we have them on demo here. Anybody who has not seen these kind of persuaders, will be happy to show you now, and also will send those pictures on the group. Also just send a request around. What this does is it pulls the spine along with the screw to the rod. One is cantilever pushing the rod to the screws, one is pulling the spine to the rod, and this again leads to another 20 to 30% of reduction. These are the kind of instruments called persuaders. And then comes the most important step, rod rotation. You have bent the rod, you have done cantilever and engaged the screws, you have got a translation of bringing the spine to the rod. Now the spine is looking like this. You just hold it and rotate it. This rotation maneuver is what you will be doing today, because we have all those instruments to do a rod rotation maneuver in a controlled manner. The concave side rotation can lead to the convex hump becoming prominent. And that is why a counter hump on the thoracic deformity has to be there when you are rotating this. The other side is double rod rotation maneuver, where you put both the rods, keep the knees loose, and rotate both the rods together with a counter there to prevent the rib hump from becoming prominent when you're doing a concave side rod rotation. So this is something that we have to keep in mind very clearly. And then last but not the least, getting the anchors, particularly in lumbar spine, and then connecting the couple, and then direct vertebral rotation and tightening it on that particular rod, followed by compression and distraction maneuvers. Compression and distraction is usually done from apex upward. Never do a distraction in lumbar spine and avoid compression at the most proximal point to prevent PJK are the simple rules. These can lead to 5 to 8 degrees correction at every segment level. So this is done concave side distract, convex side compress. This is the simple principle. This can further lead to another 10 to 15 degrees of correction getting added after all the other correction maneuvers have come in. This is fine tuning, also used to get the UIV tilt angle parallel. Generally, after a correction maneuver, if this is tilted here and there, you can compress or distract on the other side. There are some basic principles that don't distract at the top and don't distract at the lumbar spine. Otherwise, lumbar spine will go into kyphosis and this will go into proximal gentle kyphosis. So these basic principles come very handy without going into the case examples there. Anyway, so this is the end of the didactic lecture session. And we actually came across almost everything in terms of technique. We heard about technology, intraoperative neuromonitoring. We heard about navigation. O-arm, intraoperative C-arm helps us to determine where the screws are actually lying there. Lilavati Hospital is fortunate enough to have procured not only the O-arm, the navigation, the 3D C-arm, but also the robot, which will help us not only in AIS, but also in MIS cases. And soon we'll be coming up and bringing up to you the results of our early initial series of cases. Neuromonitoring is something that is available freehand everywhere. Medtronic team is there. You can take their cards. If your team, if your relatives, your seniors, somebody is going to be doing deformity, ensure that neuromonitoring is the basic that everybody should use while doing deformity surgery. And I'm sure all the principles that we have discussed are going to come extremely handy when you go and do your first case from here. With this, I would like to thank you all for having patient hearing. It has been a really long day from 9 o'clock to 4:30, and we still have another 45 minutes left out there. Any questions so far? If yes, please. In thoracic spine, concave rod first. In lumbar spine, convex rod first. That is the general thing that we follow, but again, this is not a norm. Japanese have brought out double rod rotation. So whichever rod you place, it's just a placement. The rotation happens both the rods simultaneously. The rod rotation has its own sequencing. If you rotate the concave rod without having control of the convex side, the hump will become prominent. So the curve will get corrected. Would you follow this?
No, the same thing, but there is some corrective side and the neutralizing side. In thoracic spine, the concave side is the correction side. In lumbar spine, convex is the correction side. But what happens if you place it on the same rod first? As Dr. Vishal was saying, you will increase the reform. So what I do usually is I place the convex rod first and then the concave rod, correct from the concave side. But then placement of the convex rod first and hold it so that the reform doesn't move. So that way your rod rotation manual will become more harmless. Otherwise, it's a harmful technique. When you rod rotate, you increase the reform, and in AIS you are mainly doing it for cosmesis. And you increase the reform, and then the cosmesis goes away. So place your convex rod first, and then place your concave rod, and then rod rotate. So that way you will be able to reduce the increase in reform.
Okay, now guys, we'll just divide ourselves into 4 equal batches, and then we'll have a ring to shift over with. There are only 2 workstations to do hands-on. One is pedicle screw insertion on the concave side between T1 to T6, and then reduction maneuvers in the sequencing. Every table has a faculty member. All these questions you can build them. They are there to not only give you a demo, but allow you to do hands-on. What's your birth date? 29. 29 makes 2 plus 9, 11. 11 makes it 1 plus 1 is 22. So the digit is 2. A person born on 29, the digit is 2. Anyone who's got digit 1 or 2 in their date of birth, please stand up. Rise up. Anyone who's got date of birth 1 or 2. Thank you so much, gentlemen, for rising up. Why don't you guys take this side of the hall, go to the pedicle screw insertion technique. Anyone who's got digit 3 and 4 in their date of birth, please rise up.
Can you go to the reduction maneuvering on this side of the house? Anyone who's got 6, 7, or 8 in their digital date of birth, please go to the third table there. And if this sequence is crowding, please make yourself comfortable on one of the uncrowded tables. We have max 45 minutes. At 5:10, we will want to have feedback from you and close the session. And tea and coffee and some vada pav is started. You guys can catch up on your tea and vada pav already. Like that.
Recording stopped. Recording in progress. Recording stopped.